Good morning, everyone. Is my slides visible? I'm not to move the slides. A minute. Just a minute. Okay. Good morning, everyone. I'm Dr. Pankaj Singh from Max Hospital, Delhi. My topic of presentation is safety and efficacy of percutaneous endoscopic necrosectomy as a step of minimally invasive treatment for infective pancreatic necrosis. So what is known about this topic so far is that patients with severe acute necrotizing pancreatitis with infected necrosis, these are the candidates who are initially managed with conservative treatment. But once we see that patient are not responding to conservative treatment, ideally what is done is that they require surgical necrosectomy. So the key message that we intend to convey from this is that endoscopic percutaneous necrosectomy can be an effective intermediate salvage procedure prior to surgical necrosectomy. So the aim of the study was to evaluate the outcome of percutaneous endoscopic necrosectomy for laterally placed wall of necrosis post-acute pancreatitis, which are inaccessible to transluminal endoscopic drainage. It was a retrospective evaluation of 110 consecutive patients with acute pancreatitis from February 2021 to June 2022. 30 patients with acute necrotizing pancreatitis were selected for the study, out of which 5 patients had no collection, so they were excluded. And a total of 25 patients with acute necrotic collection or bald of necrosis with or without infected necrosis were assessed finally. Of them, 20% underwent endoscopic necrosectomy. Of these 20, 7% had percutaneous endoscopic necrosectomy, that is by the percutaneous route, and 10% was done by transluminal endoscopic necrosectomy. This is the chart which shows that total of 110%, 11 of them, they were in the stage of acute necrotic collection when the wall was not formed. Out of these, 9 had infected necrosis, and most of these patients were managed only with the help of percutaneous drainage. And vis-a-vis on the other side, those with wall of necrosis, there were 14 such patients, and out of them 18 had infected necrosis, and most of these patients required endoscopic necrosectomy either in the form of percutaneous or endoscopic. The technique was in case patients with percutaneous endoscopic necrosectomy, this was chosen for those patients who are not accessible to endoscopic drainage, and the route was through the percutaneous. The route was through the percutaneous sinus tract, which was by the previously placed PCD drainage. We used the standard adult endoscope with water irrigation system. Sedation was either complete or even in conscious sedation, they were done. The necrosectomy was performed with the help of snare or Roth net basket. Cavity was lavaged with sterile NS, and then drain were updated up to 32 French. Procedure was repeated every 2 to 4 days till the sepsis was controlled and the cavity was cleared. Tubes were regularly flushed till clear or serous liquids comes out of the drain. Tubes were kept in place till the drain output decreases to less than 10 ml per day, and the CT documented confirms the resolution of the collection. Those with disconnected pancreatic duct were later managed by a special technique of tractogastroscopy. Outcome measures were primary endpoint was control of sepsis, resolution of necrosis, removal of drain. Secondary endpoint was mortality, peri-procedural complication over all length in ICU and hospital stay. This was the journey throughout the management. We can see in the first slide, this is the extensive peripancreatic necrosis where we put the PCD drainage, and these are the metal stand that we place endoscopically. This is the percutaneous route where we have inserted the scope percutaneously using the PCD drains tract. And this is the necrosome we can see inside, and these are the removed necrosome. Necrotic tissues removed from the cavity, and finally we can see the cavity cleared of the necrosis. So the results, total of 25% of them, most common etiology was either idiopathic followed by alcohol. 28% of the patient had severe disease, most were moderate disease. Organ failure was seen in 56% of the patient. Acute necrotic collection was seen in 44%, wall of necrosis in 56%. In hospital mortality was only 2. That means out of 25% that we managed, only 2 patients had in hospital mortality. 23 patients can be easily salvaged without the need of surgery. Baseline characteristic of the necrotic collection, maximum size was 2 centimeter, cross-sectional. 50% necrosis was seen in 52% of this patient. CTCI score was a median of 8. Infected pancreatic necrosis was seen in 76% of these cases. Of them, 56% had necrosis that is around the stomach, and 26% was peripheral. The problem was can be easily managed with endoscopic technique. but peripheral necrosis, it is difficult to manage with the help of endoscopic technique. So we use the percutaneous route to access this necrotic cavity and get the necrosectomy done. The interventions done in two categories: acute necrotic collection. Most patients will manage with PCD only, but in those with walled-off necrosis, we required endoscopic necrosectomy in the form of either percutaneous endoscopic necrosectomy or direct endoscopic necrosectomy using the transluminal endoscopic approach. Surgery was VAD, video assisted retroperitoneal debridement was done in only one patient. No open surgical necrosectomy was done. When you compare the results of percutaneous endoscopic necrosectomy with the direct endoscopic necrosectomy using the transluminal route, we see that walled-off necrosis was mostly in patients with DAN. 80% cases with acute necrotic collection. Acute necrotic collection means these are the necrotic collection which do not have a well-formed wall. So this is a state where endoscopic technique is difficult to do, but these patients with sepsis or uncontrolled sepsis, worsening clinical scenario, even these patients we manage with percutaneous endoscopic necrosectomy. The maximum size of the cavity was 15 centimeter vis-a-vis 12 centimeter in direct endoscopic route. Median necrosectomy session was 5 versus 2 in DAN category. Median procedure time was 15 minutes in PAN and 35 minutes in DAN. Median hospital stay was 53 days in PAN and 25 days in DAN. Necrosis completion was complete in 77% in percutaneous route and 92% in the direct endoscopic route. Complications were seen, but bleeding was the most common complication in 30% of patients with percutaneous endoscopic necrosectomy, whereas bleeding was seen in only 15% in direct endoscopic route. Post necrosectomy sepsis was seen in 20% in PAN category and none in DAN. Colonic fistula was seen in 1. In each group, pancreatic fistula was seen in 2 in percutaneous route. And to conclude, percutaneous endoscopic necrosectomy is a safe and effective, minimally invasive step of treatment approach for infected necrosis, refractory to standard conservative treatment and inaccessible to the standard transluminal endoscopic drainage. Thank you.
In progress. Nice presentation, Dr. Pankaj Singh.
Yes,
I would like to introduce our judges, Professor Haider Abbas from King George Lucknow Medical College.
Yes,
and thank you so much.
Yes.
We move forward for our next presentation. Multiple sclerosis, a difficult diagnosis, a case report, gastroenteritis-induced acute kidney injury by Dr. Mayank Butola. Next presenter, Dr. Mayank Butola. Are you there? Dr. Mayank?
Ma'am, we join in 2 minutes.
Okay. Good morning, Dr. Sandeep, sir.
Good morning.
Good morning, sir. So, sir, you are accompanied by Dr. Haider. You both judges for the session.
Okay.
Thank you, sir. Hello. Ma'am, how much time will it take? Ma'am, if Dr. Mayank is not online, we can move on to the next speaker.
Okay.
Dr. Supriya, a case series on requirement of hemodialysis in patients.
Hello, am I audible, ma'am?
Dr. Supriya?
Yes, ma'am. Am I audible?
Yeah, you're audible. You can present your case.
All right. Is my screen visible?
Yes.
Good morning, judges. Yeah. So coming to the study, it was a case series on the requirement of hemodialysis in patients with acute gastroenteritis-induced acute kidney injury. So this study was conducted in Sri Ramachandra Medical College in the year 2020-2021. It was a 6-month study and it was published in PubMed in June 2021. So moving on to the study, according to the Kidney Disease Improving Global Outcomes Review, delayed renal replacement therapy was associated with increased mortality, longer duration of hospital stay, and dependence on RRT. 3 out of our 6 cases did not require HD, and acute kidney injury resolved on conservative management alone, probably because of prompt initiation of fluids and electrolyte management. 3 out of the 6 cases had non-resolving AKI and were dependent on RRT even after 1 month after discharge, as they remained oliguric. And there was one recent paper that supported our diagnosis. The objective of the study was to determine the incidence of acute kidney injury in infectious and non-infectious diarrheal illnesses requiring hospitalization and to identify the correlates and outcomes. None of the patients had any organism isolated in stool, probably due to prompt initiation of antibiotics or inadequate culture growth. So coming to the methods and results, once the diagnosis of AKI is made, either using the rifle or the KDIGO criteria, the underlying etiology was determined by combining history, examination, and investigations of the 5 R's that we used: risk assessment, recognition, response, renal support, and rehabilitation, coincided with various points in contact with the healthcare system. The cases were also followed up telephonically after 1 month post-discharge to assess the recovery from AKI. It was seen that 3 out of our 6 cases were requiring maintenance HD even at 1 month post-follow-up. So a holistic perspective by the physician by treating the comorbid conditions may not only halt the progression of chronic kidney disease in such patients, but will also improve their quality of life. And acute kidney injury being the most common entity, it's one of the preventable and treatable causes, especially in developing countries like India. Awareness of such potential renal complications and their prevention and early hospitalization is one of the single most cost-effective life-saving measure. Our study basically was in concordance with the largest multi-center trial of AKI, which was the START AKI trial. So this was a multi-continental assay wherein more than 3,000 patients were enrolled, and they had to basically determine the timing of initiation of renal replacement therapy in patients with acute kidney injury in the critically ill patients, ICU patients. So the same study, we did it as a case series in our setup, and this was the results of the study. Thank you. Yes, madam.
Dr. Supriya, thank you for a wonderful presentation.
Okay, madam. Thank you.
We'll move to our next speaker. Is Dr. Mayank here? Dr. Mayank Butola? So, Dr. Supriya, you can present your second presentation, incidence of multiple pan-drug resistant organisms in an apparently healthy inpatient.
Yes, madam. Thank you. So, coming to my next paper presentation, incidence of multiple pan-drug resistant organisms and their adverse effects in previously healthy ICU patients. So, coming to the background and a small history taking. Antibiotic resistant infections are a substantial economic burden to the healthcare system as well as to the patients and their families. They commonly occur in hospital intensive care units due to the clustering of highly vulnerable patients, either because of prolonged ventilation or surgical site drains, use of invasive procedures, and high rates of antibiotic use. Even when effective treatments exist, data show that in most cases, patients with resistant infections require significantly longer hospital stays. So the morbidity is longer, healthier recuperation time, and experience a higher incidence of long-term disability. So here we had a 56-year-old male patient who walked into my OPD looking all healthy and got hospitalized for evaluation and treatment of hyperbilirubinemia. So it was just for the yellowish discoloration of the sclera. ERCP revealed a lower CBD stricture with biopsy ruling out malignancy. A percutaneous transhepatic biliary drainage was done with stenting on day 3 of admission itself. So once he was admitted in the immediate post-op period to the ICU for the recovery period, 2 consecutive blood cultures on day 3 and day 7 grew pan-drug resistant Enterobacteria cloacae and Klebsiella pneumoniae. However, in view of non-resolving septic shock, patient succumbed on day 12. What was unique about our case was that we just had a healthy looking walk-in patient with no known comorbidities, no habits, not an alcoholic at all, with likely biliary source of sepsis, carrying 2 pan-drug resistant organisms. Hence, it was a challenge for us treating him. And although antibiotic sensitivity pattern revealed a PDR pattern, the decision to use a lower spectrum antibiotic like cefoperazone sulbactam helped overcome the toxicity of high spectrum antibiotics, reduce the requirement for HD, reduce the total counts and procal levels, reduced inotropic support, and he basically came out of the shock earlier than we expected him to. But however, we lost him because he had to go into a ventilator support and he developed a hospital-acquired pneumonia. But this raises a debatable question as to whether treat the patient clinically or as per the reports. That's usually the dilemma that exists amongst physicians and intensivists. To talk about the gram-negative pathogens, predominantly the tricky ones like Pseudomonas, Citrobacter, Acinetobacter, the ESBL organisms, and carbapenem-resistant Enterobacters, they are particularly worrisome because they become resistant to nearly all the antibiotic options available, creating situations reminiscent of the pre-diabetic, pre-antibiotic era. It is preferable to be careful while selecting antibiotics in ICU while trying to cautiously determine whether the patient is having just a colonization or an active infection or sepsis. So in case of a colonizing infection, patient will be apparently healthy looking, but will grow multiple bacteria in cultures, but they're all insignificant growth. So it is very important to treat the patient clinically and not go as per the reports. So this is just one such example. Also to adapt a treatment model that would enable substantially smaller, less expensive and faster clinical trials. Thank you, sir.
Thank you, Dr. Supriya.
Thank you.
We move to our next speaker, Dr. Akash Goel.
Hello, good morning, ma'am.
Good morning, Dr. Akash.
Ma'am, I'm not able to start my video. It is showing that the host has stopped it.
Ma'am, Mayank is here. So
Mayank is here. Okay, Dr. Akash, please could you wait? We will take your presentation after Dr. Mayank Butola.
Sure, ma'am.
Okay, thank you. मैम ये जो लैपटॉप है
Dr. Mayank, please.
Morning, respected ma'am, presenting a case report of multiple sclerosis. Can you hear me, ma'am?
Yes, you're audible.
Yes, ma'am. Presenting a case report on multiple sclerosis. We received a patient. First of all, multiple sclerosis is an autoimmune illness of the central nervous system characterized by chronic inflammation and demyelination, gliosis, and eventually neuronal loss. It typically develops at different times in different central nervous system location, and establishing a diagnosis is a challenge due to variable and complex nature of the disease. The debilitating symptoms can considerably affect the patient's ability to perform their normal routine. We're presenting a case report of a young male of 35-year-old age, who presented with the chief complaints of weakness of left side of body for 1.5 years, severe headache for 1 month, slurring of speech for 2 weeks, and urinary incontinence for 2 weeks. Now, according to HOPI, the patient presented with complaints of weakness of the left side of the body for 1.5 years, which exacerbated over the past 3 months. He primarily complained of weakness, which was gradually progressive, first involving the left lower limb, eventually progressing to upper limb and right side of slight involvement of the right side of the body as well. There were no mentioned aggravating or relieving factors, and patient was unable to sit or stand without support and had difficulty dressing himself. Secondly, he had a severe headache for 1 month, which was throbbing in nature, localized to the bilateral temporal areas without any aggravating or relieving factors, and usually persisted for 1 to 2 hours, resolved after on its own, and did not resolve by medication. He also complained of slurring of speech for 2 weeks and urinary incontinence for 2 weeks, whereas the patient sometimes passed urine on the way to the washroom, but he does not mention any dysuria or burning micturition. And lastly, he also gave a history of emotional outbursts, but there was no history of fever, sleep disturbance, dizziness, or abnormal limb movement or incoherent conversations. In the past history, we found that the patient was first admitted in SGPGI Lucknow for lower back pain and left-sided hemiparesis, where he was diagnosed as a case of query CNS vasculitis with L5S1 radiculopathy and was started on oral steroids and antiplatelet drugs. After which, despite treatment, his symptoms did not improve, and later on getting an MRI, patient was started on anti-tubercular treatment from 13th of Feb 2020, continued till the day we received the patient in 2021. Despite the treatment, patient did not get any relief, and after SGPGI, he was also admitted in between in SMS Jaipur with complaints of severe headache and left-sided hemiparesis, where a differential diagnosis of mitochondrial disease versus query CNS vasculitis was made. Patient did not improve, and lastly, he was received in our college, FH Medical College, at Agra. In the personal and family history, the patient was a teacher by occupation before onset of symptoms, residing in Kasgan district of Uttar Pradesh. He was a non-vegetarian by diet and Muslim by religion. There was no history of tobacco of consumption of any form, or alcohol consumption, or any drug abuse. In the family history, we found that his maternal uncle had a similar illness, but is now deceased, but no documentation was available for the illness. His mother had pot spine, for which he received full treatment, but was now deceased. And wife had developed tubercular meningitis 1.5 years ago, who was treated for a full course of 1 year and was now asymptomatic. Father had an impaired glucose tolerance but had no similar illnesses or any other comorbidities. On general examination, all vitals were stable. The build was average. Pulse was 88 per minute with normal rhythm, normal volume, no specific character. Other vitals were also stable. On examination, a detailed neurological examination was done where the patient was conscious, oriented to time-place person, and cooperative with an MMSE score of 21/30. Speech dysarthria was present to some extent, and tests to assess memory and calculation were performed properly by the patient. Ophthalmic, in cranial nerve examination, only the ophthalmic examination revealed some findings where there was a reduced visual acuity and poor in both eyes and poor color perception in the left eye, but there was no evidence of any optic atrophy on fundoscopy. And other cranial examinations revealed no abnormalities. Main findings of our patients were in the motor examination, where the muscle bulk was normal. The tone was spastic in all four limbs with presence of bilateral patellar and ankle clonus. Patient was unable to stand or walk without support and had an ataxic gait when walking with support. Patient was unable to perform coordinated or complex limb movements due to weakness. Heel shin test, motor luriative, finger nose test were performed, but were to some extent with the left side of the left limbs. Power was 4+/5 in the right upper limb, 4/5 in the lower limb, right lower limb, 4/5 in the left upper limb, and 3/5 in the left lower limb. All deep tendon reflexes were exaggerated, and in superficial reflexes, the cremasteric and abdominal reflex were present, but the plantar reflex were bilaterally not elicited. This is a tabular formation of the reflexes elicited. Power, as I mentioned earlier. Sensory examination, patient revealed a loss of fine touch and vibration sense in bilateral lower limb till knee.
Dr. Mayank, could you please wind up early?
Yes, ma'am. We found bilateral discrete white matter changes in the patient over the course of from the 2001st diagnosis 2019 to 2021, which are shown. This is the latest images that we received in 2021. We conducted other investigations for white matter diseases like E-cadherin, NOS3 gene for cadherin, ADA, ESR, CRP, anti-DS DNA, all were negative. And a final diagnosis of primary progressive multiple sclerosis was reached on the basis of clinical and investigative findings. Now, this patient initially presented with back pain and sudden onset limb weakness, was referred to the neurologist in the first few months. Multiple sclerosis, as we know, is a disease which is spread throughout time and space, and the progressive nature of the disease should direct us towards the differential diagnosis of multiple sclerosis. In our patient, the patient presented with upper motor neuron type of asymmetrical progressive muscle weakness with associated pyramidal features of spasticity and hyperreflexia, and decreased visual acuity and urinary incontinence with speech dysarthria. Secondarily, we found that the patient improved on administration of steroids, signifying that it was an acquired cause of neurological disorder. Thus, in a patient with such symptoms, serial brain imaging should be done, and a close follow-up should be done of the patient to identify multiple diseases like multiple sclerosis early, because initiation of immunosuppressive therapy has been known to delay relapses and improving the quality of life of the patient. Thank you.
Yes, Dr. Mayank. So, what's the unique thing coming out of your case report among your conclusions?
Sir, according to us, the patient first of all presented with low back pain, which is a common presenting feature of multiple sclerosis, and it continued to deteriorate despite all treatment. First of all, CNS vasculitis in our country, we attributed to most primarily due to tuberculosis because of high prevalence. But if the patient is not improving despite all therapies, we should consider other areas of the medicine, and a differential diagnosis of multiple sclerosis and adult onset diseases like white matter diseases like adult onset leukodystrophy should be considered and should be thoroughly investigated. If the patient had received treatment earlier, the treatment for multiple sclerosis is primarily immunosuppressive therapy with azathioprine, cyclosporine, and interferon beta. But if the patient had received such treatment earlier, maybe his relapses would have been delayed and patient would have lived longer. He was a young patient. He should have received immunosuppressive therapy earlier.
Okay, thank you.
Thank you, Dr. Mayank. Moving to our next speaker, Dr. Akash Goel, empagliflozin beyond glycemic effects, dissecting guidelines.
Morning, ma'am. I'm not able to start my video. It is showing that the host has stopped it. Can you enable it?
Just wait, Dr. Akash. Your screen is visible. You may start your presentation.
Okay, ma'am. Good morning, everyone. Today, we would be discussing about empagliflozin beyond just glycemic effect, and why does empagliflozin form such an important part in the guidelines of diabetes management today. Diabetes mellitus refers to a group of metabolic disorders that share the phenotype of hyperglycemia. An associated increase in mortality from many other diseases like cardiovascular disease and cerebrovascular disease is noted. EMPA-REG outcome, which was a multicentric outcome, showed that there was a 32% relative risk reduction in death due to any cause in patients treated with empagliflozin. Hence, today we need anti-diabetic medications whose effects go beyond the glycemic control in diabetic patients, and hence we are focused on extra glycemic effects of anti-diabetic drugs. One such drug is SGLT2 inhibitor, which reduce hyperglycemia in type 2 diabetes mellitus by reducing renal glucose absorption. It mainly acts on S1 part of proximal tubules. We conducted a study at Jaslok Hospital, Mumbai, to study the effect of SGLT2 inhibitors on various clinical and biochemical parameters in uncontrolled diabetic patients. The objectives of this study were to assess the impact of empagliflozin on HbA1c, weight reduction, lipid profile, systolic and diastolic blood pressure, and creatinine clearance. A brief review of literature based on the international randomized controlled trials. It shows that empagliflozin has significant positive outcomes on blood pressure reduction, body weight reduction, lipid profile. The recent EMPEROR reduced trial has shown that it has a significant positive impact on heart failure with reduced ejection fraction. There is significant reduced incidence of hypoglycemia. It is one of the first drugs that has been approved for heart failure with preserved ejection fraction. There is uric acid reduction. However, there is a slight increase in ketogenesis. Also, the hematocrit increases in patient due to diuresis. There is liver steatosis amelioration that is seen. Also, there is a reduction in left ventricular mass that was seen in EMPA heart study. There is also endothelial dysfunction amelioration. This is a brief of the mechanism of SGLT2 inhibitors. So we conducted a single center prospective observation follow-up study at Jaslok Hospital, Mumbai, where 140 patients were enrolled at baseline and were followed for 6-month duration to assess the effect of introducing empagliflozin on various clinical and metabolic parameters in uncontrolled diabetic patients. The inclusion criteria and exclusion criteria were like this. The inclusion criteria included the ADA criteria for diagnosis of diabetes and that the oral anti-hyperglycemic agents have not been changed in past 12 weeks. The results were like this. Maximum number of diabetic patients belong to the age group of 66 to 75 years, that is 32.1%. The mean age of study population was found to be 61.54. 92 patients were male and 48 patients were female. Based on the duration of diabetes, maximum number of patients have diabetes from 10 to 20 years, that is 34 patients. 64 patients were found to have diabetes for a duration of more than 10 years. These demographics were in concordance with the demographics of a larger multicentric trial, that is the EMPA-REG trial. The other results were like this. There was a statistically significant improvement BMI, LDL cholesterol, HDL cholesterol, serum creatinine, HbA1c, systolic blood pressure, and diastolic blood pressure. The effects of empagliflozin on HbA1c. The mean reduction in HbA1c over a period of 6 months was found to be 1.29 plus minus 0.77%. It was observed that more be the initial HbA1c, more was the reduction in HbA1c over a period of 6 months. This table shows the same, and same has been depicted in this graph, that if the initial HbA1c was between 12 to 15, the reduction in HbA1c can be as high as 4.4%. These results were comparable in males and females and were statistically significant. Effect of empagliflozin on BMI. There was a significant reduction in BMI and body weight was observed over a period of 6 months. The mean reduction in weight over a period of 6 months was found to be 4.02 plus minus 0.22 kg. It was observed that more be the initial weight, more is the reduction in weight after treatment. The same has been depicted in this table and same has been depicted in this chart, that as the BMI category increases from normal to overweight to obese class 1, there was more reduction in weight as that is seen. In obese class 2 and obese class 3, although there was a significant reduction in weight, but not much seen, but it can be because of the lower sample size in these categories. Then our study, the systolic blood pressure, diastolic blood pressure, there was a significant reduction in systolic and diastolic blood pressures. And the effect of lipid profile, the mean total cholesterol at the time of enrollment was found to be 184 plus minus 54.16 milligram per deciliter. And the mean total cholesterol at the time of follow-up was found to be 180 plus minus 53.4 milligram per deciliter. The mean LDL cholesterol at time of enrollment was 107 plus minus 36.9, and the mean LDL cholesterol at time of follow-up was 102 plus minus 36.6. The results were again statistically significant. Empagliflozin and renal outcomes. In our follow-up study at 6 months, it was observed that the time of enrollment, baseline creatinine was 0.86 plus minus 0.235. And after receiving empagliflozin for 6 months, the mean creatinine was found to be 0.82 plus minus 0.22. The results were found to be statistically significant with a p-value of less than 0.001. So in conclusion, the clinical prospective follow-up study conducted at Jaslok Hospital and Research Center, Mumbai, shows that the empagliflozin, a SGLT2 inhibitor, helps in improving not only blood sugar control in diabetics, but also has a significant positive outcome in various clinical, biochemical, metabolic parameters, and can thus help in reducing the mortality due to various cardiovascular, cerebral, and renal comorbidities. Thank you.
Yes, Dr. Akash. So the mean age of the patient was 61 plus, no?
Sorry, sir, the mean age was 61.54 and the median was
61.5. So what do you think that if you recruit patients for younger age groups and it should be multi-center study? Because the other extra glycemic, metabolic and vascular changes are already set in.
So it can be possible. Hence, we always recommend that a multicentric study would be better to confirm the diagnosis. But because our results are in concordance with the previous multicentric study, that was EMPA-REG study, hence we can conclude our results.
Okay, and what about the better it will be to recruit patient of a younger age group?
Sorry, sir.
To recruit patient of a younger age group, like 51 something.
Yes, sir. We have started. We have recruited the patients between the age from 30 years onward, 30 years and above. But the incidence was lower in the younger age group, and more maximum patients are above of that of 55 years age group.
Okay. So, Dr. Sandeep, do you want to ask something?
There is no control group I see in this. That is any group without empagliflozin.
No, sir. There was no control group.
So
it was.
How can we be confident that whatever the changes, improvement are there are because of empagliflozin and not by a chance?
Sir, because we have included the patients whose anti-glycemic drugs and other metabolic parameters are more or less constant over the last 12 weeks, and we then see the result after introduction of empagliflozin. Also, the results are in concordance with other studies that have been conducted till date, and hence we concluded the results.
In any study, there is always a element of question that whatever the improvement is being given by a drug could always be by a chance. So we keep a control group where we don't give that drug. That is a control group without that drug. So yes, that gives us a baseline that there is whatever the changes is coming in the study group is not by chance. So yes, the weakness over here is somewhat like this, that there can always be argument that even if we had not given empagliflozin, those same diabetic drug would have been causing an improvement in the lifestyle, would have been causing the changes, whatever the changes are being shown in the weight and etc. etc. So yes, there is always a question on the research design over there. Otherwise, all is well.
Okay. Thank you, sir.
Okay, thank you, Dr. Akash Goyal.
Thank you.
We move to our next speaker, Dr. Prayas Kumar Raghuvanshi. Correlation between fibroblast growth factor 23 and left ventricular mass index in pre-dialysis chronic kidney disease patients. Dr. Prayas?
Yes, good. Can you hear me, ma'am?
Yes, you're audible.
Good morning to all respected seniors. I am Dr. Prayas Kumar Raghuvanshi from Vardhman Mahabir Medical College and Safdarjung Hospital, New Delhi. My topic for today's presentation is correlation between fibroblast growth factor 23 and left ventricular mass index in pre-dialysis CKD patients. As we all know, CKD is a growing public health epidemic and is associated with markedly increased risk of cardiovascular disease and mortality. While there are various traditional risk factors in the CKD patient like atherosclerosis, LVH, such as hypertension and diabetes. But these classical risk factors do not. Hello. 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 Can you hear me?
Audible.
Okay. So why there are various traditional risk factors? Hello. Good morning to all respected seniors. I am Dr. Prayas Kumar Raghuvanshi from Department of General Medicine, VMMC and Safdarjung Hospital, New Delhi. My topic for today's presentation is correlation between fibroblast growth factor 23 and left ventricular mass index in the pre-dialysis CKD patients. As we all know, CKD is growing public health epidemic and is associated with markedly increased risk of cardiovascular disease and mortality. While there are various traditional risk factors like hypertension, diabetes that are prevalent in the CKD population, but these factors do not fully account for the burden of cardiovascular disease in these patients. Left ventricular hypertrophy and diffuse arterial calcification are common manifestation in the cardiovascular diseases and are powerful independent risk factor for mortality in these CKD patients. Approximately 40% of the pre-dialysis CKD and 80% of the dialysis CKD patient have left ventricular hypertrophy. There's a disordered phosphorus metabolism in the patient of CKD, and they are novel risk factor for cardiovascular disease. However, overt hyperphosphatemia is uncommon outside dialysis, and it's seen mainly in the class 5 of CKD. But FGF23 has recently discovered hormone that helps maintain normal serum phosphate concentration in patient with kidney by stimulating urinary phosphate excretion and decreasing the phosphorus absorption. Importantly, the level of FGF23 start increasing early in the course of the disease, long before the increase in the level of phosphate. Furthermore, the level of FGF23 increases early, and they are more sensitive biomarkers of disordered phosphorus metabolism than the concomitant serum phosphate levels. It has also been observed in the animal models that FGF23 has been shown to non-selectively activate fibroblast growth factors implicated in the development of cardiac hypertrophy and atherosclerosis, suggesting a biological basis for an association between increased FGF23 and the left ventricular hypertrophy in the CKD patients. Several studies have reported that FGF23 is associated with LVMI in asymptomatic patients with CKD. The aim of this study was to correlate the level of FGF23 as a marker of left ventricular hypertrophy in the patient of pre-dialysis CKD. In this study, we measured the FGF23 levels of the patient, and we measured the LVMI of the patients, and we correlated these two values. The study was conducted in the Department of General Medicine in VMMC and Safdarjung Hospital, New Delhi. It was a cross-sectional observational study which was conducted over a duration of 18 months, and the sample size was 110 patients. All adults of more than 18 years with clinical or radiological evidence of CKD were involved. The following are the results of my study. The mean age of the population was 43 years with a median of 45, and the range was 19 to 69 years. The mean hemoglobin level of these patients was 9.38 gram per DL. The mean FGF23 level was 308 plus minus 111 RU per ml. The mean creatinine level was 3.5 plus minus 1.74 milligram per DL, and mean EGFR was 23. The mean LVMI, left ventricular mass index, was 103.5 plus minus 23 to 3.74 gram per meter square. So this is the correlation that was found between left ventricular mass index and fibroblast growth factors. There was significant positive correlation that was present between these two factors, and with a correlation coefficient of 0.914 and with p-value of less than 0.1. This is a graph depicting the same. So there was a significant correlation was seen between FGF23 level with left ventricular mass index. Discussion. In this study, we compared the level of FGF23 with LBMI. Now, whether chronically elevated FGF23 concentration may also directly promote myocardial hypertrophy in patients with CKD is an intriguing possibility, and further studies can be conducted in this direction. FGF23 is a hormone. It is secreted by osteoblasts and osteocytes that act primarily in the PCT and help in the urinary excretion of phosphorus and decrease the absorption of phosphorus. In the patient with CKD, FGF23 concentration are constitutively elevated and increase progressively as kidney function worsens, likely an appropriate compensation to maintain the normal phosphate concentration. By the time patient reach end-stage renal disease, FGF23 concentration are often 100 to 1000-fold above the normal level, whereas serum phosphate concentration are only modestly increased. Indeed, the serum phosphate level remains within the normal limit until the later stage of the disease. Although the increased FGF23 concentration in the advancing CKD appear to be an appropriate compensation to prevent hyperphosphatemia, in long-term increased FGF23 may have adverse end organ damage, like this study we have seen that it can lead to left ventricular hypertrophy. So the result of present study provide further evidence that markedly elevated FGF23 concentration may be toxic in CKD patient. Further, because LVH is a potent risk factor for cardiovascular mortality in CKD patient, these results suggest a possible mechanism to explain the link between FGF23 and mortality. There also has been animal studies in which FGF2 receptors are present in the when the receptors were absent in the mice. There was no significant hypertrophy was seen in those mice. So thus, it is an intriguing to speculate whether chronic exposure to elevated FGF23 concentration CKD may similarly accelerate myocardial hypertrophy and fibrosis, which characterize uremic cardiomyopathy. For example, as the markedly elevated circulating concentration seen in the patient with CKD, FGF23 may non-selectively bind to FGF receptor that are normally activated by local factors such as FGF2. Given that FGF23 concentration can be lowered in patients with kidney disease with a routine clinical intervention that limit dietary phosphorus absorption, whether treatment of elevated FGF23 concentration with dietary phosphorus restriction or oral phosphorus binder could be therapeutic target to attenuate the progression of myocardial disease in kidney disease, an exciting possibility.
Good, Dr. Vyas. Can you please tell me that what were the confounding factors in your study?
So confounding factors like hypertension was there, diabetes was there. So we adjusted the confounding factors, and still there was a significant correlation was seen.
Oh, okay, what the groups, both the groups matched for their dietary requirements, like normal vegetarian.
Sorry, sir, I can't hear.
Diet, like what sort of diet, like you know, there's a lot of
audio is not. It's not clear. Audio is not clear. Hello. Hello. Can you hear us?
Yes, because there's a lot of correlation between dietary supplementation of factors leading to influence on FGF.
Yes, sir. There are various factors that are present in the CKD patient, like hypertension, there, diabetes, there, hyperlipidemia is there. These can also lead to left ventricular hypertrophy in these patients. So we adjusted these parameters to minimize the effect of the confounding that can be because of the hypertension and the diabetes and hyperlipidemia.
Okay, thank you.
Yes, sir. Limitations.
Thank you, Dr. Priyas.
Thank you, ma'am.
So we move to our next speaker, Dr. Supriya. Prediction of clinical radiological profile and outcome of COVID-19 patients with requirement of home oxygen therapy.
Hello, ma'am. Am I audible?
Yes, you're audible.
Good morning once again. I'm Dr. Supriya, working as a consultant physician in Chinmaya Hospital, Bangalore. So going back to my study, this study was conducted in Bowring and Lady Curzon Hospital, which is a government hospital in Bangalore. And we had the maximum caseload of COVID patients, especially during the peak of the first and second wave. And this study was conducted for over 6 months during that period. So my study is on the prediction of clinical radiological profile and outcome of COVID-19 patients with requirement of home oxygen therapy. So coming to the background and aims, severe illness in people with COVID-19 typically occurs approximately 1 week after the onset of symptoms, as we all know. Our hospital had the state's highest COVID positive reservoir of cases with a myriad of clinical findings. However, we restricted to mild and moderate COVID cases who had to be discharged on home oxygen therapy and not the patients who landed up on ventilator support. Current survival from moderate to severe COVID-19 patients largely depends on providing early and best possible supportive care, of which oxygen therapy still remains an important facet. The results of a meta-analysis of 25 randomized trials that involved patients without COVID-19 demonstrate the potential harm of maintaining a higher SpO2 above 96. So hence in our study, we took a cutoff of 92 to 94%. We would like to identify the risk factors leading to prolonged oxygen requirement in COVID-19 patients. And this information will help us in managing our resources effectively in a resource-limited setting, especially like in a GH. So coming to the methods and results of our study, I would like to keep it very brief and short. So we had 100 randomly selected inpatients aged more than 18 years with a positive RT-PCR report, and of course with their informed consent, with or without pre-existing lung conditions. These were the set of patients included in the study. However, we did not include the patients who were already receiving home oxygen therapy for other causes like an OSA. Study was conducted over 3 months at Bowring and Lady Curzon Hospital and Research Institute, Bangalore. A multivariable logistic regression was applied to study the discrete outcomes of these patients who required home oxygen and requiring home oxygen for more than 1 week. And the discrete variables were in terms of either complete recovery, death of the patient, or discharge on home oxygen. So we were able to discharge about 24 patients on home oxygen out of the 100. Median oxygen requirement at discharge was about 3 to 6 liters per minute. Oxygen therapy was required in the younger patients, predominantly out of the ones discharged, and even with those without apparent comorbidities like smoking or any other asthma. Admissions with early onset of respiratory failure, a higher respiratory rate, lower albumin levels were independently associated with oxygen therapy, and these were independent risk factors. Patients who died had higher values of inflammatory parameters and bilateral peripheral lower zone pulmonary infiltrates compared to survivors. And these were the typical findings that were seen on admission. So we could predict that these were the potential patients who would be discharged on home oxygen therapy. Now, pointing out to the pitfalls or limitations of my study is that because it was conducted in the midst of the first and the second wave, the peak of the second wave in 2020, what happened is that the elderly population, we had the vaccine, Covishield and Covaxin, which came up in the month of January. So the elderly populations had already received their first dose. So majority of the patients, of my patients who were discharged on home oxygen therapy were the youngsters and the middle-aged people, predominantly in males. And we lost out on the exact count of the elderly population, probably because of the masking effect of the vaccine. And so that was one of the limitations of the study. And apart from that, at that point of time, there was non-availability of other immunomodulator drugs which had come up, like infliximab or a tocilizumab. So all those drugs were unavailable at that time. We only had remdesivir to our rescue. So probably if we had those set of drugs as well, I think patients would have done better with the immunomodulators, because considering the patchy pulmonary infiltrates and the requirement of oxygen therapy, high inflammatory markers, they were potential candidates for receiving immunomodulators or biological therapy. But since it was not available in our setup and it had still not come out in the open, they were still in trials, we were not able to install it, use it on our patients. So these were the potential limitations of our study. Thank you. Any questions?
Dr. Sandeep, any questions, please?
No.
Okay, thank you, Dr. Supriya. We move to our next presentation. Dr. Rajneesh Kumar, to correlate HS-CRP level in patients of cirrhosis of liver and with and without complications and the short-term outcome. Dr. Rajneesh.
Dr. Rajneesh Kumar is not available now. We'll go
Okay,
ahead.
so we can move to our next presenter, Dr.
Yes.
Vikyat Satish. Impact of
Morning, everybody.
COVID-19. Yes, okay.
Yeah, hi. How's everybody doing today? So my name is Vikyat Satish, and I'll be presenting a couple of papers today. And can I take the stage? Oh, just 1 second. Yeah. Are you able to see this?
Yes, your screen is visible.
Okay. Morning, everybody. So my presentation today is going to be on the impact of COVID-19 vaccination on the disease severity and outcomes in hospitalized patients. As we all know, coronavirus disease is an infectious disease which is caused by the SARS-CoV-2 virus under the coronavirus family. Now everybody is almost experts in this disease. So it's claimed many lives around the world, and it's taken lives of a lot of people irrespective of the age. And one of the very important factors we saw, which played a huge role in disease severity, was COVID-19 vaccination. And the vaccination was shown to reduce the disease severity, but the very scant reports, especially from India. So what we did was we present the outcomes of hospitalized patients in COVID-19 in a tertiary care hospital in Bangalore. So it was a retrospective observational study conducted over 40 days during the peak of COVID-19 in second wave in India. So that was exactly during the April-May time. And what we studied was 500 patients with moderate to severe laboratory-proven COVID-19 pneumonia. As we were a tertiary care referral center, we did receive a high caseload of severe cases as well. And the procedure mainly involved extensive collection of data with respect to demographics like age, sex, BMI, and comorbidities, as well as the vaccination status and the CT severity scoring, the requirements of oxygen, as well as stay and outcomes. The results were analyzed and statistics were performed using the chi-square and Mann-Whitney test, and a p-value was set at 5% and considered significant, anything below that. So moving on to the result quickly. So according to the demographics, 320 patients of our out of the 500 were males, and an average age was 52 years. And the BMI was in the overweight category of 26.6. Almost half of the patients had at least one comorbidity, and most commonly seen was diabetes mellitus and hypertension. The mean CRP level at admission was around 70, and usually a normal value is considered somewhere a little less than 10. And on admission, more than half of the patients required respiratory support, and this ranged from low flow oxygen in terms of nasal prongs, oxygen mask, but also vary to HFNC as well as mechanical ventilation. In the remaining patients, many of them also progressed to require respiratory support due to clinical worsening. And the mean length of hospital stay was around 6 days. And very importantly, what we found was the vaccination data. So 148 patients, that's around 30%, were vaccinated with at least one dose before being hospitalized. And out of which a very small number of them had received both the doses. That's around 14 patients. So majority of the patients were vaccinated with Covishield just because of the increased availability during the beginning of the pandemic. And a few of them also had received the Covaxin vaccine. So just to trip down memory lane, this was during April, as I mentioned, of 2021, and only by the vaccination had started only by the month of end of January to February, only to the healthcare workers and slowly to elderly patients and with people with comorbidities. So the mean age for vaccinated patients was around 58 years. Compared to the 49 years in non-vaccinated patients, and this was a significant association we found. And this again was due to the national vaccination policy prioritizing the elderly patients. Around 29 of the 148 patients compared to 125 out of the 352 patients had severe disease at presentation. So again, this was a significant association we found. And the vaccinated patients had a significantly lower CRP level at the baseline, that is at the time of admission. Again, another significant association. Many of the vaccinated patients required respiratory support at baseline, but it was much lesser compared to the ones who are not vaccinated. Again, another significant association. Of note, of very importance is that the need for reduced respiratory support in vaccinated patients was seen despite a higher mean age, as well as more comorbidities in the vaccinated group as well. So it does shed some light on the importance of vaccination in the prevention of severe disease. And moving on to the mortality data, the overall mortality was around 17.2%. And though the mortality was numerically lower in the vaccinated group, there was not a significant association with this. But what we'd like to highlight here is that 20 of the 148 patients who died in the vaccinated group had received only a single dose. And everybody who received 2 doses of the died also had a higher mean CRP at admission as compared to its survivors, and were already on respiratory support. As I mentioned, it was a tertiary care referral center, so we did receive a lot of referrals who are already on ventilator as well. So this table really summarizes the entire result. And as I mentioned earlier, that the mean age was higher in the vaccinated group when compared to the non-vaccinated group. And again, the mean CRP was lower in the vaccinated versus the non-vaccinated group. And the oxygen support at baseline, again, was on the lower side. What's very interesting to see is that the case severity. Here you can see that most of the vaccinated patients came under the moderate category compared to the non-vaccinated, where there were more people percentage in the severe category. And though not significant, ICU admissions was also seen at a lower rate. And another significant association we found that was incremental oxygen requirement was seen more in the non-vaccinated group. Moving on to the discussion. So vaccination with both the Indian vaccines really did have a significant impact in reducing the severity of the disease, inflammatory markers, as well as the respiratory support, and a trend towards lower mortality. These were the 4 main points of the study. And the effects were seen despite the vaccinated patients having more risk factors, such as higher mean age and more comorbidities. The impact of single dose versus 2 dose could not be evaluated, as most of these patients had only received a single dose, because it was just like almost the first or second month since the vaccination rollout had happened from the government of India. And additionally, 2 doses have been shown to reduce hospitalization, which could also possibly explain the lower numbers in the hospitalized cohort. There was also no mortality in the vaccinated patients who received 2 doses. But again, the study had a smaller number of people who received 2 doses, so larger numbers are required to validate this observation. It was also not possible to see the differential impact between the 2 vaccines because the initial vaccine rollout was with Covishield, that's the AstraZeneca vaccine. And in conclusion, I would say that the initial reports highlight the role of vaccination in the impact of the disease severity in hospitalized patients. It raised additional questions such as the outcomes of mortality, the role of 1 versus 2, and at that point, the availability of significant vaccine doses. And the results in this study really show that there are significant advantages even with a single dose of vaccination, and even a single dose of the vaccine can help in the preventing of severe disease and death with a mortality benefit. Thank you. Any questions?
Yes, Dr. Vikyat.
Thank you, Dr. Vikyat.
Yes, Dr. Vikyat, can you please tell that what yours was mostly with the Covishield type?
Yes, sir. Yeah.
So you suggest that more studies should be done with Covaxin also. And please can you tell me that you said that you would put the patients with 1 dose of vaccine, most of them?
So what happened was this was during like April time, and the vaccination rollout had happened, just started for healthcare workers during the end of January and February. So a very small number of patients who were really motivated to get the vaccine in the elderly group above 65 had received 2 doses. So we really couldn't tell during the April and May how much the importance of 2 doses was versus 1 dose. As well, at the same time, if you can remember that Covaxin was not widely available when compared to the AstraZeneca Covishield vaccine, because the Serum Institute of India was producing it at larger numbers than the Bharat Biotech vaccine. So again, this was the preliminary data which we did publish during the second wave of COVID, that's the Delta wave. And this study was really important to help with the vaccine hesitancy and try to improve the outcomes of people getting vaccinated and the advantages of it.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Vikyat. Kindly move to your next presentation.
Sure, ma'am. Thank you. One second. Are you able to see this? Hello. Am I audible?
Yes.
Yes, you're audible. Yes.
Okay. So my next presentation is a case report. So I'm going to be speaking about gossipy boma larynx, cause of post-trachea stripe. Introduction is the gossipy boma. A gossipy boma is a mass lesion surrounded by foreign body reaction. And retained sponsors in adults mostly occur post-surgery and is very common in the abdomen, pelvis, and the thorax. But incidence of surgery is exceedingly rare and also very difficulty in early diagnosis. So the failure in early diagnosis could to increase morbidity and mortality and has the potential of causing stridor and ischemia. And we report a case for glaucoma in the lab, severe head injury. To our knowledge, this is a reported case of glaucoma in the airway. So, 32-year-old male who underwent a craniotomy for traumatic traffic accident. One complaints of external dyspnea, stridor, plus difficulty in breathing for tracheostomy decannulation. Also complained of a slight body sensation to the throat and sensitivity. The patient was relatively well, and he had a pulse rate of 92 per minute and oxygen saturation 96 on room air. And the patient is steroids antibiotization and differentials like post-intubation or tracheostomy, tracheal stenosis, pseudomembrane formation, as well as granulation and synechia formation were suspected in this patient. So moving on to the investigations, an elevated leukocyte count was noted and other lab values were relatively normal. And a chest radiograph was done, which really revealed no abnormality, just to rule out any lung pathologies. And the CT scan of the neck was undertaken, which revealed a peculiar finding, a very rather unique finding, that is a well-defined curvilinear soft tissue density, which extended from the hypopharynx to the larynx and the upper trachea. And it caused also mild to moderate luminal narrowing. Here, if you can see, here we have marked the homogeneous curvilinear membrane in the lateral neck view of the CT scan. So what we did next was, ultimately the patient did worsen over time, and the patient complained of irritant cough and suddenly had a severe exertional dyspnea at rest and was unable to move out of the bed. So the patient was urgently taken for fiber optic bronchoscopy after informed consent was taken. And the patient was prepped with lidocaine nebulization and was also pre-oxygenated, and an emergency standby team was positioned for the requirement of an emergency tracheostomy if necessary. So during the fiber optic bronchoscopy, we found that the vocal cords visualized were normal and moved equally with respiration as well as phonation. A gray strand of glistening thick inspiciated mass projected across the vocal cords along the anterior commissure. The scope was passed distally beyond the cords, and a band-like structure was found to be adherent to the anterior tracheal wall at the tracheostomy site as well. This is the same mass we're talking about. So the tracheostomy site was healthy and with adequate tracheal lumen with no granulation tissue as well. And the tracheal bronchial tree was inspected and thorough toileting was performed. And upon withdrawal of the scope, the initially visualized band in the larynx was not visualized. So we really did get wondering what happened to this. And suspecting a distal dislodgement, the entire tracheobronchial tree was revisualized, but we were not able to identify the structure again. And assuming it was a mucus strand that the patient coughed up and swallowed, the bronchoscope was withdrawn. At the same time, the patient complained of a foreign body sensation in the throat during the visualization of the pharynx, where a thick grayish black slimy mass was retrieved. And further examination revealed that it was a ribbon gauze covered with mucus. And the patient clinically improved and was discharged the following day. So here you can see that the ribbon gauze was the gossipy boma, in fact. So moving on to the discussion. So gossipy boma is a well-accepted never event that it should never happen in any patients and is uniformly accepted by the UK, USA, and all countries around the world. And the Joint Commission also designated the retained surgical items, that is a gossipy boma, as a sentinel event requiring immediate root cause analysis as well. So majority of the cases do go unreported due to the fear of litigation and the perceived taint of a professional career. Understandably, many people do not want to report this, and I have come across a personal case during my undergraduation as well, which was treated silently. And the principle of res ipsa loquitur, where the act speaks for itself, really does apply to this, and it should never happen in any patient. And in this case, the most probable cause for the retained sponge was the surgical gauze used to guard the tracheostomy site. As we all know, the gauze is usually tied around the tracheostomy tube to give a good seal to prevent air leaks. However, the patient was shifted to multiple departments due to multiple interventions for the road traffic accident and craniotomy as well as maxillofacial surgery. So the missing of the fact that the gauze was there in the first place. And so it could have possibly got buried under the skin, and the post-decannulation slowly dislodged into the trachea over time. And despite the patient's effort to cough it up, the gauze was lodged in the larynx at one end and was not able to be coughed up. So the gauze was dislodged during the end of bronchoscopy and was retrieved. The gossipy boma larynx presents itself earlier when compared to other sites and is at an imminent risk for airway compromise because of its unique position, and really warrants early intervention in these cases. The radiographs are most commonly used modality to detect gossipy bomas, but in certain cases, as in here, you can notice that the X-ray did not reveal any findings. So in such cases, what we suggest is use of modalities such as CT, MRI, as well as PET scan, which aids in the diagnosis, and there's data regarding this as well. And as established methods to prevent retained surgical items, like as we know, something like gauze counting during surgeries and the PAP of 5 approach. So you can calculate the number of gauze in multiples of 5. And the Swiss cheese model, which really involves multiple people rechecking the same thing so that the holes of the cheese do not align. And the flattening of the hierarchy of surgeons and use of a checklist have been proven in lowering the surgical mortality and litigation. But however, we would like to shed light on the fact that there are very sparse guidelines and studies that exist on the prevention of a gossipy boma in stomas, such as this, and because of its rare occurrence. So while the use of radio-opaque marker-tagged surgical sponge is almost universal in all Western countries, we as a developing nation should understand our limitation, and it is not readily available in all clinical settings in India. And surgical sponges tagged with RFID chips with a handheld detector carried a near total detection rate, sensitivity, and specificity. Lastly, I believe that the effective communication and documentation between the members of a multidisciplinary unit, such as this one, could have helped in the prevention of this and would have prevented the morbidity of this patient. In conclusion, the gossipy boma is a rare, albeit a very reversible cause of stridor. And we urge everybody to consider this as a cause of stridor in a patient who has undergone tracheostomy. And it may go undetected in radiographs. So further imaging modalities such as CT and MRI may be required to identify it. And in the event of such diagnostic dilemma, the evaluation of bronchoscopy should be taken immediately and will help in definitive diagnosis as well as therapeutic intervention at the same time. The primary goal is, of course, to establish protocols for gossipy boma and the use of newer technology to avoid never events in the first place. Thank you. Any questions?
Thank you, Dr. Vikas. It was indeed a good case report. Where the word myoma came from?
So gossipy boma is again related to cotton. So it's really gossypium is actually the scientific name of cotton. So cotton is the main thing used in, it's basically for a retained surgical sponge, which is made of cotton. So that's where it derives.
So you suggest that RFID chips should be placed in, should be included in surgical safety guidelines?
Yes, sir. Actually, almost all the Western countries today, when we see the data, do use RFID chips or something labeled it. So it really helps in the prevention of gossipy boma. And there are various studies regarding this, which really provides near total detection rate. Almost the detection rate was 98% sensitivity and almost 99% specificity as well. And a 95% detection rate using a handheld scanning detector.
Okay, thank you.
And I believe that the mass production of...
Thank you, Dr. Vikyat. Thank you, please. We move to our next speaker, Dr. Dipansha, using artificial intelligence to predict mortality in patients with heart failure.
Am I audible?
Yes, you're audible.
Okay. Good morning, judges and my friends. So today is the era and age of technology and the era of artificial intelligence. Today I'll be presenting my abstract using artificial intelligence to predict mortality in patients with heart failure. Cardiovascular disease amounts to a huge burden of morbidity and mortality worldwide, and heart failure is one of the most common cardiovascular pathology. Heart failure is an expensive and lethal disease. Various factors influence heart failure and the prognosis of patient with heart failure. Identify these risk factors as well as predicting the prognosis can help and can lead to a cost-effective care and timely management of the patient. But the complex nature of heart failure produces a significant amount of information that is too difficult for clinicians to process, as it requires simultaneous consideration of multiple factors and their interplay. Here, artificial intelligence and machine learning algorithms can be utilized in this scenario. We have aimed to create an artificial intelligence algorithm to be used as a reliable clinical decision support system to predict mortality in heart failure patients and assist clinicians to properly interpret patient records to make informed decisions. Prediction of prognosis and knowledge of future risks can help the physicians to make informed decisions regarding the intensity of the treatment, and the identification of low-risk patients will decrease the patient anxiety and prevent additional cost of treatment. So what we did was we analyzed 299 patient records with left ventricular systolic dysfunction or a history of heart failure, which categorized them into class 3 or class 4 NYHA stage. These records were analyzed, including the demographic details, the lifestyle parameters, as well as the clinical routine laboratory investigations, such as platelet counts, serum creatinine, serum sodium, and then these patients were followed up for 130-day average to look for the patient outcome. The database comprised of 32.11% patients who died during the follow-up period. This is the description of features we used in the dataset and numerical features which we have available. We then did feature selection using a combination of literature review, trial and error method, as well as recursive feature elimination techniques. We then applied the threefold cross-validation technique to use during model training, and model stacking was done. We utilized a series of different AI algorithms to train our models using the data set, and then evaluated these models on various parameters and metrics such as F1 scores, Matthews correlation coefficient, accuracy, and precision. So this was our final model pipeline. And then coming to the result and discussion. So finally, out of all the AI algorithms, two-stack extreme gradient boosting machine algorithm was which provided us the most better outcome and outperformed all others with an accuracy of 84%. We can also see the area under the curve, and our model also outperformed other approaches used in the previous studies. It highlighted that there are three most important critical factors which influenced heart failure mortality and prediction of the heart failure mortality, including the ejection fraction, serum creatinine, and age of the patient. It also corroborates with the current clinical literature finding available. Using the Shapley plot, that is the Shapley additive explanation plot, we increase the expandability and interpretability of our model. And it showed that patients with low ejection fraction with increased serum creatinine and elderly patient had a higher risk of mortality. The model is particularly helpful in busy clinical settings and poor resource settings, where doctors can take the support of this model to predict mortality in patient and increase the intensity of the treatment. A limitation of our study was that it is a small data set we used, and using a large multicentric data set will improve the model's accuracy as well as the sensitivity and specificity. Our approach showed that machine learning algorithms can be utilized to provide consistent and precise prediction for patient survival from clinical parameters and provides a clinical decision support system, which is the future of technology and future of healthcare. Thank you. Any questions?
Thank you, Dr. Dipansha. So this was a nice presentation. May I love to ask that how much sample size you require for robustness of this study?
So, sir, this was like approximately 300 patients. We would require a little bit more, and if we involve different geographic patients as well as increase the data set and increase the number of patients, the accuracy of the model improves because the model has the AI algorithm has more data to train, and that's why it increases the accuracy. So any amount of increase in the patient number will increase the accuracy. So that's what we aim for to overcome the limitation of this model.
Okay, thank you. Thank you.
Thank you, sir.
Thank you, Dr. Dipansha. Do we have Dr. Bhavya Ratan here?
Yes.
Okay, so yeah, you can start with your presentation.
Okay. Is my screen visible? Hello, is my screen visible?
Yes.
Okay. So a very good morning to all judges. I am Bhavya Ratamaru, and I'll be presenting the development of a lightweight deep learning algorithm to identify monkeypox skin lesions. Human monkeypox virus is an enveloped double-stranded DNA zoonotic virus of the poxviridae family. It presents with 1 to 4 days history of fever with headache, fatigue, followed by maculopapular, vesicular or pustular rash. The clinical presentation of monkeypox resembles chickenpox and measles and smallpox. Moreover, minor differences in morphological presentation of these diseases have made early diagnosis of monkeypox challenging, and polymerase chain reaction-based strategies for diagnosis is also not widely accessible. On July 23, 2022, the global monkeypox outbreak was announced as a public health emergency of international concern by WHO. The recent case fatality ratio has been around 3 to 6%. The virus spreads by close contact or contact with contaminated objects like clothing. WHO recommends isolation of the patient with confirmed monkeypox case until the lesions have
using some slide. I think they're not in college.
And fresh skin has formed underneath. Therefore, it is crucial that cases are detected rapidly to reduce community transmission. In recent times, artificial intelligence-based applications have been used extensively in the fields of healthcare. Visual detection using deep learning technologies have found to produce successful results. Through development of a lightweight artificial intelligence algorithm to identify monkeypox skin lesions, we can assist the community as well as healthcare workers to make rapid diagnosis while operating on widely accessible supercomputing devices like mobile phones. Coming to the aim, we aim to develop a lightweight artificial intelligence image classification algorithm to accurately identify and differentiate monkeypox skin lesions from other varieties of skin lesions while also operating on a lower computing power. Coming to our methodology, our data comprised of 102 monkeypox skin lesions and 126 non-monkeypox skin lesions. These non-monkeypox skin lesions involve chickenpox or measles skin lesions, which are similar in presentation to monkeypox lesions. 80% of the data was used for training the model, while 20% was used for testing. Data augmentation techniques were used to increase the size of the training dataset. MobileNet V2 models have proven to perform competitively for recognition of monkeypox skin lesion, as shown by the approach by Shahin et al. A custom convolutional neural network comprising of MobileNet V2 with additional pooling, tense, and dropout layers was created. The model was trained with appropriate weights to solve class imbalance with early stopping and callback functions to retain the best performing model. So this is the pipeline of our overall model. The model takes in an image and then transform it through the overall pipeline, present a diagnosis, whether the following presentation is of monkeypox or not. This is the summary of the model. Coming to our results, the model provided an accuracy of 95.56% on the testing set and a sensitivity of 95% and a specificity of 96%, displaying its capability to be used as a reliable tool to detect monkeypox skin lesions. This is the classification report showing the accuracy and the precision and the recall for the two classes, as well as the accuracy as the training data is increased for the model. Our model surpassed previous approaches in development of an artificial intelligence algorithm with more accurate and precise classification while utilizing lower computing powers. This is the sensitivity specificity, as well as the truth table for the developed model on the testing set. In this study, we demonstrate the ability of a lightweight artificial intelligence system to identify monkeypox skin lesions with high specificity and sensitivity while operating on lower hardware infrastructure. This system allows monkeypox suspects and healthcare workers to conduct preliminary screening, as well as enables infected people to take action in early stages of infection, thereby helping to reduce the spread of the rate of the monkeypox global outbreak. AI has great potential to assist in detection, diagnosis, and control of infectious diseases by assisting clinicians in low-resource settings wherein there is scant availability of skilled personnel and hardware infrastructure. The limitations of our study include the lack of other clinical parameters, as well as the small size of dataset. Thank you so much. These are my references. Thank you so much.
Thank you so much, Dr. Bhavya. So your model was for, have you seen so many cases?
Yes, sir.
From where your AQ AI came from?
Sorry, sir, you weren't clear. Can you repeat the question?
Have you seen those so many cases, or you computed the cases?
So the images for the training of the dataset was not recorded by us. This dataset was provided by another author called Ali et al. They provided the dataset for the model training, and all due permissions were got from them for the development of this study.
All the images. For the images.
Yes, sir. For the images.
Okay. Thank you.
Thank you, sir.
Our next speaker is Dr. Venugopal, Demographics and Dynamic, a study comparison of first wave and second wave COVID-19 patients in India. Dr. Venugopal?
I'm not able to share my screen. I'm not able to start my video. Can you help me out here, if you don't mind?
ऑफ करना होगा तो इसमें कटर दिया हुआ है तो बंद हो जाएगा।
अच्छा,
It's showing that I'm not like I cannot start my video because host has stopped it. It's showing like that.
Dr. Venugopal, are you able to share your slides?
No, it's showing that I am not able to share because host has stopped my video. It's showing like that. Can you help me out with that? If you don't
Kindly
mind?
wait, please.
Okay. Thank you so much. Good morning, everyone. Myself, Dr. Venugopal. Currently, I'm working as a research assistant in my clinic. Today, I'll be presenting about my abstract presentation that I made it as an poster presentation. So, is that visible?
yes, you are visible.
Okay. So, is my abstract, the poster presentation visible?
We aren't able to see your slides.
Okay, just a minute, maybe. I think there is some technical issue with that. I'll just present my case presenter verbally, then that should be fine. So my title of the abstract is Demographic and Dynamic Study Comparison, First Wave and Second Wave, where in a COVID-19 patients in India. And the hypothesis of my abstract is the second wave of COVID-19 in India displayed a rise in number of young adults being hospitalized, which has higher mortality rate. We present the analysis of hospitalized COVID-19 patients during the second wave in India. That we took the data from Apollo Hospital, Jayanagar, from April 21st to June 1st in 2021. So the method we used a retrospective analysis of hospitalized COVID-19 patient, and the results are like this. So the cohort consists of 500 patients with a mean average age of 52 years. Out of 500 patients, 320 patients, that is 64% males, were males. In the mean BMI was 26.6 kg. Out of 500 patients, 256 patients had at least one comorbidity with diabetes or hypertension being the most common, where like diabetes was 37.5% and hypertension was 30.5%. So respectively. Out of 500 patients, 148 patients were vaccinated with at least one dose, because during that time, the vaccination was just started during that time. So in 2021, we took the data in April. We started collecting data in April 21st. So according to that, only 148 people out of 500 people were vaccinated. That is 29.6. And the mean CRP at the administration, while was around 70 plus or minus 31.2. Out of 500 patients, 256 patients, that is 53% patients, require respiratory support at the admission, while 85% of the remaining required it eventually. First, initially, they came with dyspnea, then later they went under ventilation. And out of 500 patients, 191, that is 38 patients were hospitalized, had an average age of 45. Which was significantly higher compared to the first wave, which is like 257 out of 257 out of 1,840. And overall mortality rate was 17.2%, which was significantly higher compared to the first wave, that is 7.5%. The p-value less than 0.05. And the patients with more than 45 years contributed 20% of the death compared to the 8% during the first wave. Again, the p-value is less than 0.05.
हाँ क्या हाल है? अच्छा अच्छा, कब है भाई?
2 दिसंबर सर।
सब बढ़िया। कहाँ से हो रही है?
Shall I continue? There was a disturbance. Again, there were like again I will come back. 45% vaccination, like vaccinated people require respiratory support compared to the non-vaccinated, that is 56.5%, indicating milder diseases in vaccinated patients, and mortality was higher in non-vaccinated patients, and in the death in the vaccinated and non-vaccinated patients were like this: 13.5% versus 18.75. And the conclusion is the male sex, older age, non-vaccinated, higher BMI, and comorbidities are associated with severe disease. And the implication, worldwide vaccination is essential to prevent the severe disease mortality among the population, especially young adults. Thank you. I'll be taking your questions now. Sorry for the inconvenience, I couldn't share my presentation.
Okay, Dr. Venugopal, thank you so much. And what do you think are the factors, apart from the factors you enumerated about vaccination and other things, what
Sorry?
You think what do you think the factors were there for increased mortality in the first wave?
So the factors are like male, older age people, and higher BMI, more comorbidities. So that will, in those patients, vaccination helps in significant way.
Okay, thank you.
Thank you.
Our next presentation is by Dr. Cooper.
Hello, good morning. Is my screen visible?
Yes, it's visible.
Okay, so good morning, everyone. I would like to present a very interesting case, which is a favorable outcome by rituximab in a case of new onset refractory status epilepticus and febrile infection-related epilepsy syndrome. So let's get right into it. The history. We had a 17-year-old pre-morbidly healthy male who was presented as a referral to our ED. He had the following complaints: low-grade insidious fever, holochronal headache, and gradually increasing multiple episodes of generalized seizures in the last 8 days. They spiraled into confusion and disorientation, and finally completely altered sensorium. The referral was in view of refractory status epilepticus with a probable diagnosis of autoimmune encephalitis. So to rule out, he had no similar episodes in the past, no trauma, no ear discharge, any poisonous substance ingestion,
The LED stent was
rash,
taken.
bleeding, signs of lupus, drug addiction, a seizure disorder in the past, or a complicated birth history. On arrival, the available information that we had was that his complete blood count, his renal function tests, his liver function tests, all were normal. There was no dyselectrolytemia. His urine protein microscopy was unremarkable, and even his CSF studies showed nothing. And imaging of the brain along with venography also showed no abnormalities. On arrival, our examination showed he was hemodynamically stable, no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. His CNS examination, he was in a post-ictal state with preserved spontaneous movements in all 4 limbs. No meningeal involvement, bilateral pupils reactive to light. His plantars were upgoing bilaterally with an ankle clonus, and the reflexes elsewhere were 2+. On investigating him further, an EEG showed generalized fast beta activity. A repeat CSF analysis showed absolutely no abnormalities. An MRI did show posterior reversible encephalopathy syndrome, probably associated with autoimmune conditions. And antibody panel to rule out paraneoplastic syndromes were negative. A fever profile and TORCH titers to rule out infectious panel was also negative. Our attempt to manage this patient over a course of roughly 60 days consisted of a slew of anti-epileptics ranging from levetiracetam, oxcarbazepine, valproate, topiramate, midaz. We even included methylprednisolone, mannitol, an anti-infectious panel of ceftriaxone, acyclovir, artesunate, vanco, but he wasn't responding to any of them. Finally, we had to put him into a thiopentone-induced coma with mechanical ventilation, along with the ketogenic diet, but he still showed no signs of improvement. So what next? Finally, we had a breakthrough with the use of rituximab 500 mg as an IV infusion. By the 5th cycle, he showed tremendous improvement. We gradually tapered his anti-epileptics and he was soon discharged with a favorable prognosis, and he still maintains the ability to walk. So to summarize, his final diagnosis was FIRES or NORS. NORS is basically a clinical presentation in a patient without active epilepsy or other pre-existing relevant neurological disorders. There is no structural, toxic, or metabolic cause. And even after extensive evaluation, we have not found any particular cause. We would just label it as cryptogenic NORS. And FIRES, as in this patient, is a subcategory where a prior febrile infection had begun at least 2 weeks to 24 hours prior to the onset of the status epilepticus. Rituximab is a therapy with potential to tackle this condition, and there are emerging therapies such as brexanolone, anakinra, cannabinoids, intravenous immunoglobulins, which have been used successfully in case reports. As of now, there are no randomized controlled evidence to inform doses, orders, or timings of such treatments. And there have been over hundreds of case reports showing immunosuppression as a promising treatment. Much more research is needed to find a clear answer for this condition, and hence I believe this is a significant topic. Thank you.
Okay, so much. Thank you for this nice case report. And what are the side effects of this rituximab?
We did monitor for myelosuppression. We did monitor for liver function and renal function tests. Since he was for over 2 months in our ICU, he did have a lot of comorbidities. He did have a lot of infections that set in. So yes, we did monitor for abnormal liver, renal, and bone marrow suppressions, but all were tackled with appropriate consults.
So our next presentation is by Dr. Haiman P. Afsar, in silico drug target screening for drug repurposing using artificial intelligence. Dr. Haiman P., are you there? So, thank you, Dr. Sandeep Bhattacharya sir, Dr. Heather sir, for being our judges for the session. I welcome our judges, Dr. Ajay Verma, Dr. Jyoti Shah, and Dr. Shivani for our next session. We'll start our next presentation. Dr. Ayush Pandey, effect of early pulmonary rehabilitation in COPD patients.
I'm just sharing my screen. Is my screen visible? Hello, is my screen visible?
Yes, your screen is visible.
Slideshow mode.
Hello everyone, and first of all, I would like to thank the judges for the session, Dr. Ajay Verma sir, Dr. Jyoti Shah, and Dr. Shivani, and the moderator Preeti for organizing this session and giving me an opportunity to present the paper in ACP India chapter. So the topic for my paper is effect of early pulmonary rehabilitation in COPD patients. Hello everyone, I am Dr. Ayush Pandey, and I am a senior resident in Department of Pulmonary Medicine at SGT Medical College and Hospital, Gurugram. So as we all know, COPD is a common preventable and treatable disease characterized by persistent respiratory symptoms, airflow limitation that is not reversible as per the latest goal guidelines 2023. So pulmonary rehabilitation is an important component of the integrated and holistic healthcare of patients with chronic respiratory impairment. Pulmonary rehabilitation aims to reduce symptoms, decrease disability, increase participation in physical and social activities, and improve the overall quality of life for patients with chronic respiratory disease. So minimum 8 weeks of 2 to 3 sessions per week of outpatient or community-based sessions are recommended to achieve a satisfactory outcome of PR. So we conducted a study of all on adult patients of either sex diagnosed as a case of COPD, and this study was carried out from September 2019 to October 2021 in the Department of Medicine at SGT Medical College, Gurugram, Haryana. So we enrolled total 60 patients after applying all the inclusion and exclusion criteria as per the latest goal guidelines. Patient underwent a comprehensive rehabilitation program of 8 weeks with once weekly supervised sessions. So all enrolled 60 patients completed the program and were assessed pre and post rehabilitation on the following parameters, that is body mass index, pulmonary function test, 6-minute walk test, COPD assessment test, and modified medical research council, that is MMRC dyspnea scale. So these patients underwent a comprehensive rehabilitation program of 8 weeks, which included once weekly supervised sessions. These sessions included breathing exercises, educational sessions regarding nutrition, lifestyle, smoking cessation, counseling sessions, and proper use and method of inhaler therapy, as we all know that many patients do not know how to use the proper method to take inhaler. So breathing exercises were taught to patients in the presence of a respiratory physiotherapist. Pursed breathing, diaphragmatic breathing, unsupported arm exercises, airway clearance were mainly taught to patients. The exercise intensity and schedule was tailored according to individual patient. Psychological support and nutritional counsel was also an important part of our pulmonary rehabilitation program. So these were the patients, and they have been doing the various exercises, pulmonary rehabilitation exercises. Talking about the inclusion criteria, we included age group more than 40 years of mild, moderate, severe, and very severe COPD patients as per the goal guidelines. Again, COPD confirmed by history, physical examination, and spirometry. No formal pulmonary rehabilitation program within the past 12 months has been done for the patient and patient who are willing to participate and perform the given rehabilitation program. Talking about the exclusion criteria, patients with active TB or any complications of pulmonary TB were excluded. Any patients with systemic diseases like IHD, RHD, or any cardiac disease were again excluded from the study. Any patient presenting with acute exacerbation of COPD and non-cooperative or psychological impairment patient were also excluded from the study. The stats which we applied were according to SPSS software, and one-way ANOVA test was applied, and a p-value less than 0.05 was considered as significant. So what was the result in MMRC score? So there was significant improvement in the MMRC score. So the patients who were in the MMRC, especially in the 2 or 3 grade, they landed up more into MMRC grade 1 after pulmonary rehabilitation program, showing that the data was statistically significant. This was the result again after 8 weeks. Talking about the COPD assessment test, the patients again in the high or high impact category, they again landed up into the low or medium category, again showing that there was significant improvement in the COPD assessment test of the patient. Talking about 6-minute walk test, the patients score significantly improved. So the patients who were earlier used to walk for 100 meters or 101 to 200 meters, they increased and they landed up into either 201 to 300 group or 301 to 400 meter group, showing the data was statistically significant. Again, this is an important table because there was although some improvement in the spirometry post-rehabilitation, but the data was not statistically significant, showing that pulmonary rehabilitation has very limited role to improve spirometric volumes post-rehabilitation. This was again improvement in the MMRC, CAT, and 6-minute walk test, pre and post-rehabilitation, p-value showing significant, statistically significant. Talking about the discussion part, the distribution of study participants according to the different score of MMRC grade shows promising results. So again, analysis of data was made pre and post rehabilitation, post 8 weeks, showing a p-value was significant in the MMRC, CAT score, and 6-minute walk test. So a CAT score of 15 indicates increased risk of exacerbation, and analysis showed that data was statistically significant. And again, although there was improvement in the FEV1 and FEV1 by FPC, but the data was not statistically significant when talking in terms of spirometric values. So talking about the conclusion, pulmonary rehabilitation has a significant role in improving the 6-minute walk test, MMRC and COPD assessment test, thereby implying that it improves exercise tolerance of the patients with COPD. So hereby I end my presentation. Thank you very much.
Dr. Ayush, nice presentation. What was upper age limit in your study subjects?
Sir, we included age group more than 40 years, and after applying all the mild, moderate, severe and very severe criteria as per the gold guidelines of the COPD latest.
No, I just asked your upper age limit.
So, sir, the sample size we took was 60 patients, and the maximum age group we were able to take was 81 and 82 also. 82 was the upper one patient was in 81 was of 81 years age, and the other patient was of 82 years age. So we had two patients. So thereby 82 was the maximum age which we...
Nice presentation. But what is new in your study? What new?
Sir, we exactly showed that although pulmonary rehabilitation is an important component and it improves the 6-minute walk test and exercise tolerance, spirometric volumes there was improvement. So there have been studies which showed that although there was improvement in the 6-minute walk test and MMRC score, but there is many such studies which has done to show that spirometric volumes along with all the 3 and 4 parameters correlating all the same. So we tried to correlate, showing that data was not so much statistically significant was for the pulmonary function test as compared to the significant data when talking in terms of 6-minute walk test, MMRC and CAT score.
Okay.
Thank you, Dr. Ayush. Our next presentation will be by Dr. Shivam Mir, a study of cardiac autonomic neuropathy in patients with diabetes mellitus.
Ma'am, Shivam is not available.
So next was also by Dr. Shivam Mir. So we come to Dr. Prabhakar. Is he there?
Is I audible?
Hello? Is Dr. Prabhakar there?
On behalf of Dr. Prabhakar, Dr. Devender. Hello.
Hello, yes.
I think
Shivam Mir is not there. So next is Dr. Prabhakar. Or do we have Dr. Aishwarya? Who is this? Ma'am, do we have Dr. Prabhakar or Dr. Aishwarya?
Yeah, ma'am. Actually, I'm online with the name.
Ma'am, your good name?
Is My name is Devinder Kaur on behalf of Dr. Prabhakar ma'am.
Could you please repeat?
Yeah, my name is Devinder. On behalf of Dr. Prabhakar, is I audible, ma'am?
Okay, you're Mayuri Shukla on behalf of Dr. Prabhakar.
Yeah.
Okay, you can start your presentation.
Actually, I want to share my slides. Is it visible as slides? My slides are visible, ma'am.
Yes, please go ahead and put in slideshow mode.
Okay, ma'am. Good morning, one and all. Today I'm here to present my oral presentation session. And my topic is interleukin 28B and toll-like receptor 2 gene polymorphism in hepatitis C infection. So as we all know about the HCV is a major concern about the public health, and worldwide about 3% people infected, and in India about 1 to 1.9% people infected with the HCV. So if I'll talk about the biological process in HCV related HCC, so as if know the natural course of the hepatitis C infection, like healthy liver, and once the patient is infected with the HCV and the virus enters into the body, then there will be a further biological process will take place, that is inflammation, cell growth signals, resistance to apoptosis, oxidative stress, metabolic disorders. Once it will lead to the active chronic hepatitis, then it will further go for the liver cirrhosis, and it may also lead to the hepatocellular carcinoma. And in that, major genetic susceptibilities are also there. Various SNPs also play an important role. So that my main target is interleukin 28B gene. So as we all know, interleukin 28B gene is a type 3 interferon, which have further 3 families, IL-28B, A, and IL-29. So IL-28B is clustered on chromosome 19. It's a first line defense against the viral infection. It's also play a role in the adaptive immune response. So about toll-like receptor 2, as we all know, they are the membrane proteins and important role play in the innate immune response. The toll-like receptor 2 is also present on the chromosome number 4. And toll-like receptor 2 genetic, as according to the various genetic studies, it play a role in alter the host defense, and it also may lead to the disease progression. So aims and objective to determine the role of IL-28B and toll-like receptor 2 polymorphism in HCV infected patients. According to this aim, further objective was designed to determine the association of SNP IL-28B with the HCV infection, and also determine the association of toll-like receptor 2 with HCV infection. So that methodology, this is a case control study, and it was done in 2018 to 2021, and institutional ethical clearance was taken. Then informed consent was also obtained from the patients in the written form. And study design, there were 2 groups, HCV positive cases and healthy controls. A total number of cases in each group was 124, and the study parameters was designed to check the association of IL-28B in HCV infection and healthy control by using the PCR and RFLP technique. And also for toll-like receptor 2 was done in healthy controls and HCV infection, that is done by the conventional PCR and gel electrophoresis. So this is the demographic characteristic of the study subjects. In that, age and gender was done by using the mean and standard deviation, by using chi-square test and student t-test. Is I audible? Ma'am, is
Yes,
I audible?
yes.
Yeah. So the first objective to determine the association of SNP IL-28B with the HCV infection. Protocol for that was that 3 ml of EDTA blood was collected from both the groups, HCV cases and healthy controls. Then further the DNA extraction was done by using the manual method, that was salting out method. Then further for that particular gene, then conventional PCR and RFLP was used in that restriction enzyme was used, that is HPY1661. And that result was for this was, as we all see in highlighted in red, that was unfavorable allele. That is more in cases and also more in controls. So that will shows that IL-28 interleukin B was also associated with the HCV infection according to the odds ratio. And when we'll do with the association of IL-28B SNP with HCV infection according to your genetic model, as we'll see that 4 genetic models was there: dominant, recessive, additive and multiplicative. In that recessive model shows the highest odds ratio as compared to the other. So according to these results, the probability of developing HCV infection is highest where the unfavorable allele, that is A of IL-28B SNP, was in the homozygous condition. So summary of the objective 2 was that to determine the association of SNP with HCV infection, and that what we observed that IL-28B with the RS number 129799860 was associated with HCV infection, and the probability of developing HCV infection was highest when the unfavorable allele A IL-28B was in the homozygous condition. So from that objective, we concluded the IL-28B may be as a risk factor. So that second one, to determine the association of toll-like receptor 2 with HCV infection, the same protocol was followed and DNA was extracted. But in that, we used the conventional PCR and gel electrophoresis technique. And in that, the result shows as the deletion was insertion and deletion, that insertion is act as a favorable allele and the deletion act as a unfavorable allele. So in this, it was shown that there is no association with the HCV infection. And this was the first study in India related to toll-like receptor between the healthy controls and the cases. So in this, we didn't get any association related to the HCV related to toll-like receptor 2. So we can't say that toll-like receptor 2 deletion and insertion may be act as a risk factor. So conclusion for the study was that SNP IL-28B associated with the HCV infection, and toll-like receptor 2 polymorphism was not associated with the HCV infection. So further recommendation was that IL-28B mediated signals may be used as a future therapeutic target. We need further replicative studies to reach to one conclusion related to the HCV infected patients. Thank you.
Sir.
Any questions, Dr. Ajay Verma, Dr. Jyoti Shah?
Mayuri, was any significant association of sustained virological response with that of genotype 2 and 3 patients?
I'm not getting, sir. Can you please repeat?
Is any significant association of sustained virological response with that of genotype 2 and 3 patients? Have you seen?
This that will be my further target to do with the particular genotypes. In this, I just check about the related with the only polymer. So further, I will try to process that only, sir. With the particular patients, I will take in which particular genotype and all will be included, sir.
Okay, thank you.
Yes.
Our next presentation will be by Dr. Aishwarya. Dr. Aishwarya, are you there?
Dr. Aishwarya is not there.
Okay, then Dr. Keshu Jindal.
Ma'am, Keshu Jindal is not available for present.
We'll move on to Dr. Aditi Tripathi. Hello. Good morning. Is my screen visible? Yes, your screen is visible. Okay. So, a very good morning to members of the dais and my fellow conference attendees. I am Dr. Aditi Tripathi, a PG resident in Department of General Medicine, Vardhaman Mahavir Medical College and Safdarjung Hospital. Today, I am here to present a paper titled Correlation of Adipocytokine Levels with EGFR in Pre-Dialysis CKD Patients. As we all know, persistent low-grade inflammation has been recently recognized as an essential component of CKD, playing a unique role in its pathophysiology and is also related to progression of CKD. Inflammation is a consequence of CKD and is also associated with adverse outcomes. It is accountable in part for cardiovascular and all-cause mortality. Over the last 15 years, there has been an exponential growth of interest in inflammation in CKD and end-stage renal disease, which led to the evolution in our perception of inflammation as not any longer a novel, but a rather well-established, if not traditional risk factor for morbidity and mortality in CKD. An inverse correlation between GFR and inflammation has now been clearly proven. Systemic inflammation is one of the hallmarks of CKD, and the exact pathogenesis of inflammation in CKD is not fully understood. Multiple comorbid conditions like infection and autoimmune systemic diseases can underlie inflammation in CKD in some but not all cases. Also, uremic milieu produces oxidative stress, which is pro-inflammatory. Adipose tissue has more recently been recognized as a metabolically active organ system linking the endocrine and the immune systems. It is a source of a variety of cytokines that are also called, due to their origin, adipokines or adipocytokines. They include adiponectin, leptin, TNF-alpha, vispatin, interleukin-2, resistin, and PAI or plasminogen activator inhibitor. Now, this is a flowchart that shows that adipose tissues liberate adipocytokines, the names of which I have mentioned before. These adipocytokines further lead to endothelial and podocyte dysfunction, inflammation, fibrosis, and oxidative stress. This will again in turn lead to progression of chronic kidney disease. One of these adipocytokines, that is adiponectin, actually has a different mechanism of action as compared to its counterparts. It is, unlike its counterparts, it is anti-inflammatory, anti-atherogenic, and anti-proteinuric. This is a table showing the salient features of the two main cytokines which I have studied in my study. Leptin, both of these cytokines are liberated by the white adipose tissue, and both of them are found to be increased in CKD. As we can see, leptin is atherogenic inflammatory. It increases the oxidative stress, it modulates the immunity, decreases the bone turnover, increases renal sympathetic activation, and decreases erythropoietin sensitivity. Adiponectin, on the other hand, is anti-inflammatory, anti-atherogenic, decreases oxidative stress, decreases proteinuria, and regulates the bone turnover. Adiponectin is the most abundant adipose tissue protein in human plasma and is suggested to be involved in anti-inflammatory, anti-atherosclerotic, and insulin-sensitizing effects. Adiponectin has anti-inflammatory effects on the vascular wall by suppressing the expression of low-inflammatory adhesion molecules and by interfering with endothelial NF-kappa B signaling, suppression of the pro-inflammatory cytokines, as well as by stimulating the expression of anti-inflammatory cytokines. Adipose tissue produces leptin to regulate energy intake and energy expenditure. Leptin is a 16 kilodalton polypeptide product of the obese gene or the OB gene and is predominantly secreted by white adipose tissue. Its major physiological role is to regulate hunger and satiety. Interestingly, leptin levels are elevated in obesity and in CKD and correlate with inflammation and adiposity in CKD, suggesting a potential link between inflammation, adiposity, and leptin levels. However, leptin is also linked to the development of CKD in absence of obesity. Renal disease have an estimated 4 to 7.5-fold increase in plasma leptin concentration compared with healthy control subjects, which may be the result of altered leptin production as well as terminal renal failure.
However, the mechanism for this link is poorly understood, and as such, future studies are required to further investigate this association. A potential mechanism for leptin and cholesterol-induced vascular dysfunction is mediated by upregulation of ROS, or the reactive oxygen species. They act by increasing the oxidative stress and decreasing the NO production. Also, the kidney in itself expresses abundant concentrations of the truncated isoform of the leptin receptor. Leptin can bind to this truncated isoform, and this can lead to renal fibrosis as well as hypertrophy. There is paucity of literature testing the role of adipocytokines in CKD. So there is a need to study it in pre-dialysis patients where early intervention could be more useful. The aims of my study were to study the level of adiponectin and leptin in patients of pre-dialysis chronic kidney disease. Objectives: to measure the serum adiponectin and leptin levels in patients of pre-dialysis chronic kidney disease and to compare the results of these with the eGFR. My study is a cross-sectional observational study lasting for 18 months. The study population is a total of 50 patients of pre-dialysis chronic kidney disease, fulfilling the inclusion criteria. The inclusion criteria, we included patients who were 18 years or older with eGFR less than 60 milliliters per minute per 1.73 meter square body surface area, not requiring renal replacement therapy, that is dialysis, and belonging to any gender. The exclusion criteria included presence of active infection, acute MI in the last 6 weeks, uncontrolled diabetes mellitus, consumption of antioxidant drugs, and presence of any active inflammatory disease. So patients presenting to VMMC and Safdarjung with symptoms suggestive of pre-dialysis CKD were first subjected to the inclusion criteria. The consent for study was taken, and then the exclusion criteria was applied. And thus 50 participants were finalized. Once finalized, these participants were subjected to clinical assessment and classification based on their KDIGO class, that is, based on their eGFR, into 4 categories. And these were then subjected to investigations, which mainly included adiponectin and leptin, and then we went on to further analyze the study. The categorical variables were presented in number and percentage, and continuous variables as mean, plus minus, standard deviation, and median. The normality of data was tested, and if normality was rejected, the non-parametric tests were used. Statistical tests were applied, and a p-value of less than 0.05 was considered statistically significant. The data was entered in SPSS software. So these are the results of my study. As we can see, around 24% patients were of the age 21 to 30 years of age. 28% belong to the 31 to 40-year-old age bracket, 26% belong to the 41 to 50-year-old age bracket, and 22% patients were older than 50 years. In my study, 36% of the participants were females and 64% of the participants were males. Here is a pie chart that is showing the distribution of the eGFR of the study participants. Around 74% of the patients had an eGFR that ranged between 15 to 29 milliliters per minute per 1.73 meter square. Around 24% of the patients had eGFR less than 15 ml per minute per 1.73 meter square, whereas only 2% of the patients had their eGFR between 30 to 60 ml per minute per 1.73 meter square body surface area. The mean value of serum adiponectin of study subjects was 18.43 plus minus 2.12 with median of 18.15. The mean value of serum leptin of study subjects was 8.98 plus minus 3.3 with median of 8.1. When we went on and correlated the adiponectin and leptin with eGFR, we found that a significant negative correlation was seen between eGFR with serum adiponectin and serum leptin with correlation coefficients of minus 0.998 and minus 0.55. A significant positive correlation was seen between serum adiponectin with age, serum creatinine, blood urea, serum phosphorus, serum HDL. A significant negative correlation was seen between serum adiponectin and serum calcium. A significant positive correlation was seen between serum leptin and age and HDL. Discussion. It is now evident that low-grade inflammation is an important component of CKD, which underlies its pathophysiology and is responsible for its accelerated progression and all-cause mortality. And as we have seen, adipose tissue has more recently been recognized as a metabolically active organ system, which links endocrine as well as the immune systems. Previously done studies have found an conducted in the Department of General Medicine in Safdarjung Hospital included 50 CKD patients who were not on dialysis. In the study, serum adiponectin and leptin levels were measured and then correlated with eGFR and other markers. The mean values are as have been mentioned before. Adiponectin has a number of functional roles, including acting as a cardioprotective protein, improving insulin sensitivity, and acting as a vascular protective agent, while the suppression of reactive oxygen species. In our study, adiponectin levels were measured and correlated with eGFR. A significant positive correlation was seen between adiponectin, age, serum creatinine, blood urea, serum phosphorus, and serum HDL. A significant negative correlation was seen with serum calcium. The two most plausible explanations given for increasing adipokine level in association with increasing severity of CKD are: one is that there is a decreased renal clearance of adipokines and as a physiological responsible to the pro-inflammatory state. As we have seen that adiponectin is in itself an anti-inflammatory cytokine. So maybe the body is trying to compensate. The result is in accordance to previous studies done by the authors. However, other studies have found that subjects with CKD had normal levels of plasma adiponectin despite the adverse metabolic environment for CAD. Various inflammatory adipokines have also been studied in relation to CKD. Leptin is one such inflammatory adipokine which mediates persistent inflammatory state in CKD patients. Significant positive correlation was seen between serum leptin and age and HDL. These findings are in accordance to various previous studies which have yielded similar results and found that female gender, higher percentage of body fat, higher insulin levels, older age, lower GFR and higher CRP were associated with higher serum leptins. Hyperleptinemia in CKD may be due to its decreased renal clearance, which in turn plays a key role in the pathogenesis of many complications associated with CKD and also in the progression of renal disease. There are a few limitations to my studies. The study is a hospital-based one and the sample size of the group was not large enough so that it can be applicable to the overall population. The study included only single measurement of adipocytokines, which may not represent the average levels of these markers over time. Our study was a cross-sectional one, and it could not assess the long-term trends in adipokines and eGFR. An association between adipokines and subtypes of CKD by different causes could not be evaluated because biopsy was not a part of the study. We concluded that adipocytokine levels are inversely related to eGFR in pre-dialysis CKD patients, and more studies are required to ascertain a causative role of these adipocytokines and to propose intervention models. Thank you.
Dr. Aditi, nice presentation.
Thank you, sir.
Just answer me the key findings of your study, number one, and how eGFR, urine, albumin, creatinine ratio are related with serum adiponectin levels.
Sir, I have studied the levels of adiponectin as well as leptin, and I've correlated both of them with estimated glomerular filtration rate. And I have found that in my study, as and when the GFR falls, it leads to a higher level of adiponectin as well as of leptin.
Okay.
It shows that either these adiponectin and leptins are mediating the progression of CKD, or these are the body's mechanism of fighting against the inflammatory milieu, which is leading to CKD. So the reason I have studied is that if we are able to find more evidence for this, then maybe we can also lead to formulation of certain drugs and intervention models, which if given in early stages of CKD, can actually halt the progression of CKD in further given time.
Okay. Thank you.
Thank you, sir.
Our next presentation will be by Dr. Aishwarya, Utility of Various Inflammatory Markers in Predicting Outcomes of Hospitalized Patients with COVID-19 Pneumonia.
Hello. Hello, ma'am. Hello. Hello, ma'am. Am I audible? Hello.
Yes, you're audible.
Good afternoon, one and all. I thank you everyone for giving me this opportunity. Ma'am, can I actually my second topic presentation first, ma'am? The study of clinical
Yes, sure.
immunology.
Yes, sure. You can. You can.
Yes. Okay, ma'am. Okay, ma'am. Good afternoon, one and all. This is my my paper is titled "A Study of Clinical and Immunological Profile of Patients with Antiphospholipid Syndrome in a Tertiary Care Hospital." Antiphospholipid syndrome is a systemic autoimmune disease characterized by thrombophilic state and obstetric complication. It was first described in 1983 by Graham Hughes as anticardiolipin syndrome, and subsequently it has been replaced by the term antiphospholipid syndrome when it was clear that antibodies against antiphospholipids other than anticardiolipin were also associated with APS. Earlier description of APS was in general mainly related to systemic lupus erythematosus, called as SLE, and later it was found that there are many other antibodies other than the anticardiolipin antibody, which has led to antiphospholipid syndrome. So, then there came a division of a primary antiphospholipid syndrome and secondary antiphospholipid syndrome. And the latest criteria which we have for the diagnosis of classical antiphospholipid antibody syndrome is the revised 2006 Sapporo criteria, which says that the patient should have either one of any thrombotic event or obstetric event and antibody positive for the classical antibodies, lupus anticoagulant, anticardiolipin, or the antibodies against beta-2 glycoprotein. But the defect or the drawback of this criteria is that there are several other antibodies which are not part of the Sapporo criteria, which are if seen in association with both seropositive as well as seronegative APS. These antibodies have been described with various manifestations of antiphospholipid syndrome, and one such antibody, which has been found in majority of patients with both seronegative and positive APS, is antiphosphatidylserine serine prothrombin complex antibody. But this, though it is not part of the revised Sapporo criteria, and there is positive literature pertaining to antiphospholipid syndrome, and more so in Indian patients. And overall, there are very few studies on antiphospholipid syndrome, including both primary as well as secondary, and also seronegative APS. Hence, the study was undertaken to establish a relationship between the clinical presentation and immunological profile of antiphospholipid syndrome, and also to find out the prevalence of antiphosphatidylserine serine prothrombin complex antibody in patients with antiphospholipid syndrome. So why do we need to know about the clinical and immunological profile in APS? Manifestations of APS ranges from asymptomatic laboratory abnormality to multisystemic devastating thrombosis and pregnancy morbidity. There's high degree of heterogeneity in laboratory and clinical manifestation of antiphospholipid syndrome. So these two predisposes for us to have a proper idea of what are the clinical immunological profile in APS. The aim of my study was to study the clinical immunological profile of patients diagnosed with antiphospholipid syndrome in a tertiary care hospital. And the primary objective was to compare the clinical presentation and antibody profile in APS. Secondary objective was to find the prevalence of antiphospholipid antibody in patients with APS. Material, it was done in Apollo Hospitals, Beams Road, Chennai. Study population included all patients aged 18 years and above diagnosed with APS. And study design was a prospective observational study, and study duration was 1st February 2020 to 31st March of 2021. Sample size calculation was done using a study done by Arvind Ganpati et al. Of CMC Vellore, and the required sample size was 58 cases. Inclusion criteria, as we saw, like all patients aged 18 and above with APS attending the hospital, and the diagnosis of APS was based on revised 2006 Sapporo criteria. Patients classifying only the clinical criteria of the Sapporo were without fulfilling the laboratory criteria were classified as seronegative antiphospholipid syndrome after taking opinion of the rheumatologist and hematologist. And this is the revised Sapporo criteria. To make it short, the clinical criteria should include any vascular thrombosis, be it arterial or venous thrombosis. And pregnancy morbidity, we have 3 under pregnancy morbidity. 1 or more unexplained deaths of morphologically normal fetus beyond 10 weeks of gestation, or 1 or more premature birth before 34 weeks of gestation, or 3 or more unexplained consecutive abortions before 10th week of gestation, provided like rest all maternal and paternal abnormalities were excluded. Laboratory criteria, as of now, we have, as you have seen before, there are only 3 antibodies and namely anticardiolipin, lupus, and anti-beta-glycoprotein, of which it can be either IgM or IgG type. Exclusion criteria is patients less than 18 years. The methodology, we just got the clinical history, and as needed, we did the laboratory profile. And while doing the antibody profile, along with the 3 classical antibodies of lupus, anticardiolipin, and beta-2-glycoprotein, we started doing this novel antibody test called as the antiphosphatidylate serine prothrombin complex. Along with it, other investigations to rule out SLE and other connective tissue disorders like C3, C4, anti-nuclear antibody, anti-DHDNA, all these antibody profiles were also done as needed. This is the statistical analysis plan. And this was the proforma which was used to collect the data. It includes all things. So to sum it up briefly, antiphospholipid syndrome can be either seropositive or seronegative. Seropositive, it can be either single antibody positive or double positive or triple positive or even quadruple positive, was 3 classical antibodies along with antiphosphatidylate serine. And if it is seropositive, we then look for either it is obstetric APS or thrombotic APS, or did it have any non-criteria manifestations. Out of all this, it can be either primary APS or secondary APS. And same thing happened with seronegative APS as well. We're trying to find the seronegative patients, and then we try to classify like which category they belong, either obstetric or thrombotic, or did they have any non-criteria manifestations. So the results of my study. This is the results of my study. We were able to get a total sample size of 65 patients, and mean age of the patient was 36 years plus or minus 4 years, with a range of 26 years to 56 years. And majority of the patient were female. There was a female predominance with 56 patients being female, around 70.8%, and male patients were 29.2%. And the presenting complaints, this is the presenting complaint symptoms of patients with APS. Majority of the patient presented with limb swelling. Limb swelling was likely secondary to any DVT, deep venous thrombosis, or any thrombotic event. So that was a majority of the patient's initial presentation. Around 30.8% had limb swelling, and we had 26.1% with recurrent abortions, and a shortness of breath secondary to pulmonary embolism was seen in around 21.5%. And there were also like smaller proportion of patients with myalgia, abnormal pain, chest pain, cough, rash, oliguria, anuria, discolored toes, hemiparesis, yellow discoloration, leg ulcer, abdominal distension, seizures. And the aim of listing out all these clinical presentation is to highlight the fact that APS in as such has a very varied clinical manifestation, and it can be a very simple to very complex presentation which we may come across. And along the patients with the past history, like there were around 4 patients with previous history of systemic lupus erythematosus, and 2 patients with rheumatoid arthritis, and 1 patient with ITP and Evans syndrome, and 19 patients, that is around 29%, had previous history of thrombotic events like stroke, young stroke, and DVT was seen in 9 patients, and pulmonary embolism was seen in 3 patients. And obstetric events, among the participants, 14 patients, 21.5% had late pregnancy loss, that is greater than 10 weeks. 17 patients, that is 26.1%, had early pregnancy loss, and recurrent pregnancy loss were seen in around 12.3% of the patients. other significant and so this is the schematic diagram.
Could you please wind up early because there's a time limit?
Yeah, yes, ma'am, sure, ma'am. This is the antibody profile which I wanted to highlight and show. So, lupus anticoagulant was present in 32.3% of the patient. Anti-beta-glycoprotein was seen in 49.3%, and anti-cardiolipin was seen 30%. And the anti-phosphatidylserine prothrombin complex, which is not part of the Sapporo criteria, was seen positive in 53.9% of the patients. So this tells us the importance of the antibody and also and this is the other flow chart in comparison with they were around 15 patients, 23.09 patients diagnosed with seronegative APS. That is, they tested negative for all three classical antiphospholipid antibodies. So if you see in obstetric APS, the blue diagram shows classical antibody positive, and the classical plus APS PT is positive is represented by the orange bar. So if you see in obstetric APS, on addition of the antiphospholipid antibody, you are able to get 100% diagnosis of APS. So with 20% of the patient who didn't have any classical antibody patient, we were able to diagnose them as APS with addition of this antiphospholipid prothrombin complex. And similarly, in overall APS also yielded a 8.8% higher pickup rate along thrombotic, and overall of 16.9% higher number of phase with addition of this antiphosphatidylserine prothrombin complex antibody. And also there's a correlation of LA positivity and antiphosphatidylserine prothrombin positivity. So if you see, whenever we were able to find LA positive, APS-PT IgG antibody also was positive with a significant p-value of 0.000. So in cases when we are not able to perform LA, like the patient is on any anticoagulant or any warfarin or something, we can do this APS-PT IgG, which can be used as a surrogate marker for lupus anticoagulant positivity. So our study was this is one of the summary of previous studies which has been done on APS. So this is the present study which we did in India, and number of cases was 65, and we found the correlation between APS-PT and LA as well. There's one other study by Ganapati et al. At CMC Vellore, but it was not a prospective study. It was just a retrospective study with a smaller sample size than compared to us, and there wasn't any LA correlation as well. And previous studies were also mostly of the retrospective type with those retrospective type, and it was not and in which they used Stoll's theorem to do the APS-PT testing, but ours was a one-of-a-kind prospective cross-sectional study in which we studied real-time patients and followed up. So APS testing can be including APS-PT in addition to the other classical antibodies will enable us to increase the diagnosis of APS with more sensitivity and specificity, and it can also be used as a surrogate marker for LA activity when LA testing is not feasible. And as I said before, the limitation was we didn't have any longer follow-up, like it was a 1-year study. And there was also an obstetric morbidity like preeclampsia and intrauterine gestation was not captured in our study. So it is a diverse manifestation. So to sum it up, the overall prevalence of APS-PT in our study was 53.9%. Addition of APS-PT testing to revise Sapporo criteria can reclassify additional 16.9% cases as seropositive APS overall. And it picked up 20% more of obstetric APS and 8.8% more of thrombotic APS. APS-PT assay can be considered as an additional serological marker for diagnosis of APS in addition to the classical APS test. And to improve the likelihood of diagnosis of APS, APS-PT testing needs standardization as different labs use different reference range. And these are my references. Thank you. Thank you, ma'am.
Any questions, Dr. Ajay Kumar and our respected judges?
What are the major target organs affected in Aplar syndrome?
So target organs, mainly if you take the thrombotic events, it can present as deep vein thrombosis of the lower limbs, and following which pulmonary embolism can occur. And also we are reporting major cases of stroke, young stroke patients. The young stroke are being diagnosed as antiphospholipid syndrome. So it can have a CNS manifestations and also.
Okay. Are you aware of two-hit theory of antiphospholipid antibody syndrome?
Sorry, sir?
Two-hit theory. Have you heard of name?
Two-hit theory. I mean, the patients who have any antibody positivity without any clinical manifestations are more prone to get these thrombotic events and obstetric complications. That thing.
No. Somewhat related with pathogenesis.
Okay, sir.
Okay. Thank you.
Thank you, sir.
Dr. Aishwarya, you can present your second topic and please kindly stick to the timeline.
Okay, ma'am. Ma'am, can I present after the? I'm not unable to open at the file, ma'am. I'll present after the next presentation, ma'am. Sorry, ma'am.
Okay, no problem. Thank you. Do we have Dr. Keshu Jindal with us?
No, ma'am, Keshu Jindal is not available.
Dr. Aditi Tripathi?
She is done with the presentation, ma'am.
Okay, then we can have Dr. Sudhiti Sharma.
Yes, she's there.
Good afternoon, good morning, everybody. Good morning, ma'am. Good morning, judges. Hello.
Your slides are not visible.
Yes, sir. Yes, sir. 1 minute, sir. Sir, actually, my apologies. I did not receive the mail regarding the presentation. Like, it went to my spam folder. So I don't have a PowerPoint presentation, but I have my paper. I have a case presentation, sir. So can I just present using that? Hello.
Yes, you may present.
Okay. Is my screen visible?
Yes, it is.
Yes, it is. So I'm presenting a case report of a rare presentation of duodenal ulcer, Valentino syndrome. So there was a 42-year-old male patient that came to our ER emergency department in Apollo Institute of Medical Sciences Research, Hyderabad, Telangana, with chief complaints of pain in the right iliac fossa since 4 hours and 1 episode of vomiting along with fever. His pain was sharp and sudden in onset and worsened on sudden movement. His Alvarado score was 8. Alvarado score is used to measure any case of appendicitis. This is the Alvarado score. So his Alvarado score came out to be 8. The patient had no such history in the past. The patient was a known case of alcoholic and a smoker with 2-year history of smoking. And the patient was taking NSAIDs for intermittent pain in the abdomen for the past 5 years. The personal history was not significant. On physical examination, there was localized guarding and tenderness. Localized guarding and tenderness was elicited in the right iliac fossa and epigastric region. In epigastric region, signs of ascites were present. Based on clinical findings, acute appendicitis was suspected. We did an ultrasound of the abdomen, and the right iliac fossa showed inflamed appendix measuring 6 millimeters in diameter with presence of mild to moderate ascites. These are the ultrasound findings for the patient. This is the ultrasound picture, and this is the report given to our radiology, given by our radiology department, AIMSR. So it showed fluid periappendicular fluid. So laboratory findings were performed and they were all within a normal range. And the surgical profile was done. And based on clinical findings, the patient was subjected to appendectomy. And there was a plan for laparoscopic appendectomy. On diagnostic laparoscopy, right iliac fossa was examined and 500 ml of fluid was seen collected in the right paracolic gutter with no signs of inflammation of the appendix. The fluid was green in color, indicating it to be bile stain, which hinted it to be due to upper gastrointestinal perforation. The laparoscope was reinserted into the epigastric region, and perforated ulcer was visualized in the first part of the duodenum. It was diagnosed to be a case of duodenal ulcer perforation. The laparoscopy was converted into laparotomy, and open Gram-Schwarz repair was done for the perforation with a midline incision. The fluid was sent for culture and sensitivity, and the edges of the ulcer were sent for biopsy after freshening. The post-op period was uneventful with IV fluids, analgesics, antibiotics, proton pump inhibitors, and the patient was kept nil by mouth with dry tube aspiration for 3 days. The patient's condition progressively improved over a course of 5 days and was started on a soft diet followed by a normal diet and was discharged on the 10th post-operative day in a stable condition. The histopathological examination showed features consistent with duodenal ulcer, with perforation showing acute serositis. These were the intraoperative images taken for the patient. And this is the histopathological report, which showed consistent with duodenal ulcer, showing acute serositis, the biopsy report. So now I would like to discuss that Valentino syndrome, rather conclude that differential diagnosis of duodenal ulcer perforation should be considered for adult patient with diagnosis of acute appendicitis. X-ray, erect abdomen, and diagnostic laparoscopy can help overcome the foot-and-mouth situation due to duodenal ulcer. Even though in this case we did perform X-ray, but we still couldn't. We should have perhaps performed a X-ray abdomen as well for this patient. That's all. That's all. Hello. Hello.
Hello. Hello.
Hello.
Dr. Sudhiti. Dr. Sudhiti.
Yes, sir.
Yes, you're audible. You're audible.
How will you differentiate between Valentino syndrome and acute appendicitis? Hello? Hello? Am I audible?
Yes, sir, you are audible.
My question is, how will you differentiate between Valentino syndrome and acute appendicitis? Hello, should I repeat the question? Hello.
Dr. Sudhiti, are you there?
Hello.
Hello.
Hello. Sorry, sir. Am I audible now?
Yeah, you are audible.
Yes, sir.
My question with you is, how will you differentiate between Valentino syndrome and acute appendicitis?
Valentino syndrome and acute appendicitis, sir. In this case, actually, we could have perhaps done a CECT abdomen, but since the clinically the features were pointing towards appendectomy and financial restraints of the patient. We straight up diagnosed it clinically as acute appendicitis, and we went ahead with the surgical procedure. But so in this case, sir, how we differentiated was because there was when we were performing appendectomy, there was it did not show any inflammation of there was fluid accumulation.
My question is general, because we routinely come across in emergency with acute appendicitis. So how will you differentiate? I am not talking about this case only. I am concerned with the general question.
Okay, sir, we should perhaps one way could be to take more thorough history. The patient did give complaints of, abdominal pain. In general, sir, we can take more thorough history. They could probably have signs and symptoms correlating with a gastric ulcer. And it could have history, it will have more history, whereas appendicitis will have a more acute onset. One, that could be and secondly, we could perform a CCT abdomen, sir. But since CCT abdomen may always not be feasible in an ER, in an emergency situation, but it could be considered, sir, if the patient is more financially equipped.
Okay. Thank you.
Thank you so much, sir.
So next speaker is Dr. Lokesh Kumar, a rare treatable cause of adult onset spastic paraparesis.
Am I audible?
Yes, you are.
Am I audible, ma'am? Hello?
Yes, you're audible. Please put in slides.
Okay. Is my slides visible, ma'am?
Yes.
Okay. So I shall proceed with the presentation. So welcome one and all. And in my case, there are treatable spastic paraparesis. So begin with our case history. So a 8-year-old male who is born out of 30 history, and he came with insidious onset, slowly progressed spastic paraparesis for the past 4 years. So initially at the onset, he noticed difficulty in getting up from squatting position, which was associated with stiffness of 2 years of the illness. Noticed difficulty in walking, particularly with slippage of slippers while walking with awareness. There is no history suggestive of sensory disturbance, no history suggestive of upper limb involvement, no history suggestive of bowel and bladder involvement or cranial involvement, no history suggestive of cognitive decline. There was no history of similar illness. So coming to our examination, so our general examination revealed marfanoid diabetes. The patient was tall and his span was 6 compared to the height, which was more than 1.05. And he has upper segment lower segment ratio was less than 0.6. And CNS examination revealed spasticity and exaggerated reflexes involving both lower limbs. And the power was grade 4, MRC grade 4/5 in both proximal and distal muscles. Symmetrically, abdominal reflex was absent. Patient was able to support. There was no normal bowel and sensory system examination was normal. Spine and cranium examination was normal. And ocular examination revealed ectopia lentis. So now we further proceed for investigations. Routine hematologic and biochemical blood tests were normal. Serology was done for human immunity virus and we was done ruling of syphilis, which was negative. And MRI spine was done, suspicion of thoracic spinal lesions, which was also normal. CSF analysis was done, which was also normal. CSF oligoclonal bands testing was done, which was also showed negative. And we proceeded to look central causes of spastic paraparesis. So we did an MRI brain, which revealed symmetric T2 or flare hyperintensity involved in the periventricular white matter of bilateral frontoparietal region. So this would be the MRI of the patient. It shows T2 and flare hyperintensities in the involving ventricular and deep white matter region, the frontoparietal regions. So our suspicion went on to rule out adult onset leukodystrophies because of the white matter lesions. So we did a clinical exon sequence testing, which showed a MTHFR gene mutation. So we did fasting plasma homocysteine levels, which are significantly elevated, 60, and normal was 3.3 to 11.3 micromoles per liter. So we started managing the patient with oral B12, 1,500 mcg per day, and folic acid and pyridoxine supplementation. And parents were advised for doing genetic testing. And the patient showed symptomatic improvement in continuous follow-up. Our take-home message would be a detailed physical examination aids in identifying inherited disorders, like considering this patient with this patient ectopia lentis and marfanoid diabetes, which will be in case of homocysteine. And central cause of spastic paralysis are a rare etiology, so MRI brain can be done to aid in the diagnosis. And white matter lesions usually in our setting we usually ignore periventricular white matter changes usually, but in a young patient with white matter lesion, it can be pathological. And a potentially treatable genetic condition like MTHFR mutation should be considered in case of spastic paraparesis. So we can measure homocysteine, which can be used as a screening tool for suspected MTHFR mutation disease in patients with non-compressive spastic paraparesis. Thank you.
Any questions, sir?
Dr. Lokesh, what is investigation of choice for adult onset spastic paraparesis?
Sir, adult onset spastic paraparesis, we can proceed with imaging, sir. So in this patient had a lower spasticity with no involvement of upper limb. So the lesion can be in a spinal lesion, can be put out 1 and above T9, this patient. So thoracic spine has to be evaluated for this patient.
Okay.
And since there was no finding in our MRI spine, so we proceeded with MRI brain. So central causes should be ruled out, like parasagittal meningia and AC territory aneurysm. These all should be ruled out.
Thank you, Dr. Lokesh.
Thank you.
So we move on to our next speaker. Do we have Dr. Meghna?
Yes, ma'am. I'm here. Hello.
Do we have Dr. Meghna?
Hello.
You can start with your presentation.
Yes, ma'am. Good afternoon, everyone. Today I'll be presenting a case report of on the topic interaction between HIV and inherited thrombophilia, fact or fancy. HIV infection is a prothrombotic condition with a 2 to 10-fold increased risk of venous thrombosis. Venous thromboembolism is a dynamic, multifactorial disorder which results from interaction between acquired and inherited factors. Risk factors for venous thromboembolism in HIV are opportunistic infections, protease inhibitors, CD4 count less than 200, malignancy. This case is being presented to highlight the challenge in achieving the optimal anticoagulation in HIV patients. Case summary: 29-year-old female, known case of treatment-naive retroviral disease since 6 years, disseminated tuberculosis on ATT for 2 weeks, presented with painful diffuse swelling of right lower limb. Later, she had developed abdominal pain, which was dull aching over right hypochondrium. There was no history of OCP usage. On examination, vitals were heart rate of 110, BP 90-60, pallor was present, pitting pedal edema noted with the swelling extending up to right thigh. Tenderness was present with no signs of inflammation. Peripheral pulses were felt. Our systemic examination was normal. Local examination showed shiny stretched skin, swelling of right lower limb extending up to thigh, and the circumference of right leg was 3.5 centimeter greater than the left. Tenderness was present over right calf region. All peripheral pulses were well felt. No redness or local rise of temperature was present. And the well score came up to 4. The score predicts the risk for DVT. Investigation showed anemia of hemoglobin 8.2. PT-INR was 14 and 1.2. APTT was 26. The major crux we found in managing the patient was patient's INR was very labile and it was difficult to maintain within the therapeutic range of 2 to 3. If the anticoagulation was withheld, INR would fall up to less than 0.5. But if with minimal dose of anticoagulation also, INR would be more than 5. CD4 count was 27. D-dimer was 2500 and ESR was 108. AV Doppler of right lower limb and CECT abdomen showed echogenic content filling the lumen of IVC, right common iliac, external iliac, femoral and calf veins. ECG and 2D echo was normal. Because of labile INR, we thought it was not just simple DVT and we went ahead with the coagulation study which detected homozygous for factor V laden mutation positive. There was also protein C and S deficiency. Normal antithrombin, lipoprotein A, prothrombin gene, lupus anticoagulant, IgG antibodies, anticardiolipin, and other factors were coagulation factors were normal. Patient was treated with elastocrine bandage, limb elevation, IV anticoagulants, and it was bridged to maintenance oral acinocumarol. And patient was discharged with advice to follow up. This is the AV Doppler of right lower limb showing the echogenic content suggestive of DVT. And this is the CECT abdomen showing the IVC thrombus. So in this patient described, DVT can be explained by several risk factors. HIV, CD4 count less than 200, that is, it was 27, tuberculosis and factor V laden mutation. Factor V laden is the most common hereditary thrombophilia. It is autosomal dominant condition that causes poor natural anticoagulant response in the presence of activated protein C. Therefore, it increases the risk for venous thrombosis. Untreated HIV replication causes alterations in the composition of extrinsic pathway coagulation factors, increase in procoagulants, that is factor 3 and 8, decrease in anticoagulants, that is antithrombin and protein C, due to systemic inflammation occurs with the net effect of increasing coagulation potential. So, take-home message is a safe index of suspicion for inherited thrombophilia should be maintained for HIV patients who present with thrombosis, especially in the absence of trauma, compression syndromes, or vascular bony anomalies, because it is found that incidence of factor V laden mutation in HIV patients is comparatively higher, that is 6 to 8% compared to the normal population. And prompt investigations and treatment with anticoagulants halts the progression and complications of thrombosis. Thank you.
Yes. Dr. Meghna.
Yes, sir.
How will you test for inherited thrombophilia and what are common signs?
Sir, inherited thrombophilia, if patient is not on anticoagulants, we can check for protein C and protein S levels, sir. And other factor levels like factor 3, 8, 7. If we are suspecting mutation, then genetic analysis and mutation and genotyping is required, sir. For in factor V laden, we send for blood sample for testing mutation in the factor V laden.
Okay, thank you.
Thanks.
So the next speaker is Dr. Ritesh Babu. Do we have Dr. Ritesh?
Yes, I'm Ritesh. So I'm sharing you my screen. Okay, is my screen visible to you all?
Yes, it's visible.
Okay, thank you. Good morning. So I'm Dr. Ritesh, currently doing my internship in Hyderabad. So during my internship, I came across this very interesting case, which is topical steroid-induced Cushing syndrome with HP axis suppression, which result in secondary adrenal insufficiency in a young adult. So coming to the case, 22-year-old male presented with dizziness, blurry vision, and loss of appetite, which became significant during the last week. And his vital signs were like 90-70 mmHg, blood pressure, pulse rate 110 beats per minute, temperature is febrile. On examination, he's having purple abdominal striae. Patient denied any kind of oral steroid usage, which was a key point. So coming to his past medical history, 7 months back, he had a ring-like lesion on his thigh. So he used topical clobetasol on and off for a period of 7 months. And his lesion, he noticed a significant increase in his lesion and number, along with an unusual increase in weight from 50 to 70. So 2 months back, he was diagnosed with tinea incognito, and exogenous topical steroid-induced Cushing syndrome was prescribed oral itraconazole for tinea incognito and stopped topical clobetasol. So his recent laboratory investigations are like low cortisol and low ACTH levels. And ACTH stimulation test showed an increase in serum cortisol level. So we came to the diagnosis that it might be an exogenous topical steroid-induced Cushing syndrome with HP axis suppression, which resulted in secondary adrenal insufficiency in a young adult. So we started him on tablet hydrocortisone for 20 days, followed by gradual tapering of the dose to correct his HP axis. So there is also a theory, itraconazole increases methylprednisolone concentration markedly with enhanced suppression of endogenous cortisol secretion, but has no effect on prednisolone pharmacokinetics. So the pharmacokinetic interaction between methylprednisolone and itraconazole is probably related to the inhibition of hepatic CYP3A4 activity by itraconazole. So topical steroid-induced Cushing syndrome with HP axis suppression is a very common phenomenon in children and newborn, but is a very rare complication in adults. Sudden cessation of steroids causes HP axis suppression, but there is also evidence of itraconazole-induced HP axis suppression. It seems reasonable to consider that suppression of endogenous cortisol is related to the effect of corticosteroids, but might also be due to an added effect of itraconazole. So my take-home message is, considering the rarity of topical steroid-induced Cushing syndrome in an adult and easy accessibility of over-the-counter steroid creams, the motive of writing this case is to bring awareness to potential topical corticosteroid overuse and take appropriate measures to prevent significant consequences. Thank you. So, any questions?
Dr. Ajay, sir, any questions?
No question from my side.
Okay, thank you, sir.
Thank you.
Thank you. Now we move to our next presentation by Dr. Nisha.
Yes, ma'am. Hello, ma'am.
Yes, you're audible.
No. Hello.
Yes, you're audible.
Yes, ma'am. I'll share the screen.
Yes.
Is it visible, ma'am?
No, your screen is not visible. Your screen is visible?
Yes, ma'am. Good afternoon, everyone. I'm Dr. Nisha, and I'll be presenting a case report on cryptococcal inflammatory pseudotumor, a clinical curiosity. Cryptococcosis is a systemic infection caused by encapsulated yeast-like fungus, Cryptococcus neoformans and gatii. Its ecological niche appears to be soil or bird excreta. The route of entry of organism is via inhalation, and the risk factors include AIDS, CD4 count of less than 100, prolonged treatment with glucocorticoids, organ transplantation, malignancy, liver disease, and sarcoidosis. Coming to the case report, a 29-year-old female, case of treatment-naive RVD since 6 years with disseminated tuberculosis on ATT for 2 weeks with extensive DVT of right lower limb on oral anticoagulants, presented with painless progressive subcutaneous mass on her left thigh. On local examination, the isolated swelling measuring 14 into 8 centimeter was noted on the posterior aspect of left lower thigh, firm in consistency with no signs of inflammation. Skin over the swelling was not pinchable. On examination, vitals were stable. Systemic examination showed a decreased air entry on the right inferior axillary and infrascapular area with fine inspiratory crepitation. The rest of the system were within normal limits. So a differential diagnosis of organized abscess and organized hematoma or soft tissue swelling was kept in mind. Blood investigations done showed anemia with a CD4 count of 27. Blood for bacteriological and fungal culture was negative. Ultrasound scan of soft tissue showed diffuse subcutaneous edema. FNAC was done, which showed mixed inflammatory infiltrate composed of lymphocytes, few neutrophils, histiocytes, and granulomas with fungal elements arranged in sheets, clusters, and scattered singly, resembling Cryptococcus. This is the H&E stain, which shows oval encapsulated organism, and this is the periodic acid skip stain. The GMSA stain and PAS stain was suggestive of round to oval encapsulated organisms morphologically resembling Cryptococcus. Serum cryptococcal antigen was positive. CSF study was negative for Cryptococcus. Patient was started with amphotericin for 2 weeks, and she was discharged with oral fluconazole 400 milligrams per day for 8 weeks, following which the size of the swelling had reduced during her follow-up. Cryptococcosis can manifest as cutaneous lesions in 10 to 20% cases of disseminated disease. Non-meningeal and non-pulmonary cryptococcosis generally reflects disseminated infection, even if clinical manifestations are confined to a single anatomical site. There are no studies evaluating treatment of cryptococcal infection involving sites other than lungs and CNS. In general, infection at a single site in the absence of CNS disease, fungemia or risk factors for immunosuppression may be managed with fluconazole 400 milligrams, that is 6 milligrams per kg orally once daily, for 6 to 12 months. Cryptococcus manifesting as soft tissue swelling should be diagnosed, and it should be treated as early as possible in an immunocompromised patient to avoid further dissemination. Screening for disseminated cryptococcus with serum cryptococcal antigen should be carried out in all individuals with advanced disease and with CD4 count of less than 200. Thank you.
Hello.
Hello, sir.
Dr. Meghna, how one can get infection of Cryptococcus? How it spreads?
So the route is inhalational route is the most common route, sir, of infection. And the conditions like other immunocompromised states can also predispose to Cryptococcus, like HIV or other immunocompromised like diabetes. If the patient is on steroids or any malignancy which can cause immunosuppression, makes the patient prone for infection.
I think mode of spread you have told is not justified.
Sorry, sir?
Mode of spread is something else.
Inhalation, sir.
No. Contact with pigeon droppings.
That is bird excreta, and the aerosols are responsible, sir.
Okay. Thank you.
Okay.
So moving to our next presentation by Dr. Justin.
Yes, madam. Hello, I am audible?
Yes, you're audible.
My screen, are you able to see my screen?
No.
Now, madam?
No, your screen is not visible.
You are not allowing my screen to share? Madam, hello? Hello, you are not allowing me screen to share, madam.
Yes, sir. Please share your screen.
Yeah, video has come, but yeah. Are you able to see my screen?
Yes.
Yeah. Thank you. Good afternoon, everyone. My presentation is neurological spectrum of post-COVID rhino-orbital cerebral mucormycosis, an observational study in a tertiary care center in South India. Introduction: COVID-19 has spread worldwide since December 2019. In India, the peak COVID-19 infection in April 2021 was paralleled by an outbreak of rhino-orbital cerebral mucormycosis, ROCM, a fulminant angio-invasive fungal infection involving various neural axes. In COVID-19 pandemic, along with steroid as a therapeutic armamentarium, in association with diabetic and irrational use of antibiotic, make the land fertile for fungal growth, as evidenced by the recent surge of mucormycosis, which mostly entangles the sinuses, orbits, and brain. Introduction: mucormycosis depends on the organs involved. It's a further subclassified as rhino-orbital cerebral mucormycosis, which is most commonly observed, followed by a cutaneous, pulmonary, disseminated, renal, and gastrointestinal involvement. The association between the COVID-19 and mucormycosis is already established, but the presence of two important confounders, diabetes and indiscriminate use of steroid, make it difficult in establishing the exact cause and effect relationship. SARS-CoV-2 virus itself has been implicated in disruption of the cell-mediated immune response, leading to invasion, tissue necrosis, and thrombosis by mucormycosis. Introduction: studies depicting the clinical feature of ROCM and pattern of neuroaxis involvement along with its radiological correlates fall short of their actual need. These are of utmost importance in aiding early diagnosis, predicting the natural history of ROCM, and skewing towards the favorable outcome. The study here intended to show the entire neurological spectrum of ROCM and its radiological correlates from a tertiary care center, Madurai. Aim of our study is to provide an overview of the pattern of neuroaxis involvement and clinical radiological correlation in post-COVID rhino-orbital cerebral mucormycosis cases. Method: we systematically reviewed 100 patients diagnosed with post-COVID ROCM admitted to the hospital during April 2021 to June 2021. Data pertaining to the clinical radiological features were analyzed using percentage of total cases. Our results are: out of 100 patients, the clinical manifestations include headache in 90% and facial pain in 88%, and ophthalmoplegia in 87%, and loss of vision in 85%, and proptosis 85%, dizziness 60%, cerebrovascular accident 24%, seizures in 20%, encephalitis in 3%, and the radiological profile suggestive of cranial nerve involvement in 45%, early cerebritis in 40%, cerebral abscess in 25%, cavernous sinus thrombosis in 20%, and ICA stenosis in 16%, the cerebral infarct in 9%, and leptomeningeal enhancement in 6% of the patients. Here, this is an axial 2-to weighted images of diffusion weighted and ADC mapping showing the MRI of the patient, showing the T2 hyperintensity, with the diffusion restriction and the right basofrontal cerebral abscess. Right basofrontal cerebral abscess. And this is a T1 axial section showing the MRI showing the hypointense mucosal thickening of the left ethmoidal cells. And post contrast, T1 shows the heterogeneous enhancement of the periorbital soft tissue and infraorbital lesions. And it's an axial T1 post contrast showing the ring enhancement, nicely seeing a ring enhancement with axial diffusion weighted, and ADC showing the diffusion restriction in the periphery with the intracavitary projection in the right temporal lobe. So, discussion, our observation revealed middle-aged 40 to 60 years of male and the rural and middle class population were most affected. 88% of the subjects were found to be diabetic at the time of diagnosis of mucormycosis. Majority had a history of hospital admission and more than half were treated with oxygen. More than half of the subjects who had anosmia associated with SARS-CoV-2 later developed ROCM, which might suggest some intriguing relationship with the route of entry through nasal of the mucormycosis spores. Conclusion, neuroaxis involvement was characterized by the multitude of features pertaining to the involvement of the cranial nerve, extraocular muscles, meninges, cavernous sinus, brain parenchyma, and internal carotid artery. High index of suspicion is required to ensure timely diagnosis and appropriate treatment in high-risk population to prevent high mortality. These are my references. Thank you, sir. Hello?
Hello.
Yes, sir.
Very nice presentation, sir. Compliments to you.
Thank you, sir.
I just want to know that this data is published or still.
Sir, it's in the process, sir.
Okay, sir. Okay. Congratulations and best wishes, sir.
Thank you very much, sir. Thank you, sir.
Thank you, sir.
Thank you, madam. Thank you.
Our next presentation will be by Dr. Firdaus Jabin.
Hello. Yes, ma'am. Am I audible?
Yes, you're audible.
Okay. Actually, there is no option for sharing screen because previous one is working, I think. Is my screen. Where is my file? My screen is sharing or not? Ma'am?
No, your screen is not visible at present.
1 second, ma'am, please. Showing is not. My screen is showing or not, ma'am?
No, at present it is not. Your screen is not shared.
Hello. Ma'am, there is a below. Please click on that. Is it showing?
Yes.
In terms that
ये visible नहीं हो रहा है उधर नहीं ये visible नहीं हो रहा उस side
शेयर स्क्रीन जूम है कहाँ है जूम
अरे ये है ये
कर्सर लगे शेयर बस हो गया
Your screen is visible now.
Okay, ma'am.
please put it on slideshow mode.
Very good afternoon, ma'am. My topic is prognostic evaluation of clinical frailty index in hospitalized moderate to severe geriatric COVID-19 patients. First of all, introduction. The first case of coronavirus disease 19 caused by the novel coronavirus SARS-CoV-2 were first identified in Wuhan, China. The disease spread rapidly and reached the criteria to be regarded as a pandemic in March 2020. COVID-19 affected people irrespective of age, but older patients aged greater than 65 years with or without comorbidities had the highest mortality rate. Severity of COVID-19 was higher in the older people, which might be due to the physiological changes that occur at this age. Apart from this, older patients were more susceptible to other clinical conditions, including sarcopenia, cognitive decline, and frailty, which not only aggravate the disease but also contributes to the negative progression of disease. Then what is frailty? Frailty is defined by the World Health Organization, a progressive age-related decline of body functions resulting in vulnerability and reduced resilience to physical and mental stressors with an increased risk of negative health outcomes. A simple prognostic factor is needed to inform acute decision on COVID-19 care pathway in older patients, and one potential marker is frailty. Frailty can be assessed using the various approaches such as a clinical frailty scale and frailty index lab. These are the two measures used to quantify chronic and acute health status respectively. A chart review and face-to-face assessment with patients and families used to determine the clinical frailty scale. Scale ranges from 1 to 9. Recently, laboratory frailty index has been proposed, which is based solely on biomarkers and general biochemical hematological parameters. Then aim to find out the association of clinical and frailty index lab with outcome in elderly population, which was hospitalized in COVID-19. Then objective of my study was to assess the frailty index by clinical frailty scale and FI lab 21 in hospitalized geriatric patients to compare the applicability of clinical frailty scale and FI lab 21 for predicting the outcome. Then material and method. Type of study was prospective, observational, and type setting COVID-19 patient admitted to HDU and ICU of ERA Lucknow Medical College and Hospital. Study participant was the moderate to severe COVID-19 patients with age greater than 65 years. Inclusion criteria was after informed consent. All the consecutive moderate to severe COVID-19 patients age greater than 65 years proven by RT-PCR, and inclusion criteria was none. We prospectively selected the 100 cases of COVID-19 having the age greater than 65 from the ERA Lucknow Medical College and Hospital respectively. COVID-19 diagnosis was clinically confirmed by the positive reverse transcriptase polymerase chain reaction test. Patient data were extracted from the electronic medical records, which included the clinical frailty scale. In hospital mortality and home discharge were followed up for the 28 days. We assessed the association between the clinical frailty scale and outcomes in the geriatric COVID-19 patients. The study showed the frailty is associated with age and comorbidities. Among the 100 cases, 46% cases were mild to moderate frail with mean age was 70, in which 6 patients were with no comorbidity. 33% cases were severe frail with mean age was 78, in which no one with the comorbidity. 21 cases with non-frail with mean age 66, in which 12 patients with no comorbidity. Severe frail COVID-19 patients were significantly older than the mild to moderate frail and non-frail. Patient with expired outcome had the higher FI lab 21 score as compared to alive cases at the admission as well as discharge. Differences between in FI Lab 21 scores of alive and expired cases was not found to be significant at the admission. A significant decline in FI Lab 21 score of alive cases was observed at the discharge, while among the expired cases, a significant increment in FI Lab 21 score was observed at the discharge. Then conclusion, our result add the evidence that the moderate to severe geriatric COVID-19 patients with severe frail COVID-19 patients were significantly older than the mild to moderate frail and non-frail. In addition to age, comorbidity in the frail patients is a useful predictor of short-term COVID-19 outcomes in geriatric patients. Level of frailty was significantly associated with comorbidities. Proportion of severe frail cases was maximum, followed by the mild to moderate frail and minimum non-frail having comorbidities. There is a significant association of frailty and outcomes in the geriatric COVID-19 patients. Thank you. Hello, ma'am.
सपोर्ट मिल जाएगा तो
हेलो
जी सर.
Dr. Firdaus, nice presentation. Have you tried for publication of this study?
Yes, sir, in process.
Okay. Thank you.
जी, thank you, sir.
Thank you. So we have our judges for the next session, Dr. Wahid Khan, Dr. Kanksha Rastogi, and Dr. Dishank Patel. So we can start with the next presentation by Dr. Justin, a case series of cerebrovascular accidents, clinical radiological correlation.
Yes, madam. Good afternoon. Are you able to see my screen?
Yes.
Yeah. Good afternoon, everybody. My topic is back to basics, a case series of cerebrovascular accidents, clinical radiological correlations. Background: stroke is a leading cause of morbidity and mortality and most common neurological reasons for hospitalization worldwide. A stroke is an acute compromise of the cerebral perfusion or via vasculature. Approximately 85% of the stroke are ischemic and rest are hemorrhagic. The clinical localization based on the symptomatology, when done appropriately, has got utmost significance. Any neurological diagnosis which is correlated radiologically in majority of the cases. Aim and method. Aim is to highlight the importance of clinical localization in stroke and its radiological correlation. Methods. This is the hospital-based cross-sectional study of patients with the CVA with unique clinical feature conducted at Madurai Medical College, Tamil Nadu between the April 2022 to May 2022. The study included 20 patients who were presented with stroke. Detailed analysis of their clinical features were done to localize the territory involved and correlated radiologically. Results. Out of 20 cases, 13 were ischemic stroke and 7 were hemorrhagic strokes. Out of 13 ischemic stroke, we had 2 cortical risk drop cases with infarct in the precentral gyrus, otherwise called hand knob area, and 2 frontal opercular syndrome, that is Fox-Giovanni-Meri syndrome. 1 case with complex visual hallucinations with hemianopia, hemifield, secondary to temporo-occipital stroke, Charles-Bennett syndrome. Justman syndrome because of the left parietal infarct. 1 pseudo-orthotic hand with thalamic pain syndrome, otherwise called thalamic degenerative syndrome. 1 is lateral medullary syndrome. And right motor neglect with verbal perseveration with left frontoparietal temporal infarct. 1 case of Wernicke's aphasia. 2 right hemiparesis with Broca's aphasia with infarct in the left perisylvian network. So results. Out of 7 hemorrhagic strokes, we had 1 Justman syndrome, 2 cerebellar hemorrhage, 3 capsuloganglionic bleed with dense hemiplegia, 2 cerebral venous sinus thrombosis with bilateral lateral rectus palsy secondary to raised ICT. So this is the motor knob area. It's an axial section showing a diffusion vector image showing a restriction in the right hand knob area. Hand knob. This is the axial section of diffusion vehicle showing the restriction in the left temporo-occipital region, cortex. And this is the axial section showing the watershed infarct, showing the diffusion restriction in the left angular gyrus, producing the Justman syndrome. And this is the bleed, the CT scan showing the bleed in the left angular cortex, that is Justman syndrome, and the CT scan showing the bleed in the right capsular ganglionic region. And another CT scan showing a bleed in the left cerebellar cortex. So discussion, stroke has been reported to be a second largest cause of death worldwide and the third most common cause in the first world countries. There is no cost-effective curative therapy for stroke, and the bulk of the public health initiatives are focused on prevention. In present study, 20 cases of stroke were studied during the hospitalization. All cases were primarily diagnosed by the clinical examination. Blood investigation were done. All the patients were subjected to this brain imaging to differentiate an infarction from the hemorrhage. So discussion, the present study mean age of the patients was 49.92, that is 50 years, with maximum age incidence was between 40 to 80 years of age. This result is comparable with the Indian study of Huxing et al. At 2001, having a peak age incidence of 41 to 80 years of age with a mean age of 58 years. So Indian study Dalal et al. 1968 reported 23.6% of incidence of young stroke, which is almost equivalent to the present study result of 20 to 20% incidence. Male are more frequently affected than female. The present study result shows that male to female ratio is 2:1, which is comparable with the Singh et al. Study. Results of male to female is 3:1. Incidence of TIA as a forerunner of permanent stroke is between 13 to 15%, and the recurrence of stroke is 7 to 23%, which is comparable with the present study results of 12% and 8% respectively. Discussion. In this study, cerebral infarct 65% cases predominate over the cerebral hemorrhages 35%. These results were comparable with the study results of the Huxing et al., which is 61% and cerebral infarct and 38% in the cerebral hemorrhages. Thus, to summarize, the study has shown that clinical methods along with the radiological investigations were useful to physicians in differentiating the probable cause of stroke versus cerebral infarct or hemorrhage. So stroke is not uncommon in our setting, associated with the significant morbidity and mortality confounded by the delayed diagnosis and possibly by less accurate etiological and clinical diagnosis. A detailed clinical history and examination is the key for the clinical localization, and if done systematically, correlates with the radiological features in almost all cases. These are all my references. Thank you.
I think Dr. Justin, very good study. Myself, Dr. Dishank Patel.
Yes, sir.
Just one question. How did you select the 20 patients? The selection was based on the certain dates in which
no,
all
sir,
the patients.
1 month of admission, we have categorization. We have did categorization. Which patients the admission day in our ward, we have admitted in our ward. We have analyzed who are all the patients having an infarct, who are all the patients having an hemorrhages. Then we have analyzed by clinical examination where is the exact localization, where is the artery involved, which artery is involved, where exactly the anatomical localization by clinical examination. Then we correlated with the imaging studies, whether it is correlated with. That is our studies.
Okay, thank you.
Sir, this is Dr. Wahid Khan. So
Yes,
first you did the CT scan or first you did the clinical?
Sir, first we did the clinical examination, then we did the CT scan to rule out the hemorrhage or infarct. If we are not able to pick up the infarct in the CT, then we did an MRI.
Was there any specific parameter in clinical examination which could differentiate infarct from a hemorrhagic stroke?
Sir, this basically if other factors like if it is there is an altered sensorium, if the gaze preference is there, and if there is a history of headache and vomiting is there, then it's more for favor for a hemorrhagic stroke. Otherwise, he'll go for an infarct. So how he is clinically presentation? What is the time of onset? Whether it is an awakening stroke or it is during the bedtime he developed or he is working on the spot, he developed immediately the stroke. Based on this only we are categorized on clinical grounds.
Thank you.
Thank you, sir. Shall I go for a second case, sir?
Yes. I think.
Yes, sir.
This is my second presentation. This is a paraneoplastic cerebellar degeneration. Paraneoplastic syndromes are a group of manifestations seen in patients with systemic malignancies. Underlying mechanism of these syndromes could be...
Sorry, we cannot see your screen.
Justin, your screen is not visible.
Oh, sorry. Just a minute, madam. Just a minute. Yeah. Are you able to see my screen, madam?
Yes.
Yeah, sir. Sorry for the interruption. Paraneoplastic syndrome are a group of manifestations seen in patients with systemic malignancies. Underlying mechanism of this syndrome could be hormonal caused by the active protein or autoimmune caused by the cross-reacting antibodies. Paraneoplastic cerebellar degeneration is one of the paraneoplastic neurological syndrome caused by the immune-mediated injury to the cerebellar Purkinje cells. It is associated with multiple malignancies, but most commonly we see with breast and pelvic malignancies, Hodgkin's lymphoma, gastric cancer, prostatic cancer, and small cell lung cancer. PCD is an inflammatory autoimmune process that occurs due to the destruction of the cerebellar Purkinje fibers by the onconeuronal antibodies which are produced in response to the cerebellar degenerated related protein 2 expressed by the cancer cells. There are no clear studies to conclusively prove that paraneoplastic antibodies are pathogenic. However, they are useful markers of autoimmunity to categorize the peripheral nervous system subtypes. 3 antibodies, anti-OIO and anti-DIA and anti-metabotrophic glutamate receptor 1 predominantly associated with cerebellar dysfunction. The index case highlights the need to look for a paraneoplastic syndrome to discover the malignancy, to address the distressing symptom for the patient relief if the malignancy is not curable. See, 48-year-old female presented with 6 months history of diplopia, ataxia, and dysarthria and dysphagia. She was shown to have an hypertension, diabetes mellitus. Neurological examination revealed intact language and cognition, significant bilateral diplopia and nystagmus. Although she was unable to stand or walk unattended, there was no muscle weakness. She had generalized hypotonia with intact deep tendon reflexes. Post-binding dysdiadokinesia, finger-nose incoordination, and positive heel-knee tests were elicited. She was found to have been prominent downbeating nystagmus, cerebellar overshoot with smooth pursuits, severe cerebellar dysarthria, profound truncal and gait ataxia. Routine laboratory workup was unremarkable. Ultrasonogram abdomen showed well-defined hypoechoic lesion in the right adnexa. MRI of the brain demonstrated diffuse cerebellar atrophy. CT scan abdomen was done which showed an ill-defined lesion in the right adnexa with separate enhancing nodule along the small bowel lobe. Ultrasonogram breast was normal. CSF analysis showed positive anti-OIO antibodies with normal protein and sugar. Serological paraneoplastic panel was sent and showed anti-OIO2 positive by immunoblot method with Casper positivity. CA125 was significantly elevated. Biopsy of the right adnexal lesion revealed high-grade adenocarcinoma of the right ovary. In view of clinical profile and investigation finding, patient was diagnosed to have a cerebellar atrophy secondary to paraneoplastic etiology. Patient was started on high dose of methylprednisolone and intravenous immunoglobulin 2 grams per kg given over the period of 3 days along with her chemotherapeutic drugs. Her diplopia and dysmetria were slightly improved. Patient was transferred to the rehabilitation facility for the continuation of the palliative chemotherapy. This shows an cerebellar atrophy. T2 axial shows an diffuse cerebellar atrophy. Discussion. The patient here when described had a PCD as a first manifestation of the ovarian adenocarcinoma. Hallmark of a PCD is a severe loss of cerebellar Purkinje fibers with relative preservation of other cerebellar neuron. Out of 9 antibody, Purkinje cell cytoplasmic antibody type 1, also known as anti-OIO, is highly specific and most frequently detected autoantibody. PCD treatment includes tumor treatment, immunotherapy, supportive therapy. Treating the tumor as soon as possible is the best approach for stabilization or symptom improvement with or without immunotherapy. Immunotherapy include steroids, IVIG, plasmapheresis, cyclophosphamide, azothioprine, and finally rituximab. Multiple studies shown that patients with the anti-viral antibody have a worse neurological prognosis, with most becoming bedbound within 3 months of diagnosis, compared with PCD patients with the other antibody types. However, immunotherapy have been reported to be effective in some cases, and hence the trial of IVIG, steroids, and plasmapheresis is indicated. Our patient with the anti-viral antibody associated with PCD experienced a clinical improvement with some in her neurological symptom after and stabilization of the other symptom with the high dose of steroid and IVIG. However, her relief was partial since her primary cancer was advanced and her treatment were limited. Our patient, the PCD significantly affected her quality of life, while the melaninosis was largely asymptomatic. So, in conclusion, paraneoplastic cerebellar degeneration is characterized by the degeneration of the cerebellar Purkinje's neuron. Several antineuronal antibodies were implicated in this degeneration, including YO and HURI and MA. Anti-YO antibodies particularly has been linked to the ovarian and breast cancers associated with the cerebellar degeneration. Studies have been shown that 88% of the patients with paraneoplastic cerebellar degeneration express high titer of anti-YO. Despite successful treatment of the primary tumor, in many cases, paraneoplastic symptoms often continue to be negatively impact the patient's quality of their life, more so than the underlying tumor. This signifies the importance of the early diagnosis, as delay in the start of treatment can lead to the rapid progression and the irreversible neuronal damage. Thank you, sir. These are all my references. Hello.
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 Hi, Dr. Kanksha this side.
Yes, sir.
So, Dr. Justin, it's a very interesting case. So one
Yes,
thing I
ma'am.
wanted to know, like the patient, you said there was a partial improvement in her neurological symptoms. So
Yes, ma'am.
how significant the improvement was and how early it happened with the IV steroids and the IVIG?
After IVIG, after a period of 2 weeks only, he started showing improvement in the form of this dysdiagonality and tremors were reduced. And this eye movement abnormality also a little bit reduced. But other disability is walking and other things, the ataxia is same. It is not improved in the ataxia and other, because the malignancy was so advanced, because we are catching on the tail, leaving the head. Already it has gone over.
Was it a partial improvement? It lasted temporary with the steroids and IVIG, or it stayed there for a longer time? Did you follow up that case?
So, madam, he is on the follow-up with the oncology department now. Okay. We have to follow up. We have to follow up.
Okay, fine.
Thank you. Thank you very much. Thank you, sir.
Thank you, sir.
Thank you, madam.
So our next presentation will be by Dr. Alia Abdul Jabbar. Is Dr. Alia there?
She's not available, ma'am. Ma'am, she is not available.
Okay, so we proceed to our next session by Dr. Koduri.
Hello.
Yes, you're audible.
Yeah, okay. Hello, is my screen audible, ma'am?
Yes, your screen is visible.
Okay. Okay, good afternoon, everyone. I'm here to present a case report of an unusual case of pituitary hyperplasia in primary hypothyroidism, which ended up in a rare complication. Coming to the introduction, pituitary hyperplasia is an under-recognized manifestation which usually presents in primary hypothyroidism, almost incidence being 25 to 81%. It usually occurs due to the negative feedback which occurs on the pituitary and the hypothalamus due to the hyperplasia of the lactotrophs and as well as the thyrotrophs, which leads to the elevated TRH, ultimately resulting in the elevated TSH. So this presentation and imaging can mimic a pituitary mass. As coming to the mechanism, as I've already mentioned, it is mostly due to the thyrotroph hyperplasia. Though they comprise even 5 to 10% of the entire pituitary, during the hyperplasia, they increase up to 34%, being visible as a pituitary mass. Coming to the history, our patient is a 16-year-old female who presented to the OPD with complaints of delayed menarche, short stature, amenorrhea since 2 months, and galactorrhea. Patient was diagnosed a case of hypothyroidism, and she was on treatment with tablet Thyronorm, which is thyroxine, 100 mcg. But the patient is on irregular follow-up. And we have done the investigations, which include TFT, a thyroid function test with the TSH, T3 and T4, FSH, LH, serum prolactin, growth hormone, ACTH, cortisol. To rule out the other causes of the amenorrhea, we have also obtained an OBG opinion suspecting to rule out physiological causes like pregnancy, where the UPT turned out to be negative, and also the ultrasound abdomen showed no sonological abnormality. So patient was also given a trial of tablet registrone, which is nothing but progesterone, to see for any withdrawal bleeding, but she has not responded to that treatment, hence ruling out our gonadal causes also. Coming to the clinical case findings, the thyroid function test showed an abnormally elevated TSH levels, whereas the all other hormones like FSH, LH, GH, and all other cortisol hormones were found to be in normal limits, whereas the serum prolactin was elevated. This has also, since all other hormones were in the normal limits, it also has ruled out our primary pituitary tumor or an other cause which would have caused this. Coming to the MRI brain, it showed a diffuse homogeneous enlargement of the pituitary gland, almost of size 13 into 14 into 10 mm, typically showing a nipple sign, which is rather suggestive more of the hyperplasia rather than an adenoma. Here we could see the nipple sign on the MRI brain. Coming to the treatment given, but we couldn't confirm it to be a hyperplasia and ruled out adenoma solely based on MRI brain. Contrast has to be done, but the patient is not affordable. Coming to the treatment given, patient was continued on thyroxine replacement therapy, now on a strict regular follow-up, and we have followed up the patient on a regular basis, and almost after 2 to 3 months, when we have done to see if the hormonal levels have been normalized, but the repeat TFT has showed the low TSH, T3 and T4, only with prolactin levels being normalized, and all other hormonal levels turned out to be low. And repeat MRI brain was done to see if there is any shrinkage in the size of the mass, but it remained the same in spite of the regular follow-up being done to the patient. So generally, if the pituitary hyperplasia occurring to the secondary to the primary hypothyroidism usually regresses with the thyroxine therapy and follow-up, but in this case it has remained the same. So the only explanation could be the long-standing hyperplasia would have led to the structural abnormality leading to the hypopituitarism. That's why the repeat GH, cortisol and the other hormones have become low, whereas the starting they were normal. So this is one of the rarest complication we could have seen, almost incidence being less than 5%. So my take-home message being, we have to be aware of the pituitary hyperplasia occurring even to the secondary to the causes like primary hypothyroidism, and medical management should be preferred first to avoid unnecessary surgery like adequate hormonal replacement, and patients also should be need to be educated regarding the regular follow-up for the adequate treatment and also to early diagnose the disease. Thank you.
Thank you, Dr. Koduri. I would like to know, Dr. Dishang Patel, like to know in this case, what happened to the symptoms of the patient after you correctly started the dose of the thyroxine and once the TSH became normal? Whether they persisted or they...
Yes, sir. The symptoms like amenorrhea and galacturia became normal, but she also presented with short stature and all, which showed no improvement. TSH is not normalized actually, it has become low. It could also be due to iatrogenic drug induced. So we have suspected hypopituitarism since there's no improvement in other symptoms. And hyperprolactin also ruled out since prolactin levels are normal and galacturia has been decreased.
So, Dr. Koduri, so do you recommend, Dr. Vahe there, do you suggest that all cases of primary hypothyroidism at that first time of diagnosis, we go ahead and go for an MRI to avoid this pituitary hyperplasia?
No, sir. Primary hypothyroidism may not present every time with hyperplasia, but if the patient is has not regressing the symptoms, or if she has presented with any other symptoms, like in this case she's on irregular follow-up also, so that is why we have and also other symptoms like short stature and all, that's why we have followed up with an MRI brain which showed a pituitary hyperplasia.
So, Dr. Koduri, did we also do a visual perimetry in this case?
Yes, ma'am. Visual perimetry is also done where the vision was normal. Fields were also normal for the patient, and the patient has no complaints of blurring and all. So we have ruled out any compression of optic chiasma.
Okay. And how long did we follow up this case? I mean, how frequent MRI images were repeated?
An MRI was done after every 2 months. This was the image I'm showing you after the 4 months. Usually, pituitary hyperplasia regresses within 2 to 4 months of continuous thyroxine therapy initiated on regular basis. But this patient has not regressed in size. Hence,
I think it's a very well presentation. People should have the insight of this condition, and the hasty surgeries can be avoided in such a case. That's an important thing here, especially for the gynecologist. Also, they should have this thing in mind.
Yes.
Yeah, one thing is not, I think I missed or not clear, I don't know. But when the TSH became normal or low, still the T3, T4 level were low. You presented like that? T3, or they became normal?
Sorry, sir, I couldn't hear you properly.
You mentioned in one slide that the TSH was low and T3, T4 were also low after you started the treatment.
Yes, sir.
So that means the hypothyroidism status was not completely restored after starting the thyroxine replacement.
The higher levels of thyroxine have become low. It could also be due to iatrogenic. So drug is actually working there. We have only suspected this condition because the GH and ACTH levels have also become low. So that's why we have suspected hypothyroidism.
Okay. Okay, great.
Yeah, thank you. Thank you.
Okay, thank you.
So our next speaker will be Dr. Zeenat Usmani.
Yes, ma'am. Ma'am, am I audible?
Yes, you're audible.
Ma'am, shall I start?
Yes, and kindly stick to the timeline.
Sure, ma'am. Good afternoon, everybody. My topic of the presentation would be serum pesticide levels in obese and non-obese subjects with type 2 diabetes mellitus in a teaching hospital of North India. This study titled Serum Pesticide Levels in Obese and Non-Obese Subjects with Type 2 Diabetes Mellitus in a teaching hospital of North India was conducted in Department of Medicine, Eras Lucknow Medical College and Hospital to assess whether there is an association between serum pesticide levels and BMI in patients with type 2 diabetes mellitus. The study protocol was cleared for this ethics by Research Institutional Review Board. It was a cross-sectional study. The present study was carried out in Department of Medicine, Eras Lucknow Medical College and Hospital. And the study unit was all OPD and IPD patients in Department of Medicine, ALMHCH, diagnosed with type 2 diabetes mellitus, either obese or non-obese. It was a 24-month study. Sample size was calculated on the basis of variation in serum pesticide levels using this formula. The inclusion criteria was all consecutive adult patients attending OPD or IPD of Department of Medicine, ALMHCH, having type 2 diabetes were included after taking written and informed consents. Patients were divided into obese and non-obese on the basis of their BMI. The exclusion criteria was patients in ICU, patients with bilateral pedal edema, NSARCA, fluid overload or ascites, pregnancy, incidental or accidental intake of pesticides or patient with known pesticide poisoning. Coming to the methodology, all the patients in sample frame were invited to participate in the study. The patients were subjected through complete history examination, anthropometry, abdominal circumference, clinical examination including non-filament test, nerve conduction velocity and fundus examination, blood investigations including the blood glucose, HbA1c, lipid profile, urea creat, urine analysis for microalbumin and urine albumin creat ratio. Blood serum analysis was achieved by gas chromatography and mass spectrometry or electron capture detection on two different capillary columns. The method was validated through successful participation to several inter-laboratory tests and by analysis of human serum with different organochlorine loading. These were the name of pesticides that we were detecting in the serum. The results were analyzed using descriptive statisticals and making comparison among various groups. Categorical data was summarized as proportions and percentages, and quantitative data was summarized as mean plus minus standard deviation. The following statistics were calculated in the present analysis: mean, the standard deviation, unpaired and paired t-test, correlation, and regression analysis. Coming to the conclusion. The present study is carried out with an aim to study the serum pesticide levels in obese and non-obese individuals with type 2 diabetes and to determine the correlation between serum pesticide levels and BMI. For this purpose, a total of 100 patients falling in the sample frame were enrolled in the study. Following observations and results have been obtained. So I'll just sum up the discussion. The present study entitled Serum Pesticide Levels in Obese and Non-Obese Subjects with Type 2 Diabetes in a Teaching Hospital is carried out with an aim to determine the serum pesticide levels and the correlation between the serum pesticide levels and BMI. For this purpose, a total of 100 patients were enrolled in the study. In our study, it is observed that mean age of study cases were 54.64 plus minus 9.5 years, with slightly higher in obese group, but showed insignificant difference between obese and non-obese groups. Whereas the study, our results are also indicated that mean pulse rate of study cases was 81.02 plus minus 10.97 per minute, was slightly higher in obese group, but showed insignificant difference between obese and non-obese groups. The mean systolic blood pressure of any study cases was 133.7, with slightly higher in obese, but showed insignificant differences between obese and non-obese groups. The mean diastolic BP of study cases was 81.8 and was found to be same in obese and non-obese. The mean height of study cases was 161.6 and was found to be almost same in obese and non-obese groups. The mean alpha HCH level 303.56 plus minus 43.24 ppm mean beta HCH level, mean gamma HCH level of obese group was found to be significantly more than that of non-obese. It also found that consistent results as he established a positive relationship between high serum levels of beta HCH and BMI. However, many studies did not show any association for these POPs and obesity. A raised level of alpha HCH was found among the polyneuropathy cases compared to without polyneuropathy. Compared to without polyneuropathy, a raised level of delta HCH pesticide was also found among obese cases compared to without retinopathy. In the current scenario, a production of chemical increases tremendously and simultaneously the prevalence of diabetes is high, suggesting a positive correlation between the chemical exposure and prevalence of diabetes. Therefore, it is important to understand the mechanism as well as the preventive steps which are required to prevent the development of diabetes and diabetic neuropathy. Various environmental chemicals are reportedly that may be the causative agent for diabetes or increases substantial levels of glucose may also lead to development of diabetic neuropathy. Ma'am, I also have an attached poster to it, if I can show it, please.
I think we are running short of time, so you need to conclude it fast.
Sure. So in the conclusion, the obese patients which are having BMI of more than equal to 25 kg per meter square, they have significant level of HCH and PP-DDD levels as compared to non-obese patients. There was no significant difference between these two groups with respect to mean HCH and PP-DDD levels. A positive correlation of HbA1c levels was observed with HCH, PP-DDD and PP-DDT levels on the overall evaluation. On univariate analysis, HbA1c levels showed a positive association with HCH levels on overall evaluation and non-obese population. In obese population, HbA1c levels showed a significant association with HCH and PP-DDT levels. Thank you.
Dr. Zeenat, I think it is an interesting study, but what I would suggest is that whether have you compared these pesticides levels between the non-diabetic obese and non-obese? In your study, you have not done, but have you seen any other studies published online and have you discussed it in your discussion part?
No, sir. We have only taken the diabetic patients with obese and non-obese as on the basis of their BMI. We haven't seen it in diabetic and non-diabetic as yet.
Because it would be interesting to compare it between the non-diabetic subject. If you have not done any study, then you may find any studies maybe published online, and then you can compare whether there is any significant difference or not. So it may give the future direction of the research in that area, whether the pesticides has any role in development of diabetes and whether it is insulin dependent or insulin resistant diabetes.
Yes.
And observation from my side, though the study presented was in a good way, but it would have been handy have you presented it as a PPT format rather than displaying through the direct word presentation of the thesis or whatever it was.
Yes.
It helps us as readers to judge what is in nutshell, especially the results part. We couldn't see what exactly those results and graphs were. So.
Sure.
So Dr. Zeenat, hi. Was there any relation with the duration of diabetes in such cases?
Ma'am, not the duration. We took the HbA1c levels and there was a positive association like to people with higher HbA1c levels. So probably they would be diabetic for a longer period of time, and on the higher HbA1c levels means they would be on uncontrolled diabetes. They had higher levels of HCH and the other pesticides that we compared.
But that also depends upon, have we taken this factor in mind that the patient is compliant to the drugs or not? I mean, high HbA1c can be due to any of the reason. If the patient is not on a proper medication or not taking or not on a diet compliance, a lot of confounding factors would be there that ways.
Yes, ma'am. Ma'am, we have not taken duration into account as such. We have only taken the HbA1c levels and ma'am BMI.
Okay, I think we need to have more study into this era.
Yes, ma'am.
Thank you, Dr. Zeenat.
Thank you.
Thank you, Dr. Zeenat. Our next presentation will be by Dr. Vinay Suresh.
Yes, is my screen visible?
No, your screen is not visible.
Just a second. I just a second. I'll have to leave the meeting and join again. I'm apologies.
Sure.
Hello, ma'am. Hello, ma'am.
Yes.
Ma'am, sorry for the disturbance, ma'am. Ma'am, actually, this is Aishwarya. Like, I had my one of my presentation in previous session, ma'am, but I didn't receive any mail for it, so I couldn't present it, ma'am. Like, I just
so we can take it at the end. We will take it at the end around 2:15 p.m.
Sure, ma'am. I'll
Around
wait.
2 o'clock.
Okay, ma'am. Sure, ma'am. Thank you so much, ma'am.
Is my screen visible now?
Yes, your screen's visible. Kindly proceed and kindly stick to the timeline.
So a very good afternoon to one and all present here. I'm Vinay Suresh, a third-year medical student from King George's Medical University. And I'm honored to have been given this opportunity to present a case report in the 7th annual conference of ACP India chapter. So I'm here to present a case report on Tullio's phenomenon and drop attacks, an unsuspected cause. A 43-year-old gentleman presented to us complaining of intolerance to loud noise, occasionally leading to sudden falls for 6 months. These complaints were insidious in onset and steadily progressive. So he said that whenever he listened to loud noises, for instance, from a television set, he felt a banging noise in his head, which subsequently led to feelings of dizziness. He had intolerance to horns and noisy traffic, which interestingly used to subside on wearing a helmet. He had a past history of fractures, a left humerus fracture 2 years ago and a right femur neck fracture 5 years ago. He was a smoker for the past 15 years and he was an occasional alcoholic. There was no history of hearing loss, tinnitus, earache, or ear discharge, no history of epilepsy, and he was not on any medication for any other disorders. His vitals were stable and general physical examination was not contributory. CNS examination, his higher mental functions were intact. Clinical tests of hearing, the Rene, Weber, and absolute bone conduction tests were all normal. Other cranial nerves, motor, sensory, there are his reflexes and cerebellar and extrapyramidal systemic examinations were normal. Coming to investigations, his blood investigations revealed that the serum calcium levels were within normal limits. Parathyroid hormone and thyroid hormone levels were within the normal range. And serum protein electrophoresis and immunoglobulin fixation was uneventful. Other tests included pure tone audiometry, which showed mild conductive hearing loss in the left ear, and brainstem auditory evoked response, BAER, was found to be normal. So coming to the imaging, we did an X-ray of the skull of this patient, the AP and lateral view. We can see that there are some lytic lesions with diffuse sclerosis and irregular margins, which is giving a sort of a geographical appearance of the skull. And even the facial bones and the mandible seems to be affected here. This is the CT scan of the patient. And you can see that there are some lytic lesions in the image C and F here. And in the images A, B, and C, we can see that the brain parenchyma seems to be normal and unaffected. So we also did a 3-dimensional reconstruction of the CT of this image of this patient, and we found that there were multiple lytic lesions which are clearly seen here. These are wonderful renders of the patient's skull. So to confirm a diagnosis, we did a biopsy of one of the skull lesions, and we found fibrocollagenous tissue infiltrated predominantly by a large number of eosinophils, and even a few lymphocytes can be seen here. Histiocytes can be seen which are interspersed and are grooved, folded, and have lobular nuclei. So these histopathological characteristics are pointing towards a diagnosis of Langerhans cell histiocytosis. For management, we started the patient on chemotherapeutic agents of etoposide and vinblastine, following which he showed considerable clinical improvement. And we also gave supportive treatment for it of vitamin D and calcium supplements for his bone lesions. Langerhans cell histiocytosis is a disorder that is caused by a proliferation of Langerhans cells, which is actually a kind of dendritic cell which the body uses for fighting infections. It is of monocyte and macrophage lineage, and it originates from the bone marrow. It is actually a multisystemic disorder which somewhat revolves around the clinical features of lytic bone lesions, but it can involve other organs as well. It has three distinct subtypes: the Hand-Schüller-Christian disease, the Lederer-Civet disease, and the eosinophilic granuloma. And each of these clinical subtypes they differ slightly in their clinical features. Eosinophilic granuloma is a slowly progressive disorder characterized by skeletal lytic lesions. So the question on LCH was that whether it is actually a neoplasm or whether it's an immune-based disease. But a study in 2010 somewhat confirmed that it is an immune-mediated myeloid neoplasm, because BRAF V600E mutations were seen in more than half of the patients in the study that was conducted. Coming to the mechanism that was seen in our patient, extensive lytic skull lesions in the skull led to a loss of conductive medium, and the phase of sound transmission, where the sound waves are transmitted from the petrous part of the temporal bone to the cochlear fluid and then further to the basilar membrane of the cochlea. Now, this was the part that was affected in our patient, and this was accompanied by loss of attenuation, which is normally done by a normal intact skull bone. And all of these factors led to conductive hearing loss and further noise intolerance, which is known as the Tullio's phenomenon. The main complaints of our patient was intolerance to loud noise, which is, we think, because of due to the loss of attenuation of higher sound frequencies, and symptomatic control wearing a helmet, which is probably due to the modification function that was performed by the helmet. Certain animal experiments, such as the one by Freeman and colleagues, they found that auditory nerve brainstem evoked response could be elicited even after removing the ossicular chain. This indicates that bone conduction is not the entire osseous transmission pathway, and even non-osseous pathways are important and critical for this mechanism. Similarly, some studies such as the one by Sommer and colleagues, they did experiments on humans after vibratory stimulation of the skin over the fontanelle in neonates and skin over craniotomy defects in patients undergoing neurosurgery. And they also did vibrations on the eye, which is sort of like a natural orifice or a natural craniotomy. And they observed that there were no differences between these responses and those obtained over the skull bone. Previous studies show that petrous bone destruction can disrupt the cochlear elements, causing sensorineural and mild conductive hearing loss. Extrapolation of these experiments to our case suggests that there is transmission of sound vibrations that is occurring through non-osseous pathways through the brain parenchyma and CSF in areas of extensive lytic lesions. Hearing abnormalities, including noise intolerance, can be an unusual clinical pointer towards the presence of lytic skull lesions, and such patients must be investigated with thorough neuroimaging and histopathology in order to find out the root cause of these skull lytic lesions. So the take-home message for my case is that LCH is an extremely rare cause of Tullio's phenomenon, and it must be considered as one of the differentials. It can damage the petrous temporal bone, allowing transmission of pressure waves to the endolimb, triggering episodes of disequilibrium, and chemotherapeutic agents such as etoposide and vinblastine provide effective treatment. These are my references. Thank you.
Excellent presentation, Dr. Vinay. It was a very interesting case. And just one question from my side is that, was there any relationship between the noise intolerance and the fall that your patient experienced sometimes?
Yes, sir. So what happened in our patient was there were two major factors that why noise intolerance led to falls. It is because the waves that were being transmitted because of the lytic lesions were directly into the brain parenchyma and into the vestibular system. And that is what led to the loss of balance and the fall, the drop attack.
Okay, thank you.
So, Dr. Vinay, was there any association with nystagmus as well? Did we check for it?
No, there was no nystagmus that was seen in our patient, ma'am. The rest of the CNS examinations were all normal.
Okay.
Thank you, Dr. Vinay. Moving to our next presentation by Dr. Hari Mohan.
Am I audible, doctor?
Yes, you're audible. We can see your screen.
Good afternoon, everyone. Thank you so much for giving me this opportunity to present at American College of Physicians Indian Chapter. And I'm presenting right now a study conducted at a teaching hospital in Kerala, southern India. It is regarding the early detection of cardiotoxicity by longitudinal strain imaging in 2D echo in patients receiving anthracycline chemotherapy. It's a prospective study. So cardiotoxicity, as we all know, is an important side effect of anthracycline and other drugs affecting the myocardium. Usually in 2D echo, we estimate the degree of cardiotoxicity by anthracyclines by using the ejection fraction. An ejection fraction of less than 10% is usually considered as the marker for cardiotoxicity by anthracyclines. But later we found out that by the time we diagnose the cardiotoxicity by ejection fraction, the patient would have been functionally so deteriorated, and we will not be able to do much in patient outcome. So our primary aim of the study is to evaluate cardiac function in patients with breast cancer and receiving anthracycline therapy using a different parameter in 2D echo that is called the longitudinal strain imaging. It is nothing but it measures the contractility of the myocardium using the 2D echo. The study was conducted on 52 patients attending the cardiology department of Trivandrum in a teaching hospital called Kerala Institute of Medical Sciences. They were diagnosed with carcinoma, breast or lymphoma, and they were seeking anthracycline chemotherapy. The study period was between 2016 to 2017. It's a diagnostic and a prospective study. 2D echo with strain imaging was done to estimate the longitudinal strain and thereby the cardiotoxicity caused by anthracycline. So in our studies, we actually measured the longitudinal strain imaging at the baseline when they first received the anthracycline therapy, and then at the end of 3 months, at the end of 6 months, and 1 year. So usually the left ventricular ejection fraction, which was initially done, showed remarkable decline only at the end of 1 year. But while using 2D echo longitudinal strain imaging, we were able to detect cardiotoxicity at the age of 3 months itself. A decline of more than 9% was significant of cardiotoxicity caused by anthracyclines. In our study, we were also able to find out another important factor, that is the regional abnormalities of cardiotoxicity in strain imaging. For example, these patients in 2D echo, we found an apical sparing. The cardiotoxicity of anthracycline was affecting more on the basal anterior and the basal septal regions. So that was an additional finding we found in our study. And when we compared with the previous studies, there was a similar study by Sovaya, who also determined reduced longitudinal strain at the end of 6 months, and that occurs earlier than the left ventricular ejection fraction decline, which did not occur after 6 months. But there are some differences when compared to our study than theirs. The first thing is that in their study, it was a heterogeneous group of treatment. That is, the patients were treated with anthracyclines and trastuzumab along with radiotherapy. But in our study, the patients were exclusively treated with anthracyclines. So it inclines more towards specificity of cardiotoxicity by anthracyclines. And also, they found out the treatment at the end of 6 months, and we found out the change with the longitudinal strain imaging by the end of 3 months. That means 3 months early. So the conclusion of our study is by monitoring with using 2D echo, by monitoring the longitudinal strain imaging instead of the left ventricular ejection fraction, we'll be able to detect cardiotoxicity at a very early stage, and also thus it will help the physicians to diagnose it at an early stage and modify the drugs of anthracycline, or even treat with an alternative drug for breast cancer or lymphoma. That's all about my study. Thank you.
Yeah, hi, Dr. Vidya. Just wanted to know the sample size of your study and in how many cases did you find that anthracycline has significantly caused the cardiotoxicity?
So the sample size was around 52, and we found around 35 patients who detected the longitudinal strain study imaging of around 35 patients.
Okay, and how many at the 3 months and how many at 6 months? Just wanted to know whether the duration was directly proportional to the cardiotoxicity.
Sure. We found that 12 patients at 3 months and rest in the 6 months.
So did we also follow up after stopping the anthracycline, that how much was the reversibility of the this thing on the echo?
In this study, we haven't done that.
Okay. Fine. Yeah. Okay.
Thank you. If there are no more questions, we move to our next speaker, Dr. Ashujot Kaur Dang.
Hello, everyone, and welcome to our esteemed judges, Dr. Khan, Dr. Rastogi, and Dr. Patel. My name is Ashujot Kaur Dang, and I am a recent medical graduate from Government Medical College, Patiala in Punjab. And I had the opportunity to take on this interesting case while I was rotating at a teaching hospital in New Jersey, US. So my case is interesting on the basis of its complicated hospital stay, whereas plus I want to report a unique and rare fungus that we found during the patient's hospital stay. Let's begin. So my case report is about Candida glabrata infected pseudocyst in a young female presenting with DKA, a case report. So pancreatic pseudocysts are one of the most common yet frightful complications of acute and chronic pancreatitis. It is estimated that 6 to 18% of post-pancreatitis patients develop acute pseudocyst, while 20 to 40% of cumulative cases develop chronic pseudocysts. About 50% of these pseudocysts are uncomplicated and regress spontaneously. Some pseudocysts may become complicated and therefore necessitate treatment. Now, one of the complications that can arise is the infection of the pseudocyst that needs endoscopic or percutaneous drainage. Many infectious disease agents are implicated in these pseudocysts, but fungal pseudocysts remain exceedingly rare, with Candida albicans being the most notorious fungal organism. This case report describes an unusual encounter with a DKA patient with pancreatic pseudocysts infected with Candida glabrata, an infrequent yet interesting cause of infected pseudocysts. So we have a 29-year-old female with past medical history of morbid obesity and obstructive sleep apnea who that presented to the ER obtunded and with altered mental status. She had been feeling dizzy, tired, thirsty, and weak for the past 3 to 4 days before she landed in the ER with altered mental status. She was found to have a skyrocketing glucose of 1500 with a pH of 7.04, which is acidic, due to which she was admitted in the ICU for managing DKA versus HHS. Upon arrival at the ICU, the patient became unresponsive and required intubation. And furthermore, she spiked the fever and hypertension, secondary to an episode of a large volume of coffee ground vomitus, and was started on vancomycin and Zosyn, that is Piptaz, empirically. The labs and imaging studies performed in the emergency department revealed some exciting results. The CT chest revealed bilateral lower lobe infiltrates with small pleural effusions bilaterally. while CT abdomen revealed findings consistent with acute edematous pancreatitis with lipase in 3000s, likely secondary to the hypertriglyceridemia, which were in 1000s. Other imaging like CT head were within normal limits. During the hospital course, the patient was intubated on day 1, secondary to the acute hypoxic respiratory failure, and was extubated the next day. DK resolved upon proper management and protocol. Unfortunately, she suffered from acute renal failure, likely due to acute tubular necrosis in a setting of shock, and was managed with several hemodialysis sessions with improvement. Acute pancreatitis resolved eventually on insulin drip, with CT showing evidence of gallstones. The patient was shifted from ICU to wards on day 7 upon showing improvement and being hemodynamically stable. She was doing well until she started spiking fevers again and was diagnosed with fungemia on blood culture growth, with blood culture growth showing Candida glabrata, and she was eventually started on IV mycophenolate. Another element from her problem list was the acute blood anemia, likely from the upper GI bleeding, managed with multiple blood transfusions and IV pantoprazole therapy, which stabilized gradually during the hospital stay. However, interestingly, despite being on IV antibiotics and IV antifungals, on day 13 of her admission, she continued to spike fevers despite the therapy, and her CT abdomen was reordered to rule any GI pathology. Now, CT abdomen and pelvis, to our surprise, revealed a large pancreatic pseudocyst measuring 12.9 into 9.8 into 7.2 centimeters, which were percutaneously managed with CT-guided drainage, and culture of the fluid revealed Candida glabrata again, and were treated with empirixosin plus IV mycophenolate for the specific antifungal treatment. Additionally, to curb her acute diabetes history, uncontrolled diabetes, she was started on Lantus 38 international units by BID and insulin Rispro 12 international units before every meal to curb her uncontrolled diabetes and HbA1c of 11.9. She was also weaned off the nasal cannula for oxygen without any requirement for home excision during the hospital stay. She was eventually discharged with the drain in situ with the scheduled follow-up in 1 week for re-evaluation and possible need for repeat CT abdomen before this drain removal at 6 weeks, along with the continuous course of antibiotics and antifungals for another 3 weeks. Now, future directions in this case report. This case report elucidates an unusual case of acute pancreatitis concurrent with an acute setting of DK and complicated by pancreatic pseudocyst infected with a rare fungus, Candida glabrata, along with bilateral pleural effusions. Although some research articles report the infected fungal pseudocyst, the incidence of Candida glabrata remains exceedingly rare. As of now, it is unclear how the co-occurrence of 2 acute conditions, DK and acute pancreatitis, is linked. We are curious about the temporal relationship between the conditions. Could pancreatitis have initiated or precipitated the DK, or did the hyperglycemia cause the acute pancreatitis? Research and data in this section is sparse and warrants further studies. Further avenues of research can provide more clarity over the causality and temporality of this situation, and they can provide better insight and additional prophylactic measures to be taken in similar situations to prevent the other from happening and to keep the course of the medical problem as uncomplicated as possible. Now, the take-home message from this case report is that infected pancreatic pseudocysts, primarily due to a fungal cause, remain a rare and dreadful complication of acute pancreatitis. Spontaneous remission is expected in half of the patients with pancreatic pseudocysts, while others may require percutaneous endoscopic or surgical drainage with antibiotics and antifungals. Now, an infected pancreatic pseudocyst can present with the constellation of symptoms, but may also present with persistent fevers despite antibiotics and antifungals without any telltale signs. In such situations, timely assessment and crucial consideration of a fungal cause is vital. Early diagnosis and antifungal therapy are warranted to curb the risk of disseminated candidemia that could have been there in this patient. Further studies with similar patient populations are warranted to explore the possible link between DK and pancreatitis with infected fungal pseudocysts and ensure further debate on optimal medical and surgical treatment. That is me. Any questions?
It's a good presentation, Dr. Ashokujut. Well, I agree that fungal infection is a crucial consideration, especially for the patients with pancreatitis and pseudocyst. So I also recently had a patient of pancreatic pseudocyst, which turned out to have harboring the infection Candida glabrata. But she was non-diabetic and she was an immunocompetent host. But the catch was that she was COVID positive. Unfortunately, we lost that patient. Probably it was not a timely diagnosis and timely intervention could not happen. But yeah, one should keep a strong check on these pancreatitis and pseudocyst for a fungal infection. Good presentation.
Thank you. Thank you, Dr. Rastogi. Thank you for sharing your experience. And I believe that reinstates my whole purpose of this case report, that fungal causes should not be ignored and should definitely be checked, especially if the patient continues to spike fevers despite antibiotics. And even
yeah, so in Vedanta, like we are getting patients referred from outside hospitals. So I think this candida is also gaining popularities. And once if the patient is transferred from some other hospital setting, then one must be very, very vigilant about these fungal infections.
Absolutely. I absolutely agree. Thank you.
Thank you, Dr. Ashutosh. Next presentation is Bhargavi, Dr. Bhargavi.
Hello, hi. Good afternoon, everyone. I'm having trouble with my webcam. Is that okay if I'm, on, if I'm not able to turn on my video call, my video?
You're audible. Please share your screen.
Okay, okay. Actually, ma'am, I'm having trouble with my video, so I don't think I'll be able to turn that on. My webcam is not working exactly well, but I'll try. Okay. Good afternoon, everyone. My name is Bhargavi. I'm a medical student from BGS Global Institute of Medical Sciences, Bangalore. And our study is about the knowledge and practices concerning the prevention of mother-to-child transmission of hepatitis B infection. And it's a cross-sectional study conducted in Karnataka, India. This is the outline of our presentation today: introduction, objective, methodology, results, and conclusion. In introductions, we see that the Sustainable Development Goal 3 by the World Health Organization aims to reduce the disease burden of hepatitis by 2030. The worldwide, over 300 million people are infected with hepatitis B virus, and about 75% of these are in Asia alone. In areas of intermediate prevalence like India, where the carrier rate is around 2% and the prevailing infection is in 20 to 50% of the population, if the mother is hepatitis B positive, the risk of transmission to her neonate or her newborn can be as high as 85 to 90%. So you're looking at 9 in 10 kids, they have a risk of getting hepatitis B if the mother is hepatitis positive. So in our study, we tried to assess the knowledge of pregnant women concerning the hepatitis B infection, the transmission, and the prevention subsequently. So the study design was cross-sectional. It was a questionnaire-based study. Our sample size was 192, and we did consecutive sampling. And we included pregnant females attending the ANC clinic at our hospital. We used a structured questionnaire with 3 sections. The first section with demographic details, second with practice knowledge and practices regarding mother-to-child hepatitis B transmission, and the third section with the hepatitis B status of the mother. And the data was collected and analyzed using Google Sheets. In our results, we were able to see that the mean age of the respondents with mean and standard deviation of 20 plus or minus 1.9 years. And although 90%, around 176 of the people of the respondents were aware of hepatitis B, only 2% knew what virus caused it. The majority stated infection was caused by the consumption of oily, spicy, unhygienic food and population. Almost all pregnant females who gave blood samples could not name the disease for which the screening was done. Understanding the mother-to-child transmission of hepatitis B infection was poor, as 35.5% stated that any disease during pregnancy is transmitted to and affects the child. About 10% of the respondents were counseled during the antenatal period by healthcare workers, and this is coming from a pretty rural population. Although we are a very urban hospital, the patients that we get are from rural sites, and especially our ANC clinic. So I think this could be attributed to the disparity in the healthcare worker distribution. Nearly 80% were aware of the vertical transmission of hepatitis B, which is mother-to-child transmission, and only 35.4% were aware of the vaccination. In conclusion, we'd like to demonstrate, we found that the study's findings highlight that the pregnant women and mothers have insufficient knowledge and misconceptions regarding hepatitis B infection, especially those with lower economic status, socioeconomic status. Therefore, it is imperative to utilize the antenatal period to advocate for raising awareness about the hepatitis B infection. And thank you for listening to the presentation. It was a very short one. Actually, I'm prepared, but thank you so much.
Thank you very much, Dr. Bhargavi. Although it was a short study, it is a very insightful study, which again highlights the very common problem that the knowledge about such diseases in terms of the future transmission into pregnancy is very poor, and we need to work more on that.
Yes,
regarding
sir,
that.
Yes, sir, Dr. Patel, definitely.
So next speaker will be okay, sir. Done, sir?
Yeah, sure, go ahead.
So next speaker will be Dr. Pooja Tripathi. Dr. Pooja, are you there?
Ma'am, Pooja is not there.
Okay, then we move to the next presentation, Dr. Avijit Saha.
Ma'am, he is not available.
Okay, Dr. K. Sai Indranil. Dr. K. Sai Indranil.
Yes, ma'am. Is my screen visible, ma'am?
Yes, yes. You're audible and your screen is visible.
Good afternoon, everyone. Today I'm presenting a case of Lawrence Moon-Bardet-Biddle syndrome. Coming to the case, a 20-year-old male who is morbidly obese with the history of intellectual delay and speech impairment and progressive vision loss, present to our hospital with the chief complaints of breathlessness, oliguria, and abdominal distension. On examination, he was short-statured, obese, and he had pedal edema, facial puffiness, crowded teeth, and retinitis pigmentosa present. He had polydactyly of feet, and he had micropenis. And his laboratory investigations was his HP was low, 6.9, and his creatinine was 12, and the urea was 271, and he has hyperkalemia of 7.7, and bicarb was low, 8.3, and his echo showed left ventricular hypertrophy. And we have done the CT abdomen, which revealed hepatomegaly with right contracted kidney and left HUN. Lawrence Moon-Biddle syndrome is a rare autosomal disorder which has a primary pentad symptoms like pentad characters, polydactyly, retinitis pigmentosa, obesity, hypogonadism, and mental retardation. In this patient, he presented with all the 5 pentad symptoms along with the CKD stage 5, and he also had the secondary features like a speech delay, developmental delay, dental crowding, and high arch palate and left ventricular hypertrophy. Conclusion of the case was it is a rare autosomal disorder with the pentad symptoms, and the renal function loss is the most common cause for the mortality in this patient. And because of the seemingly unrelated symptoms, the disorder remains largely undiagnosed in our country. Most of the reported cases of this syndrome was associated with the consanguineous marriage, which happened same in this case. And the affected family should undergo genetic counseling And the genetic counseling of the affected families raised the awareness of the need to get the family members assessed for the renal and cardiovascular problems. Thank you.
Thank you, Dr. Sai, for letting us know about this syndrome. In fact, most of us have, I think, forgotten about all these things until unless we see these, we can recall. So good presentation. Thanks.
Thank you.
Can you just one question from my side? Again, a good presentation. Can you name what are the other syndromes associated with the polydactyly? Which are the other differential diagnoses?
Hello? Yes, sir?
What are the other syndromes where you can see the polydactyly? Can you just name few?
Other syndromes of polydactyly you can find in, actually I can't remember, sir.
Okay, fine.
It's okay. No issues.
Okay, fine.
No issues. No issues.
Thank you.
Thank you.
Thank you.
Yeah. Thank you, judges. The next candidate will be Dr. Nazim. Dr. Nazim, you are ready? Dr. Nazim Javed Khan. Can you share your presentation?
Dr. Nazim is not there, ma'am.
Okay, Dr. Nazim is not there. Dr. Ira, you are around? Please share your slides.
Yes, ma'am. Am I audible?
Yeah, you are audible.
Okay, yes, ma'am.
Okay, no, that is relayed now. Okay. Just
Ma'am, is my screen visible?
if I don't see my
No, dear,
picture,
your screen
just
is
give
not
that
visible.
on. Yes, sir. You on it rather. Okay, ठीक. Okay, Era Gupta. Off ಮಾಡ್ಬಿಡ್ರಿ. They will get confused. She's looking at my face there. So
If you cannot share the slide, please start.
Ma'am, just
Can you share your screen, please?
Yes.
Okay.
So this is the bottles.
We can consider Dr. Alia in between. By the time Dr. Ira can sort out.
Yeah. Dr. Aishwarya? Dr. Aishwarya, you are around?
Yes, ma'am. Yes, ma'am. I'm here, ma'am.
Share your slides.
Yes, ma'am.
Ma'am, you can take over. Dr. Kansha, if you can just check if the students are not appearing, you can start over.
Yes, ma'am. Good afternoon, one and all. This is my study titled Utility of Various Inflammatory Markers in Predicting Outcomes of Hospitalized Patients with COVID-19 Pneumonia. So introduction, we don't need much introduction for this COVID-19 and its causative agent SARS-CoV-2. The study was done during the second wave of COVID. At that time, we had limited resources and the elevation of inflammatory markers like ESR, CRP, ferritin, and changes like lymphocytopenia were reported in COVID-19 patients, but little was known about their correlation with disease severity. Therefore, we undertook this study to determine the the utility of various inflammatory markers in predicting outcomes of hospitalized patients with COVID-19 pneumonia. The aim of our study was to study the utility of various inflammatory markers in predicting outcomes of hospitalized patients with COVID-19 pneumonia. Our primary objective was to understand the correlation between various inflammatory markers and in-hospital mortality. And secondary objective was to understand the correlation between inflammatory markers and a clinical category of patients, length of hospital stay, need for invasive ventilation, domiciliary oxygen, NIV or NIV requirement at discharge. So methods we studied around 212. We studied around 221 hospitalized patients who were diagnosed with COVID-19 pneumonia for a period of 1 year from May 2020 to July 20, for the period of 2 months from May 2020 to July 2020. All clinical laboratory data, epidemiological data, and laboratory parameters like neutrophil lymphocyte ratio, C-reactive protein, ferritin, interleukin 6, LDH, D-dimer, and procalcitonin were taken into account. The results, we included 221 COVID RT-PCR positive patients in the study. The mean age of the patient was 60 years. There was a female predominance of 70% compared to female patients of 30%. Fever was the most common presenting symptom, which was found in 79.2% of the patients, followed by shortness of breath, cough. And few patients also had varied symptoms like myalgia, loose stools, and sore throat. We categorize the patients into 3 categories, actually 4 as per a hospital protocol. Like category A include mild disease, that is they maintained saturations of 94% and above and room hair, and they didn't have any comorbidities. And category B1 included patients with normal saturations but with underlying comorbid conditions. And category B2 had moderate disease like SpO2 level ranging from 88 to 94. And category C was severe disease with saturations of less than 88%. So since we included hospitalized patients, majority of the patients belong to category C, which was 39.4%. This is the table which tabulates the median value of various inflammatory markers in survivors and non-survivors. As you can see, all these are on admission inflammatory values. So on admission values of NL ratio, ferritin, and IL-6, serum LDH, CRP, D-dimer, all of this was significantly higher among non-survivors than survivors, and this was also supported with our significant p-value. And we tried plotting these values under area under receiving operating characters or a curve. And as you can see in this curve, IL-6 and D-dimer predicted better mortality, in-hospital mortality than other inflammatory markers. So this is the area under the curve. And you can see D-dimer and IL-6 levels are almost same, and they had a greater area, and that predicted greater mortality among patients. So even though AU-ROC is higher in IL-6 and D-dimer, comparison of ROC curves between biomarkers did not reveal statistically significant value by DeLong's method. ROC was used to derive a cutoff value for the biomarkers like NL ratio, ferritin, CRP, D-dimer, IL-6 in predicting in-hospital mortality. We derived the optimal cutoff point using Udine index, which has got discriminating power. So the cutoff value, these are the cutoff value above which there was a significant in-hospital mortality, and the values above which predicted the mortality in the hospitalized patients. And as you can see, sensitivity and specificity for D-dimer and IL-6 was at 76.7% and 60% sensitivity for D-dimer, when the cutoff value was above 0.5. And similarly, even IL-6 of 60.5 above had a significant sensitivity of 80% and specificity of 65% in predicting in-hospital mortality. This is the mean value of the various inflammatory markers in different clinical category of patients. As you can see, the category C included severe patients, and the values of the inflammatory markers on admission in these category of patients was also significantly high. And this is the inflammatory marker and the duration of hospital stay. So we try to correlate if they had any if they correlated, and as you can see, NL ratio and CRP on admissions were better predictors of duration of hospital stay. That is, if NL ratio and CRP were more on admission, they had greater chance of staying at a longer duration at hospital, like more than 14 days. Similarly, NL ratio, LDH, and CRP levels had good correlation with need of oxygen supplementation or invasive ventilation with significant p-values. As you can see, NL ratio, like more NL ratio on admission had a greater chance of them ending up in invasive ventilation, and this was supported by a very significant p-value of 0.001. Similarly, LDH had LDH and CRP also had significant p-value. So to sum up our results, IL-6 levels of more than 60.5 picograms per ml and D-dimer levels of more than 0.5 micrograms per ml predicted in-hospital mortality with sensitivities of 80% and 76.7% respectively. And also NL ratio and CRP levels had good correlation with the need of oxygen supplementation and by our invasive ventilation. The limitation of our study was of a retrospective design. Due to this, the impact of various drugs or other interventions on primary and secondary outcomes of the illness could not be analyzed. However, we could ensure complete data capture of all the patients in the study since the uniform protocol was followed in our center in terms of initial monitoring and assessment. Conclusion, among the various markers that are used, interleukin-6 and D-dimer were found to be sensitive predictors of in-hospital mortality due to COVID-19 pneumonia. NL ratio and CRP on admission seem to correlate with duration of hospitalization need for invasive ventilation. LDH levels on admission correlated with need for oxygen supplementation. Serum PCT had poor relation to either mortality or need for invasive ventilation. It is more of a bacterial infection predictor. Judicious use of various biomarkers is helpful in correctly identifying the severity of COVID-19 pneumonia and predicting outcomes. This could also help in guiding appropriate strategies to help.
Yeah, Aishwarya, you are running out of time. Please sum up. You know that there is marks for the time management.
Yes, ma'am. I'm done, ma'am. That's it, ma'am. And we got it published in Lung India Journal as well.
Aishwarya?
That's all, ma'am.
Aishwarya, did you take into account of pre-existing chronic illnesses in such patients for?
Yes, all the comorbidities like diabetes, hypertension were also included. So majority of the patients had diabetes mellitus as a comorbidities associated. So.
Okay, I think if we don't have any questions, we can move to the next business.
Yes, sir. Thank you, sir.
Yeah, is the last presenter ready? Dr. Ira?
Oh, yes, ma'am. I'd like to try sharing my screen.
Yeah.
Yes, ma'am. Ma'am, is my screen visible? Ma'am, am I audible? Excuse me, ma'am.
Yeah, you are audible. You are audible.
Okay, ma'am.
Please go ahead.
Yes, ma'am. Is my screen sharing, ma'am?
It's visible. You can go ahead.
It's visible. Okay, thank you. Thank you so much. Thank you. Good afternoon, everyone. My name is Era Gupta, and I'm a fourth-year medical student from Bangalore Medical College and Research Institute, Bangalore. And I'll be presenting my paper, Alterations in Serum Lipid Profile and Assessment of Clinical Signs of Lipodystrophy in HIV-positive patients on PLE regimen. My study was funded under Indian Council of Medical Research Short-Term Studentship 2020, and a grant of 20,000 rupees was allocated through ICMR for my research study spanning 2 months. India has the third largest HIV epidemic in the world, with Karnataka having an estimated adult HIV prevalence rate of 0.52, which is much higher than the national prevalence rate of 0.27. The two most dreaded complications of highly active antiretroviral therapy involve alterations in lipid metabolism as well as lipodystrophy. Lipodystrophy syndrome is defined as distressing morphologic changes in body habitus, which is characterized by redistribution of fat. It may involve lipoatrophy, which is loss of fat from extremities, buttocks, and face, as well as lipohypertrophy, which is accumulation of fat in areas around the abdomen, neck, or the breast. The two main objectives of my study are to evaluate for alterations in serum lipid profile in HIV-positive patients who are on the first-line treatment of tenofovir, lamivudine, efavirenz for at least 6 months. I also assessed for clinical signs of lipodystrophy in these patients as an early marker of adverse effect of ART. This study was conducted in the ART Center of Victoria Hospital, affiliated to Bangalore Medical College and Research Institute, Karnataka. We included HIV-positive patients who have been on TLE regimen for at least 6 months and who possess their old basal lipid profile report, which was dated just before they started the therapy. This study was done for a period of 2 months from 5th of July to 5th of September 2021, and purpose of sampling was adopted. We included adult population HIV-positive patients who had their old serum lipid profile just before starting therapy with or without opportunistic infections, and they should have been on TLE for at least 6 months. We excluded patients with pre-existing hepatobiliary disease, renal disease, coronary heart disease, who diabetics, hypertensives, who were smokers, who consumed alcohol, or were on lipid-lowering drugs like statins or OCPs. Our cross-sectional study was done after taking informed consent, and 50 HIV-positive adult patients were included in our study, and they should have been on TLE for at least 6 months. Necessary history and clinical information was taken from case files, and a peripheral blood venous sample was collected, and it was tested for lipid profile parameters, which were compared with those at the start of the therapy. Data in the form of height, weight, BMI, mid-upper arm circumference, waist circumference, hip circumference, skin fold thicknesses like the triceps, biceps, subscapular, and suprailiac skin fold thicknesses were taken into account for assessing for lipodystrophy. All this data was entered into spreadsheets using MS Excel and was analyzed using SPSS. Coming to the results of our study, including the socio-demographic results, out of the 50 participants, majority of them were males who fell in the age group range of 26 years to 43 years. Majority of our participants fell in the middle class as per the modified DG Prasad classification of socioeconomic status. Our participants also showed a mean duration of taking TLE to be 4.26 years with a standard deviation of 0.39. Dyslipidemia, as per the NCEP ATP3 guidelines, is defined as HDL less than 40 mg per DL, LDL more than 130, total cholesterol more than 200, triglycerides more than 150, and total cholesterol to HDL ratio more than 5. And as per this definition, we saw a prevalence rate of dyslipidemia after taking ART to be 66%, 18%, 60%, 24%, and 52% respectively. The lipid profile parameters showed a decrease in HDL levels and a significant increase in LDL, triglyceride, total cholesterol, VLDL, and total cholesterol to HDL ratio with a p-value of less than 0.005. Lipodystrophy was assessed using anthropometric measures, and we saw the sum of all 4 skin fold thicknesses to have a positive correlation with the percentage body fat with an R value of 0.36 and P value of 0.010. The anthropometric parameters were found to have the following results. BMI in kg per meter square was found to have a mean value of 24.44 with a standard deviation of 5.25. The VHR had a mean value of 0.83 with a standard deviation of 0.14. The most sensitive indicator, triceps skin fold thickness in mm, was found to have a mean value of 25.14 with a standard deviation of 5.19. And suprailiac skin fold thickness was found to have a mean value of 26.40 with a standard deviation of 9.41. The duration since the start of TLE had a positive correlation with HDL difference before ART and after ART with an R value of 0.322 and P equal to 0.022. And the duration since the start of TLE and body density was found to have a negative correlation with an R value of minus 0.28 with a P value of 0.05. To conclude, our results were found to be similar to a study done in Cameroon, which showed elevated total cholesterol, LDL, and HDL levels significantly. However, in contrast to a study done in Western India, there was a decrease in HDL levels. In conclusion, there has been a significant lipid alterations with raised total cholesterol, triglyceride, LDL, VLDL, total cholesterol to HDL ratio, and a fall in HDL cholesterol for these patients who were on TLE for at least 6 months. As per the NCEP ATP3 guidelines, the prevalence of dyslipidemia was found to be 66% as per the HDL criteria, 18% as per LDL, 60% for triglycerides, 24% for total cholesterol, and 52% for total cholesterol to HDL ratio. Out of the total 50 participants, 29 showed signs of lipoatrophy, 13 showed signs of lipohypertrophy, and the 8 had no such signs. Thank you for this presentation and this opportunity to present my paper.
Wonderful presentation, Dr. Ayara. One question from my side. How did you measure the triceps skin fold thickness in your study?
So we took the skin fold thickness calipers to measure for the skin fold thickness, sir.
Okay, and for each and every visit, it was the same person who was.
Yes, sir. It was me who conducted the study. Yes, sir. Personally, I did the study for the 50 patients.
So there was no inter-individual variation in measuring the tripers.
No, sir. No, sir.
Okay.
Thank you all the judges. Do we have anyone left for the presentation? Okay, Dr. Nazim is there.
Myself, Dr. Nazim.
Yeah.
I just missed because of network issue. Am I audible? Hello?
Yes.
Yeah, hello? Hello?
Yes, you are audible.
Okay. I'll be presenting a rare case of overlap syndrome of seronegative rheumatoid arthritis, systemic sclerosis, and secondary Sjogren's syndrome. As such, rheumatoid arthritis is a chronic inflammatory disease with unknown background etiology characterized by symmetrical polyarthritis, which is the most common type of inflammatory arthritis. Overlap syndrome is a diagnosis in patient more than one connective tissue disorder at the same time. It is diagnosed the component ACR criteria. So overlap most commonly occurs with rheumatoid arthritis SLE or polymyositis, dermatomyositis, Sjogren's, and progressive systemic sclerosis. But in my case, there is patient with seronegative rheumatoid arthritis with progressive systemic sclerosis with Sjogren's syndrome. So this is a history of a patient with a 46-year-old female with bilateral symmetrical polyarthritis of small joints since 10 years. Since 20 years, with deformities of bilateral fingers of hands since 14 years, with history of dryness of eyes and difficulty of dryness of eyes and mouth with difficulty of opening mouth since 8 years, with history of Raynaud's phenomena since 2 years, with significant weight loss with low-grade fever with breathlessness of MMRC grade 1, with multiple time admission because of respiratory infection and anemia. So on examination, patient is poorly built with low BMI of 11.5 kg per meter square. On examination, dry skin was present, pallor was present, dry eyes and dry mouth was there, with mouth opening of 2.8 cm with moderate restriction. Tongue showed bald tongue with high arc palate. Small chin with generalized wasting was present, with atrophy of skin with sclerodactyly was present.
with grade 2 clubbing, multiple hand deformities. I will be showing all the photos: swan neck, button ear, and left chest and cervical lordosis. This is the deformity which she had. We can see that clearly there is swan neck deformity and button ear deformity. Button ear deformity is predominantly in all the fingers, and this little finger has the swan neck deformity. You can see the hitches thumb here and Z-line deformity. And in lower limb, we saw the valgus deformity of the grade 2 and hyperextension with high arc palate. And this photo, we can see there is a bald tongue. So on systemic examination, there was hyperdynamic apex with left parasternal view with features of pulmonary hypertension, like loud P2 was present with palpable P2 and left parasternal view was present. On respiratory examination, there was respiratory fine crepes present bilaterally, more over the basal areas, where CNS and per abdomen were non-remarkable. On investigation, patient to be found to have anemia with ESR of 45 and CRP of 27. All the RA factor, anti-CCP, anti-CPK were negative, but ANA profile found to be 3+ with RO 52 and J1 for positive. With ACR ULR 6 points of definite rheumatoid arthritis. On screamer test, it was found to have severe dryness, and Raynaud's cold water test found to be positive. With this ACR criteria, we diagnosed that rheumatoid arthritis. So ECG showed P pulmonale, features of pulmonary hypertension with pulmonary artery pressure of 65 mm of Hg. On this is Raynaud's test which we did, which is found to be positive. And chest X-ray we did, which showed reticular nodular pattern, but on HRCT suggested bronchiectasis. So a patient was earlier on methotrexate for 15 years and now on mycophenolate mofetil and hydroxychloroquine. Sildenafil for pulmonary hypertension and blood transfusion was done, and patient with above was discharged. So unique features of this case was, this is a rare case of overlap syndrome, which the incidence of 10 to 20 per million population with seronegative or rheumatoid arthritis. In this current case, Sjogren's syndrome owing to ocular symptoms like dry eyes and oral symptoms like difficulty in swallowing was there, and salivary symptom like dry eyes was also there, with presence of anti-RO antibody in the serum. Sclerosis of pulmonary hypertension, skin thickening, and sclerodectomy. So take-home message is early diagnosis and treatment of overlap syndrome like rheumatoid arthritis or scleroderma or Sjogren's with will prevent the deformity and morbidity and mortality. So thank you. Hello.
Hi, Dr. Nazim. It was a good presentation.
Thank you.
We all are aware of the seropositive RA with such overlap cases with systemic sclerosis as well as Sjogren's.
Yes,
so there are few case reports, including thyroiditis also.
Yes,
so did
yes.
you check for thyroiditis in your patient specifically?
Yeah, I checked for thyroiditis. I did for anti-TPO, TSH, and T3. It was negative for this patient.
Okay, fine. And any specific occupational exposure? Like
This
there are case
actually
reports
was a homemaker by occupation. Like silicosis, in silicosis, it is more prone for this
no exposure of silica.
No exposure of, and this was a rare case. Like it is like 10 to 20 in per million population.
Okay, good.
Thank you, sir. Thank you for giving.
Thank you very much.
Thank you, Dr. Nazim.
Yes, thank you.
Thank you, respected judges, and thank you, Dr. Nazim. So
Thank you very
moving forward, moving forward for a virtual e-poster session, our next presentation will be by Dr. Pankaj Singh, and our respected judges are Dr. Smriti and Dr. Monica Gupta.
Am I audible?
Yes, you are audible.
Is my slides visible?
No.
Is it visible?
Yes, your slides are visible.
Pardon, ma'am?
Your slide
Your
is
slide
visible.
is
Am I audible, ma'am? Hello.
yes, you're audible.
And about my slides, I've already shared my slide. Is it visible? Hello.
Your slide is visible. You are audible. Please go ahead.
Okay. So, I'm presenting e-poster. The topic of the poster is clinical utility, safety, and efficacy of novel motorized power spiral endoscopy small bowel evaluation. So today I'm talking about a innovative device which has recently come up in last couple of years. Before this, I just want to give a brief introduction about the workup that we do for small bowel evaluation. Basically, before this, all that we have now, armamentary in evaluation of small bowel is that basically someone with suspected small bowel bleed or small bowel disease comes to us, we evaluate either with CT scan or MR angiography, and then once we decide for doing an endoscopic procedure, options that we have is capsule endoscopy, or single balloon or double balloon endoscopy. This has been there for last 2 years with us, but both these modalities had their limitations. Most important limitation was that we have not been able to cover the whole of small intestine. But for last 2 years, we had a new device which is named motorized power spiral endoscopy. The new in this device is that this is a motorized device, and it is not totally controlled by operator. So it is a motor driven scope which negotiates inside the small intestine with the help of a motor, and the control in this case is with the help of a pedal that we can see in this diagram. There is a pedal which had a forward and the backward pedal. Just like driving a car, we press the forward pedal, the scope moves inside with the help of a spiral tube. It feeds the small intestine and it moves inside the small intestine. So the introduction is that this motorized power spiral endoscopy is an innovative technique which offers easier, faster, and more complete small bowel evaluation. So with this, we aim to evaluate the safety and efficacy of this in various indications. It was a retrospective analysis of prospectively collected data of conservative patients in our center who underwent power spiral endoscopy. Primary outcome measure was technical success rate, pen endoscopy rate, therapeutic yield, and secondary outcomes were depth of maximal insertion, median insertion time, in the adverse event. Results: we did a total of 44 patients with a mean age of 49 years who underwent power spiral endoscopy for small bowel evaluation. Technical success was achieved in 95% patient, in which we did an antegrade route. In this device, we is like evaluating the small intestine. It can be done by two routes. One is the antegrade route where we can introduce the device orally, and the retrograde route is where we can introduce the device parenterally. So the success rate in the retrograde was 93%. And endoscopy rate was 37%. That means about 37% patient we were able to have complete evaluation of the small intestine, which was literally not possible with the pre-existing device, endoscopic device. Capsules we can do, but capsules has limitations like patients with intestinal obstruction, strictures, or post-operative strictures adhesions. We are not comfortable putting a capsule because of the risk of capsule being stuck in the small intestine. So with this device, we can achieve a pen endoscopy rate up to 37%. And in up to 8%, we are able to pass the scope from mouth till cecum. Overall diagnostic and therapeutic yield was 85% and 30.76% respectively. The most common findings that we had was ulcer restricting lesion in 51% and vascular lesions in 9.61%. This ulcer restricting lesion on biopsy was mostly Crohn's disease, which in contrary to the previously existing data from India, that most ulcer restricting lesions in small intestine is not tubercular, it is Crohn's. In our study, we could not document any patient with small bowel tuberculosis, but mostly these are Crohn's, and they were subjected to immunomodulators and 5-AS and responded well to this treatment. Median depth of insertion was 400 centimeter from the antegrade route and 180 centimeter from the retrograde route. Median insertion time was 70 minutes in antegrade and 45 minutes in the retrograde process. The major adverse event seen in only 1% where we had post-procedure aspiration. Otherwise, minor events were seen in 48%. Minor events were described as post-procedure dysphagia, pain, or some discomfort because of the insertion of the hepatitis. So conclude that powered spiral endoscopy is a safe and effective modality for the evaluation of small bowel disorder with a high diagnostic yield. It works on the same principle as that of the earlier spiral endoscope with a specialized cell-propulsive motor, and it scoops favorably over the existing deep endoscopy devices in terms of procedural ease, duration, safety, and yield. Thank you.
Any questions or respected judges?
It's very good presentation, Dr. Pankaj. You have enumerated all the adverse effects of some. If the procedure is contraindicated in anything, like it's not done in some.
Because this is it is contraindicated in someone having esophageal varices, esophageal stricture, immediate postoperative period, suspected intestinal perforation, and cases with altered bowel anatomy, altered intestinal anatomy because of surgery. Otherwise, it is a very safe procedure. It is very effective. With this device, we are able to see most part of the small intestine. Chances of detecting small lesions in small intestine, which were not that easy with the previous devices, now we have been able to detect more of this disease. Even small bleeds, small intestine can be easily reached, and we can do endoscopic procedure and secure the bleeding points.
Okay, thank you, Dr. Pankaj.
Thank you. Thank you.
Thank you, Dr. Pankaj. Our next presentation will be by Dr. Justin.
Yes, madam. I'll share my screen. Are you able to see my screen, madam?
Yes, it's visible.
Yeah. So, good afternoon, everybody. My topic is systemic review of the clinical profile of cerebral abscess in post-COVID rhino-orbital cerebral mucormycosis. Introduction: the vulnerability of COVID-19 patient to ROCM, a spectrum of limited cyno-nasal, rhino-orbital, and rhino-orbital cerebral disease, often have underlying uncontrolled diabetes, immunosuppressive therapy in moderate to severe cases. Aim of the study is to analyze the demographic data, provide an overview of diverse clinico-radiological presentation of cerebral abscess in post-COVID ROCM. Methods: we systematically reviewed 65 patients diagnosed with post-COVID ROCM with cerebral abscess admitted to the hospital during the May 2021 to August 2021. Data pertaining to the demographic variable clinico-radiological features were analyzed using percentage of total cases. Results: out of 65%, incidence is more in the age group of 40 to 60 years. Male are more affected than female. Risk factor inhaled steroid use is 89%. Diabetes mellitus is 81%. CKD is 0.07%. HIV is 0.03%. Clinical profile include headache 97%, seizures 80%, vomiting is 60%, focal neurological deficit 18%, encephalopathy is 3%. This is the axial T1 section of post-contrast showing the ring enhancement lesion in the diffusion weighted and as well as the ADC map showing the diffusion restriction in the periphery with the intracavitary projection of the right temporal lobe. Discussion: mucormycosis in patients with COVID-19 infection has been reported worldwide. In a systematic review by the Bhattacharya, the majority of the cases, 92% of MCR in patients with COVID-19 reported were from India with 350 cases, followed by 15 cases from Iran and 6 from Egypt and 11 cases from Turkey. In our study, we have reported 65 cases. The primary reason that appears to facilitate fungal spore to germinate in people with COVID-19 is an ideal environment of low oxygen, high glucose, acidic environment, high iron level, and decreased phagocytic activity of WBC due to the immunosuppression. In a systemic review conducted by the John et al., 41 confirmed MCR cases in people with COVID-19 were described, and DM was reported in 93%, while 88% were receiving corticosteroid. In our study, 88% have received steroid, and 81% had diabetes mellitus. Yadav et al. Study showed the most common presentation symptom was facial pain, swelling 42%, followed by drooping of eyelids and nasal discharge and bleeding is 37%. In our study, clinical profile include headache 97%, seizure 80%, vomiting 60%, focal neurological deficits 18%, and encephalopathy is 3%. A CT scan is crucial for the identification of the bony destruction. Contrast enhanced MRI provides an early detection of meningeal or intraparenchymatous spread and intracranial vascular occlusion. Sen et al. Study showed, and among the CNS, the cavernous sinus was the most commonly involved in 53%. Bilateral CNS involvement was documented in 5% of the cases. In our radiological profile showed abscess in the temporal lobe is 49%, frontal lobe 28%, occipital lobe 14%, parietal lobe 6%, and optic nerve involvement in 3%. In conclusion, caution needs to be exercised with regard to the glycemic control, widespread usage of corticosteroid to reduce the superinfection, expedient commencement of antifungal therapy together with the surgical debridement help to improve the survival of these patients. In country with prevalence of high risk factors and relatively poor resources, COVID vaccination program should be topmost priority to avoid massive outbreaks and complication and mortality. Thank you. These are all my references.
Thank you, Dr. Justice. It's a very nice presentation. I just want to know what is the mortality rate of these patients.
Yes, madam. The mortality is 40%, madam. Even after debridement, even after surgical intervention, the mortality is 40%.
Okay. Thank you, Dr. Justice.
Thank you. Shall I go for the next case?
Yes, Dr. Justin, you can proceed with the next presentation.
Yes, madam. Please, 1 minute, please. Yes. This is a case report of Charles Burnett syndrome, a rare complication in ischemic stroke. Introduction. Charles Burnett syndrome is characterized by the complex visual hallucination in individuals with compromised visual function but with preserved cognitive status. It may be due to a senile macular degeneration and other anterior visual pathway dysfunction in patients of advanced age. It can also occur as a result of an ischemic stroke affecting the optical neural pathways, the occipital visual cortex, or both. Here we report a variant of CBS, that is called Charles Burnett syndrome, as a consequence of ischemic stroke in left occipitotemporal region. A case report. 65-year-old male, a chronic smoker and alcoholic, non-hypertensive and diabetic with the history of coronary artery disease, with the history of recurrent TIA in the past 1 month, and no history of psychiatric disorder, presented with acute onset of visual hallucination in the right hemifield, headache, and blurred vision. Neurological assessment showed Mini-Mental scale of 28 out of 30, people reacting to light, right hemianopia was there, normal motor, sensory, and cerebellar examination with the visual hallucination in the form of animals, auto rickshaw coming towards him, and people roaming around him in the right hemifield, and also flashes of lights with preserved insight of this illness. Metabolic and hematological profile showed no abnormalities. MRI brain revealed a T2 flare hyperintensity signals with the diffusion restricted in the left temporo-occipital region, suggestive of acute ischemic stroke. We did an EEG. EEG was normal. After complete study, the diagnosis of Charles Burnett syndrome secondary to occipitotemporal ischemic stroke was assumed. The hallucination continued throughout the hospitalization and gradually reverted after valproic acid therapy. Follow-up after 3 months showed a resolution of the hallucination and complete recovery of the patient. And discussion, The CBS is a rare cause of complex visual hallucination in individuals with preserved cognitive status. The preserved cognitive status is very important. The visual hallucination of the patient with the CBS are described as either a simple geometric patterns or a complex recognizable shapes such as faces or floral pictures. The currently accepted theory suggests that visual loss lead to the visual sensory deafferentation, causing disinhibition and later spontaneous firing of the visual cortical regions. The CBS is a primary diagnosis in patients with an ophthalmological disease, but it's also seen in the stroke patients with hemianopia and occipital lobe damage. Today, no universally accepted diagnostic criteria for CBS exists. There is no specific therapy for CBS, but anticonvulsant and antipsychotic drugs have been reported to relieve visual hallucination associated with CBS. In the present case, valproic acid resulted in improvement of the visual hallucination. Although Charles Burnett syndrome is benign, the visual hallucination can cause a great anxiety for the patient. Therefore, increased awareness of this condition can assist clinicians in proper diagnosis, counseling, and reassurance of the patients. These are all the references, ma'am. Thank you.
Thank you, Dr. Justin. It's a very nice presentation with a unique case report of the CBS.
Yes, madam.
And how many patients have you seen with the CBS? Just I want to know because
Madam, I have seen only 2 patients so far in my career.
okay, it's rarest.
Rarest
only.
rarest. That's why I put on as this one. Because the important thing is you should have a proper cognition. The cognition should be normal before diagnosing this. That is the important.
You might be patient can present it to a psychiatric department.
Yeah.
That's good.
Thank you very much.
Nice presentation, Dr. Justin.
Thank you, madam. Thank you.
Thank you, Dr. Justin, and
Thank you,
respected judges, for the session. Thank you.
Thank you.
I'm Dr. Kanksha and I'm the moderator of this session. And I wish you all a very wonderful and a remarkable afternoon. So may I invite our chairpersons, Dr. Ashish Jindal, who is a MD Medicine, CCDM Assistant Professor at AIIMS Mohali, Punjab. Dr. Rajen Kumar Verma and Dr. Prashant Shankar. Onto the stage, please.
Thank you, ma'am. So we'll start with our first scheduled event. Our first speaker is none other than Dr. Banti Sabu sir, who is a chief diabetologist and chairman at DiaCare and Harmo Clinic at Ahmedabad. He is a very renowned person, as we all know, and he is honored with the Fellowship of American College of Endocrinology, ACP, International College of Nutrition. He has done RCP, triple RCP at Glasgow, Edinburgh, and London. Sir is the managing director of Diabetes Research and Metabolic Syndrome, past president of RSSDI, and various other groups. Sir has received multiple awards. Naming some would be Knowledge-Based Diabetes Awareness Movement Award, Intensive Diabetes Education and Awareness Award, multiple diabetes clinic along with AMC with support of World Diabetes Federation. Sir has more than 150 publications in the Index Journal and have contributed many chapters in various textbooks and monograms. Over to you, sir.
Thank you, Dr. Anuj Maheshwari, and Organizing Committee and Scientific Committee of American College of Physicians, Indian Chapter. Thanks to Dr. Srinivas Murthy for organizing a wonderful meeting. I'm missing your hospitality. What I'm going to talk in next 25 minutes, the precision medicine in diabetes. It's a very interesting topic for which I'm again thankful to Scientific Committee and to Dr. Anuj for choosing this very interesting topic. I don't have any disclaimer to make for this particular talk. The Precision Medicine Initiative, which has been a 2015, Mr. Barack Obama, that time president, he had told that tonight I am launching a new precision medicine initiative to bring us closer to curing diabetes like cancer and diabetes. And I am starting by this talk with this statement. And to give us all access to the personalized information, we need to keep ourselves and our families healthier. And this is what he talked in 2015 when he was the president. This initiative, which was again published also in Genetic Testing and Molecular Biomarkers in 2015, and it had become a talk of the town and across the world in field of medicine, that now the future of medicine is a precision medicine. And in field of diabetes, in field of cancer, where we can use this precise medicine more effectively to treat individual person very, very effectively. What I'll be talking in next 25 minutes, what's the precision medicine as an overview, the difference between precision medicine and personalized medicine. We'll be talking precision medicine in diabetes and the practice of precision medicine, a patient-centered approach that I'll be talking and covering in this particular talk. The overview of precision medicine, the joint statement which has been done by American Diabetic Association along with European Association of Study of Diabetes, it encourages clinicians to consider a patient-centered approach. And that is what ADA ESD guideline we know since long. But precision medicine combines individual data, particularly gene biomarkers, the physiological and behavioral data to predict risk and response to disease in a highly precise manner. It means we have biomarkers, we have gene, we have a physiological data, and we have a behavioral data. All these four things combinedly, if you have the data, then probably we can practice the precision medicine, which will be very, very effective for predicting risk as well as response to disease when we are treating that in a highly precise manner. The components of precise medicine is, it's a precise diagnosis, precision therapeutics, it is precision prevention, it is precision treatment, it is precision monitoring, and it is precision prognostic also. So precisely for each and every person, we have a diagnostic, therapeutic part, the preventive part, the treatment, the prognosis and monitoring. Everything could be done. Or in one particular field, we may not have everything. Maybe possibly for like in diabetes, in a routine patient, we are doing monitoring, a continuous monitoring with their behavior. We are precisely monitoring them. In cancer, some of the genetic tests is doing a precisely diagnosis for that. So at this point of time, it is not like that all 6 components of precision medicine we are using in all sub-therapeutic, all different sub-therapy. But in future, maybe we will able to, for each and every disease, we will have precise diagnosis and we will have a precision prognostic also. The precise diagnosis is a precision diagnostic redefining the characterization of a diabetes to optimize therapy, or to a prognostication using information about a person's unique biology, environment, and context. The epidemiological evaluation, the probability based on a clinical features and a diagnostic testing. On that, we can subclassify, and a very in a recently like a type 2 diabetes which we are treating is not actually one variety. It is 4 different varieties of type 2 diabetes which we are dealing with. It is some of them a severe insulin deficient diabetes. We have in classification, there are patients who are obesity induced diabetes. There are because of age related diabetes that is marked, and there is a severe insulin resistance diabetes. So all type 2 diabetes are actually not same. And this is what precisely with their phenotype and some of the investigation, we can find out they are not same, they are actually different, and we are dealing with 4 different types of diabetes. And probably in future, we will able to also know that which therapy will be utilized or the best for that particular subtype of type 2 diabetes. The precision therapeutics will also is a tailored therapy. It is the using information about person unique biology, environment, context to prevent or treat the disease. This precisely we can prevent them and precisely we can treat it. If we know that this is the precise way of diagnosis, or in advance we can know that these are the features by which someone can have that particular disease, and probably we will able to in future we will have a precise prevention program for that particular person. And similarly, as I told you, the subtypes of type 2 diabetes, a precise treatment can be given for that particular type of persons. This precise prevention and precise treatment will have lot of things in between, but one the best part of it, there will be minimized side effects. And the minimized side effects of a treatment which we are going to give to that particular person, probably in future, we will able to see that every patient what we are treating with a almost same dose, like we know that each and everyone should be given a metformin of 500 milligram 3 times a day, or we want to give them 1 gram twice daily, or even maximum dose you can go for 2.5. But we don't know that whether precisely that each and every patient will require 2 gram only. There are patients who will require only 1500 milligram or maybe 1000 or only 500 milligram, or a time will come that by which we will able to know that how much insulin resistance they have and how much precisely they will require insulin sensitizer for that particular therapy. So that will decrease the side effect of the medication which we are giving them slightly supratherapeutic dose, or in some of the patient it is given in subtherapeutic dose also. The precise prognostic is also very important, that who are the one who are going to develop the complication. Like simple example of diabetes. Some of the type 1 diabetes, even with the duration of 10, 15, 20 years, they don't develop microvascular complication. Even some of the type 2 diabetes, nothing with the duration. Even with the newly diagnosed patient, they come with the complication, or many of the patients they have with the neuropathy. Some of the patients with longer duration of diabetes, with relatively uncontrolled diabetes, don't develop neuropathy, and some of the patients well-controlled diabetes with a shorter duration of diabetes also develop neuropathy. It means there are some other factors other than the duration and hyperglycemia may be responsible for these complications. And this precise prognosis, who will develop what type of complication. Probably a future will come that we will able to know that this particular person is more prone to develop microvascular complication or a macrovascular complication, and that is what we are moving forward in near future. The difference between precise medicine and personalized medicine, that's also very much slightly there is a difference for that. What is precision medicine? It depends on data, analytics, and information. While personalized medicine appraises genetic, epigenomic, clinical information to customize treatment decision. A personalized medicine also have here a patient preference. It means you have decided that this should be the treatment for one particular person, but the personalized medicine will also have his own preference. Like I want to give someone the best treatment is today like 780Z for a type 1 diabetic patient, say insulin infusion pump. But that may not be his preference. His belief is that I does not want a pump. His attitude, his knowledge about that particular thing or his social context will not decide that particular precise medicine which we are choosing. And that is what a personalized medicine, where you have to involve whatever the medication which we are deciding as per the data and analytics, it should be also involved with the patient and according to his preference and beliefs, attitude, knowledge, social or psychosocial effect of his environment and the economic part of it will decide the therapy, and that is what we call is personalized medicine. There is a bottleneck in bringing precise medicine in practice. So one of the biggest bottleneck at this point of time, it is very much new concept for diabetologists. Second biggest bottleneck is genetics is not a part of routine clinical testing. We don't do for each and every patient. We may do some analytics, some information, some continuous glucose monitoring, but not genetics. Except at this point of time, I can say MODI is one diagnosis, which is a clinical diagnosis. Then we confirm it with genetic testing, and there we can say that yes, they are precisely diagnosed what type of MODI and which therapy will be used for that type of patient. The other is defining like etiological subgroup of type 2 diabetes, but at this point of time, we are just classifying them with the phenotype. But probably in near future, we will able to know that who is developing, why a lean person is developing diabetes, what is the defect is which is happening in that particular person. Even the C-peptide is not subnormal or not very low or not like type 1 diabetes, why he is developing diabetes. The lack of marked difference in the treatment response in type 2 diabetes. We had seen the patients who are responding to GLP-1 analog with a weight reduction of 20 kg. We have seen the patient with a GLP analog with only 2 kg weight reduction. So why there is so much difference in the same therapy, even we are choosing a right kind of patient. So there we will able to know that precisely why some patients are not getting the response or they are getting more side effects. These are the bottlenecks at this point of time, and we don't have answer. Even we are talking for precision medicine or precision diabetology. But there is a definite positive shift which had come from personalized medicine to precision medicine. We are trying for each and every one a personalized therapy. That is what individualized treatment, which is now no more only the guideline-based therapy, but we would like to treat each and every person with a very much personalized or individualized approach. But with that, we are moving from individualized or a personalized approach to precision medicine. And that is what a future is of precision medicine. The precision medicine in diabetes, if I talk, this was one of the paper which was published in 2016 in diabetes, a precision medicine, a future in diabetes care. A foundation of precision medicine in diabetes, as I told you, it was in monogenic diabetes, which was now we can definitely diagnose with the persons with which type of monogenic diabetes they have. The neonatal diabetes, before we were having the genetic testing for neonatal diabetes, we all were treating these neonatal type diabetes like insulin deficient diabetes. The metformin resistance, probably we will able to know with the genetic testing also. And in future, we will also able to know the different type of therapy which we are using, probably which particular medicine will be used for which type of person and how much dose and how effective it will be, what will be the side effects, whether how we can avoid those side effects, and we can stop unnecessary medicine which may not be useful for that particular patient. The heterogeneity of diabetes, it's clearly been lagging behind cancer. During the last 100 years, the diagnosis of diabetes has largely been based on a single metabolite measurement, that of glucose. At present, we have only the glucose measurement, which gives us that this is diabetes. There is a classification as per World Health Organization, is type 1 and type 2, secondary and during pregnancy. Refined classification of diabetes, especially type 2 diabetes, could provide a powerful tool to facilitate the implementation of precision medicine from diagnosis in the same manner as a genetic diagnosis of monogenic forms of diabetes, which is MODI will guide clinician to more optimal treatment for our patients. The precision medicine recently, one paper in 2020, they had come out with a consensus report. Again, with ADA and ESD had come out with a consensus. What should be the precision medicine in diabetes? And the precision medicine in diabetes initiative, the idea of precision diabetes medicine is gaining momentum based upon the promise of reducing the enormous and growing burden of diabetes worldwide. To address this, the Precision Medicine in Diabetes Initiative was launched in 2018 by ADA in partnership with ESD, and this PMDI has partnered subsequently with other organizations across the world, including JDRF and NIDDK of US. The role of pharmacogenetic study is we can have a patient stratification, identify the right patient, then the target identification, ensure the discovery of novel drug that can illustrate the mechanism of action and open new therapeutic avenues, and a functional characterization which provide insight with respect to the mode of action of the gene product on or the cell type in which it is expressed. So right medication to the right person at the right time that is what the pharmacogenetic study, and that is what we want for our diabetic patients, and that's the future of precision diabetology. The Global Precision Medicine Initiative, some initiatives have been built, new cohorts from scratch. Most initiatives have been leveraged on the existing data from biobanks. And across the world, there are a lot of things are happening. In this particular graph, I'm just showing that how many places in the world where a lot of things are happening. Unluckily, in India, very few centers in precision diabetology. I know from Dr. V. Mohan Center had recently started, even in a clinic also, in his all center, a precision medicine center also. And he is working with ICMR on a advanced center for genetic testing, where we are sending for our for even monogenic diabetes, which is completely free. So the precision medicine in diabetes management, the drive to develop precision medicine for diabetes is based on major technological advances. The advances like genetic testing, which is omics assay, wearable devices to know the behavior, to know the sleep pattern, to know the pulse, to know the sympathetic activity, to know the exercise, and digital imaging, or to do the continuous glucose monitoring, which gives you a lot of information, and accordingly we can decide the precision nutrition, we can decide the precisely the therapy also. Like in continuous glucose monitoring, you know that who are the one who are getting post-meal glucose level very high. So it is the nutrition, and then where the alpha glucosidase inhibitor will be the most effective. I mean, that type of patients you can decide with doing their continuous glucose monitoring. The path to precision medicine in type 2 diabetic patients, we start from the continuous monitoring with multiple wearable devices, with patient feedback, with patient engagement, because he has to get engaged. He has to put a lot of things on also on app or on a different way by which he can communicate to his clinician. And on that basis, we can treat the patient precisely. And one of the best example which I can give you with artificial intelligence in type 1 diabetic patients, particularly those who are on pump therapy. Before some time, we used to put the patients on a pump, and then every time patient has to calculate that how much he is eating and how much insulin dose he has to take, and how he has to decrease his basal or bolus dose or increase his basal or bolus dose according to his seeing his continuous glucose monitoring data. And it was real difficult for clinician, not only for patient, but for clinician also. It was very, very difficult to get the best control for even a patient who are on pump on continuous glucose monitoring. With artificial intelligence and with precision diabetology, now our patient to whom we are putting with 780G, the pump itself decides that how much dose person is going to have. He will decide, the pump will decide that how much basal dose is to be continued for that particular patient. So the precision medicine with it, artificial intelligence, with the patient behavior, which patient have in 1 month or every day, the next day accordingly, the change will be there. And that is what precision medicine happen in type 1 diabetes. Precision medicine at this point of time is in different stages of diabetes. As I told you already, for MODI, we have accepted that, but still at this point of time, we have only 18 varieties of MODI genes which we can diagnose. But in future, probably we will have more such gene which may be responsible for this monogenic diabetes. The genomic variants will predict the type 2 diabetic patients who are with after genetic risk score. So who will be developing diabetes, maybe with genomic variants or with genetic study, we will able to know. Even we will also able to know genetic analysis that who are the one who are going to develop the risk of complication and response of drugs, and in how much dose, which particular molecule will be the most effective. And we may not give the unnecessarily the medication which are not effective for that particular person. That is the real future for a precision medicine. The advantage will be, it will be more scientific and specific diagnosis. It will give a more personalized care and a better quality of life. The change of therapy will become much easier for them, and a better control of diabetes, leading to reduced risk of diabetes related complication. Precision medicine in futuristic model, there are like different subtypes of diabetes you can diagnose with them, with proteomics, genomics, epigenetics, metabolics. We will able to know with their electronic medical records that which particular person is going to have the best treatment. This is one paper which has been published by Dr. V. Mohan recently in 2019. The useful for precision medicine in monogenic diabetes, as I already explained you, for neonatal diabetes and MODI, which is well accepted. And Dr. V. Mohan, in his paper, he talked about this genetic study, which he is doing at his center in precision medicine, in precision diabetology, and across the country. Those who are suspected with monogenic diabetes, they can send their sample free of charge, and we can know that which are the patients to whom we should send for monogenic diabetes. And that will become real future, particularly for those young to whom we are suspecting either type 1 and type 2, rather monogenic diabetes. And they are the one who can be just treated with a sulfonylurea. They don't need insulin. They don't need even your metformin. They just need sulfonylurea only. The practicing precision medicine will be very much patient-centric approach. It will definitely very much personalized. It will be a right patient for a right therapy, for a right time of therapy, which will be also decided. But there will be a lot of patient rights will be also there. Patient has to give a lot of information to get all these precise medicine for that particular patient, and patient have to become very responsible also. Like his active participation is very, very important, because unless he will have an active participation, we will not able to know that how his behavior is and how we can decide precise medicine for that particular patient. The similar way, there are physician rights also in patient personalized medicine, and there are responsibilities. The responsibilities are the knowing the patient as an individual. That is the one of the most important responsibility of physician. Understanding the environment and the lifestyle of the patient. That's again very, very important for each and every patient. The environmental factors are different. The lifestyle of a person is also very different. And that is what we are doing as a personalized medicine too. Emphasizing and knowing the patient concern. And that is what, when we are talking of precision medicine to the precision personalized medicine, the patient concerns are also very important. It is the cost. It may be sometimes they don't want injection. Sometimes they don't want the lifestyle to be changed. So that patient concerns are very important. Discussing the patient need and getting the knowledge of direct to consumer genetic testing. This is a very important example of precision diabetes. A paper which is published from Sweden, and then a similar type of paper which was published from India also by Dr. V. Mohan. The type 2 diabetes is not a single disease. Rather, it consists of multiple subtypes of diabetes. It is obesity induced, it is severely insulin resistance, it is age-related diabetes, or it is severely insulin deficient diabetes also. This was, as I told you, Mohan had also published the similar paper from their group, and they had talked about the novel subgroup, and there they found there is one unique variety of insulin deficient diabetes in our country, where they have insulin deficient with insulin resistance, and that variety was not there in the Sweden group. So I mean, again, because we could do a similar paper and we could find out that in Indian type 2 diabetic patients are again different from the type 2 diabetes patients from a Caucasian population. Even we have also the 4 variety of patient, but one variety which is very unique to India, which is combined insulin deficient with combined insulin resistance. The treatment response based approach in a precision medicine in type 2 diabetic patients, like you are just doing a simple information, which we are doing in our day-to-day clinical practice. We also get some physiological markers in some of the patients, either clinically by insulin resistance or by knowing their C-peptide. But we are not doing for each and every patient the genetic, epigenetics, and pharmacogenomics, and this could be a future. This will make our treatment more precise for future. At this point of time, it is also very much individualized therapy, because for each and every patient, we wanted to know their eGFR, we wanted to know the comorbidities, we wanted to know their insulin deficiency. We do their age, sex, anthropometric data, and we try to treat them. But in future, there will be a genetics, epigenetics, and pharmacogenomics will decide that who are the one who will have better response and who are the one who will not have the response with this. This is one more paper which they have written along with Dr. B. Mohan Radha, who is a senior scientist from molecular genetics from the MDRF Chennai. She has written that precision diabetes is slowly becoming a reality. This paper has been in 2019, but probably in another 10 years, it may be a reality, and we may treat our diabetic patients down the line in a decade or in a 5 years or 10 years down the line in a different way, the way we are treating today. So to conclude my talk, precision diabetes medicine has evolved and now may be applied to all forms of diabetes. It involves precision diagnosis, therapeutics, prognosis, and monitoring. With respect to type 2 diabetes, there are different clusters of diabetes have been seen, and 2 unique clusters, as I told you, in India, we could find out in one of the study. The precise diagnosis of monogenic diabetes may help children with neonatal diabetes and MODY, and to go off with the insulin and to start them only on sulfonylurea. A collaborative, comprehensive, research-based approach involving all stakeholders is necessary for implementation of precision diabetes medicine to clinical practice. Certainly, the future of diabetes will become a precision medicine. With this, I once again thank you to Dr. Anuj and the organizing committee and scientific committee for giving me an opportunity. Thank you very much.
Thank you, sir, for the wonderful and inspiring presentation. Now next to the Dr. Ashish Chindal, if you want to have some question or anything.
Sure, ma'am. Sir, that was a very enriching talk. And next on stage, we welcome Dr. Rakesh Sahai. Sir is Professor and Head Department of Endocrinology at Osmania Medical College. Sir is also a consultant endocrinologist at Sahai's Endocrinology and Diabetes Clinic. Sir is President of Endocrine Society of India. And Sir is President-elect for RSSDI, which is the Research Society of Diabetes in India. Sir have multiple awards, including Fellowship of American College of Endocrinology, which he got in 2009, Best Teacher in Medicine Award from Government of Telangana. And Sir have authored various publications in many books and monograms, and have over 150 publications in various national and international journals. We welcome you, sir. Over to you.
So may I leave now if there is no question? You asked me to join, that's the reason I am here. Dr. Akanksha, Dr. Preeti.
Sir, we'll be planning the questions at the end of the session.
Okay, I thought it will be immediately after the talk only. Do you have the audience there at this point of time or no? It is not going live.
On the virtual, hardly it's going to be 3-4 audience. I can't see anymore.
No issue. Thank you.
Okay, sir. Thank you so much. So, I welcome Dr. Rakesh Sahai for the next presentation.
So good afternoon to all. Thank you to ACP for inviting me. I would like to thank especially Dr. Anuj Maheshwari, Dr. Narsingh Verma, and all the entire team of ACP India for inviting me to be here today. the topic given to me is about thyroid disorders in pregnancy, a case-based discussion. So in the next 17-18 minutes or so, I'll discuss this topic. So if you look at thyroid disorders, they're very common today. They're very common endocrine problems in pregnancy. Overt hypothyroidism occurs in about 3 to 5% of all pregnancies, and subclinical hypothyroidism occurs in much higher prevalence of 10 to 15% of all pregnancies. Hyperthyroidism occurs in a much smaller number, and postpartum thyroiditis is the other problem that is common in women during pregnancy. Now, what I'll try to do is I'll just discuss about the physiological changes of thyroid in pregnancy, and then go on to discuss in a case-based manner many of the issues that are listed here. So if you look at the changes that happen in the thyroid function during pregnancy, what happens is that the first issue is the increase in estrogens during pregnancy leads to a rise in thyroid binding globulins by 2 to 3 fold. And that leads to increase in the total hormones, the total T4 and total T3, while the free hormones would remain normal or maybe slightly on the lower side. And because of the increase in HCG, which happens in early pregnancy and peaks around the 10 weeks, the HCG has a structural similarity to TSH and can stimulate the release of T3 and T4. And it can also cause a transient suppression of TSH in the first trimester of pregnancy, late in the first trimester. Peripheral metabolism of thyroid hormones is increased, and that can lead to decreased levels of free T4 and free T3. Plasma volume is increased, and in addition to this, the fetal thyroid starts functioning from the 10 to 12 weeks of gestation, and that adds on to the requirement of iodine in pregnancy. And so it could, you could summarize all this by saying that it's a physiological pregnancy is a significant physiological stress leading to a near pathological outcome. This figure, which is taken from the Nature Reviews article, which was looking at thyroid disorders in pregnancy, and has actually highlighted all these issues in one picture, which clearly shows the factors which are increasing the maternal iodine requirement during pregnancy. Now let's look at some of the interesting case scenarios which would help us in understanding the thyroid disorders in pregnancy. So this is a 27-year-old woman who is planning for pregnancy. She has been started on folic acid. She has read about thyroid diseases in pregnancy and is concerned about that. There's no family history of thyroid dysfunction, no history of any autoimmune disorders in the family. She wants to know whether she should get a thyroid function test done during pregnancy. So what do you want to do? So if you look at the current recommendations for identifying hypothyroidism in pregnancy, it's largely based on screening using the TSH levels. According to the ATA guidelines, there is insufficient evidence to recommend for or against using universal screening with TSH at the first antenatal visit. As of now, ATA recommends only targeted screening. And whom do they target for screening? They are women over the age of 30 years, those with a family history of autoimmunity, or those with a goiter, those with a previous history of thyroxine therapy, those who are living in a presumed iodine deficient area, those who have got previous miscarriages, other autoimmune conditions like type 1 diabetes, those with infertility, and those with clinical signs and symptoms suggestive of thyroid hypofunction. So in all these situations, they would suggest a thyroid test to be done, but otherwise they would not recommend a universal screening. But if you look at the epidemiology of hypothyroidism in our country, it's much higher than what we see in the Western countries. Western countries is just about subclinical hypothyroidism, 2 to 3% of all pregnancies, overt hypothyroidism in 0.3 to 0.5%. But look at our population. In a study from Mumbai, it was the prevalence was 4.8%. Sahu et al. Showed 6.47% of subclinical hypothyroidism, and overt hypothyroidism in almost 5% of women during antenatal period. And one interesting study that we had conducted across 11 cities in 9 states of our country, we found that the prevalence was to the tune of 13.13%. For where hypothyroid using a cutoff value of 4.5%, TSH cutoff value of 4.5 micro international units per ml. So clearly showing that this is subclinical hypothyroidism again. So this prevalence is much higher then it would have been much higher if we had used the American ATA criteria. ATA 2011 criteria was speaking of a cutoff of 2.5. When we did the study, that was what was commonly being used. But when we used a TSH cutoff of 4.5, and we got a prevalence of 13.3%, and 20% of the women were positive for autoantibodies, anti-TPO antibodies. So if you look at other studies also, there was a meta-analysis of 10 eligible studies which were for understanding the need for doing universal versus targeted screening. 4 studies demonstrate that universal screening may lead to less miscarriages and pregnancy complications, and 2 of the studies demonstrate that universal screening would be cost effective also. And if you look at other studies which have looked at this issue, most of them have shown that when you do a universal screen, I mean, if you are going to do a targeted screening, you would miss out as much as 80% of women who develop hypothyroidism in the multi-center cohort study by Wang et al., while others reported as much as 30 to 60% missing out rates of detecting hypothyroidism. So it's clearly seen that based on this, the Indian Thyroid Society in 2012 itself recommended universal screening for our population. The 2019 update of the ITS guideline also recommends a universal thyroid screening for thyroid dysfunction in pregnancy. Now, the other important issue, having looked at this issue in quite some detail, I'll go on to discussing about the reference ranges of TFT in pregnancy. So there has been a lot of confusion about this reference ranges. It is seen that the reference ranges in different populations would be different, and hence there is need for they would differ by ethnicity, maternal iodine status, the laboratory assay method used, and the rigor for selection of reference population. So all these lead to variation in that, and in fact the ATA guideline of 2011 was based mainly on the reference ranges of the US population, and hence many experts felt that there was probably an overdiagnosis because we were looking at the reference ranges of the US populations, and therefore the recommendation was to use population specific reference ranges in the subsequent guideline of 2017. So if you look at the reference ranges for India itself, we would say that there are probably 2 studies which have. This is a study from Marwa et al., and they have shown the reference ranges in each of the trimesters. As you can see, the upper cutoff of the reference range is somewhere around 4.3, 4.4 in the first trimester, 4.43 in the second trimester, 4.1 in the third trimester. And if you look at another study by Rajesh Rajput, he has shown the cutoffs again. In the first trimester, the cutoff was TSH was 1.78, 4.47 in the second trimester, and third trimester was 4.64. So as you can see, these cutoffs are what we should be using for the diagnosis of hypothyroidism in pregnancy in our population. Now, the other issue that I would like to also highlight here is that if you're looking at total T4 versus free T4 measurement, there is always a difficulty in getting a good assay for doing the free T4, because it requires separation by equilibrium dialysis, which has been and this can have problems in the assay, because most of the assays that are used are not very good for doing this, and therefore we should what is suggested is that we should continue measuring the total T4 and use 1.5 times the upper limit of normal as the cutoff during pregnancy. So that obviates the need for doing a free T4 measurement. Now let's move to the second case. This is a 28-year-old lady with a history of primary hypothyroidism. She presented with amenorrhea for 6 weeks, and she was diagnosed to have hypothyroidism. About 6 years back, she was on L-troxin. She was on levothyroxine at a dose of 75 micrograms for the past 2 years. And she had a diffuse non-tender enlargement of the thyroid gland earlier when she presented now during pregnancy. Her laboratory investigation showed a TFT which was showing a TSH of 10.75, free T3 and free T4, which were in the normal ranges, urine pregnancy test was positive. The USG showed a gestational sac of 6 weeks. So what are the options that we have in this patient? Should we maintain the same dose of levothyroxine? Should we increase the dose of levothyroxine? Or should we terminate pregnancy? So these are the options that come to the mind of the physician, and the appropriate response would be to increase the dose of levothyroxine. Here it would be to increase it to 100 microgram per day, this which would mean about a 30% increase. And we need to, in fact, even before pregnancy, we need to counsel women to target the TSH to less than 2.5 prior to pregnancy itself. Once the patient conceives, she will require an additional dose of about 30% higher dose, maybe ranging from 20 to 47% higher dose. And a simple way in which you can do is increase the tablets by 2 tablets per week. Whatever the dose the patient is taking, whether the patient is taking 50 micrograms, you increase 2 tablets per week, and that takes care of the additional requirement. And this can be done before the patient comes to you. Itself, this advice can be given, and once they come to you, you can always assess thyroid function and decide the adequacy of the dose, and you can decide on adjusting the dose accordingly. So this patient who had who had increase in dose to 100 micrograms underwent a test again after 4 weeks, and was found to be in the normal range. The TSH was found to be in the normal range, and she was continued with that dose, and she had a periodic evaluation every 4 to 6 weeks, and so the ideal way would be to evaluate every 4 to 6 weeks, and preferably at least once in each trimester, if not at every 4 to 6 weeks. So coming to hypothyroidism in pregnancy, it could either be overt hypothyroidism, as we all know, where there is increase in TSH levels along with increase in along with a decrease in the T4 and T3, and there could be symptomatic thyroid hormone deficiency. While subclinical hypothyroidism is more common, where there is elevation of TSH levels without decrease in the FT3 or FT4, and this is a biochemical thyroid hormone deficiency, many times may not have any clinical features associated with that. So what are the various reasons why a woman may develop hypothyroidism during pregnancy? It may be because of autoimmunity, as we have just seen in most of our patients. Treatment of hyperthyroidism for using radioactive iodine or ablation or surgical removal, or it could be hypothyroidism of pituitary or hypothalamic origin also in some situations. But whatever the cause of hypothyroidism, it has an impact on the maternal and fetal outcomes. In the mother, it can lead to anemia, congestive heart failure, antepartum depression, eclampsia, preeclampsia, gestational hypertension, placental abruption, and so on and so forth. So a lot of problems are associated. Particularly important are miscarriages and preterm delivery and preeclampsia. So these are the 3 major problems that we are worried about. And if And does subclinical hypothyroidism also cause these problems? That's the major question that is there. And there have been a lot of data which has been, a lot of studies which have tried to look at treating subclinical hypothyroidism to see whether it improves the outcomes. And these are some things which I'll just quickly present in the next few minutes. So if you look at one of these studies, recently published studies in JCM, this was looking at subclinical hypothyroidism or hypothyroxanemia and the obstetrical outcomes. So as you can see, if you look at all the outcomes, there was not much of a difference between all the different outcomes, but the major ones which were showing a difference was prematurity and respiratory distress syndrome. So maternal serum concentration of more than 4 in the pregnancy was associated with approximately 2-fold increased risk of prematurity and RDS in the offspring. Elevated TSH level was also associated with statistically non-significant increase in the risk of fetal loss, preeclampsia, eclampsia, and low birth weight. So this is how you see that there are some factors which are clearly affected, others may be affected. Now, the more contentious issue is about where you have more conflicting evidence is the effect on the child's neurodevelopmental outcomes. So if you look at those outcomes, there's probably more of confusion in that. Mild maternal thyroid hyperfunction has been shown to have a deleterious effect on the child's neurodevelopmental outcomes in multiple cohorts. If you look at some of them, one was a Danish cohort of almost 4,000 mother-children pairs, and what we clearly see from that study was that both low and high maternal levels of free T4 in early pregnancy were associated with lower child IQ and higher likelihood of an IQ of less than 85 at 6 to 8 years of age compared with normal levels of maternal free T4. So, and if you look at another this analysis, the maternal in this analysis, however, the maternal serum TSH levels did not predict the child's IQ. Brain MRI has shown alterations in the child neuroanatomy associated with either low or high maternal thyroid function. The strongest effect was observed when thyroid function was measured between 8 to 14 weeks of gestation. So these findings suggest that the 8 to 14 week period is very critical period for the effect of thyroid hormone on fetal brain development. Of note is if you look at this longitudinal study of about 4,000 odd UK mother-child pairs, they did not show a significant association between maternal levels of TSH or free T4 measured in the first trimester and the standardized test scores of children from age of 54 months through 15 years. So clearly, there is a disparity between different studies. Some of the studies have shown some benefit of treatment, while others have not shown. And if you look at another meta-analysis of 2018 of 26 studies, they found a significant association between maternal subclinical hypothyroidism or hypothyroxanemia and the measures of child intellectual development, such as low IQ, language delay, global developmental delay. So all these were clearly shown in this meta-analysis. Although several questions remain to be answered, observational data strongly suggests an association between maternal levels of free T4 in early pregnancy and child's neurodevelopmental outcomes. Now let us look at another contentious issue, which is there in the management of thyroid dysfunction in pregnancy. This is a 30-year-old pregnant woman coming with normal TFT and strongly positive anti-TPO antibodies. So this is another scenario that we commonly see, where you have normal TFT but a increase in anti-TPO antibodies. This patient is concerned regarding the same. How would you counsel her?
You have another 2 minutes.
So if we look at 10 to 20% of all pregnancies in the first trimester are having anti-TPO antibody positivity. 16% of these women who are euthyroid and positive for anti-TPO antibodies in first trimester develop a TSH greater than 4 by the third trimester. And almost 33 to 50% of these women who are positive for anti-TPO or anti-TG antibodies in the first trimester will develop postpartum thyroiditis also. So this is how this predicts subsequent development of hypothyroidism and postpartum thyroiditis, but they could also have impact on causing miscarriages, spontaneous miscarriages. They can increase the risk of spontaneous miscarriages, premature delivery, placental abruption, and postpartum thyroiditis. Two major hypotheses have been proposed. One is that the anti-TPO antibody positivity reflects generally a diffuse autoimmune process, or it may be that TPO antibody positivity is driving the thyroid dysfunction and subsequently resulting in poor obstetric outcomes. So, a recent prospective study has shown that with recurrent pregnancy losses, they found that anti-TPO antibody positivity was associated with reduced live birth rate. I mean, they were particularly focusing on this, and they found that treatment with thyroxine increases the live birth rate significantly. However, what is the balanced view on this? The view is that universal screening for thyroid antibodies and possible treatment is not recommended for all. Pregnant women with TSH more than 2.5 should be evaluated for anti-TPO antibody status. Euthyroid pregnant women who are antibody negative, antibody positive should have a measurement of serum TSH concentration performed at time of pregnancy confirmation and every 4 weeks throughout up to mid pregnancy.
So we are short of time. Please conclude your
And what do the ATA guidelines say about pregnancy, about management of hypothyroidism during pregnancy? They speak about using pregnancy-specific ranges, which we already discussed about. And they said that if you don't have a pregnancy-specific range, use 4 as ideal cutoff, or a 0.5 difference between the normal normal persons and pregnant women. And where do they recommend treatment of subclinical hypothyroidism? While treatment of overt hypothyroidism is obviously recommended, subclinical hypothyroidism should be treated with levothyroxine in patients who are antibody positive with TSH greater than the pregnancy specific reference range, TPO antibody negative woman with TSH greater than 10, and it should be considered. It may be considered for those women who are TPO antibody positive with TSH concentrations more than 2.5 and below the upper limit of the pregnancy specific reference range.
So we are
That is
running
4
out
in
of
this
time,
case.
please.
And TPO antibody negative women also may be considered with TSH concentrations greater than the pregnancy specific reference and below 10. That is between 4 to 10. Levothyroxine is however not recommended for TPO antibody negative women with a normal TSH value. That is TSH value below the cutoff of the reference range. Now, what happens to those who are diagnosed during pregnancy? How much is the dose that is required? They have a reduction in the requirement. Many of them do not actually remain hypothyroid, and many of them can be do not require any replacement. But some of them do require. Who are those? Those advanced stage, those who have a goiter, those who have family history, positive family history of thyroid dysfunction, those with thyroid autoimmunity. They are at future risk of hypothyroidism, and these patients should be receiving treatment. And again, regarding the dose also, we had done an observational study where we found that majority of patients with overt hypothyroidism during pregnancy require more than half of the final dose after delivery, while those with subclinical hypothyroidism without a goiter and without any associated or those who are associated with higher T4 levels after delivery, they are the ones who probably do not require replacement therapy. And finally, let's look at another aspect of the story, that is this 29-year-old lady who is presenting at 10 weeks of gestation with a thyroid function which is suggestive of thyrotoxicosis. That is with the TSH which is suppressed, FT4 index which is high, T3 which is high.
Yeah, this is.
She has no previous history of thyroid disease. She's feeling well apart from nausea. She's been quite okay otherwise, with nausea and emesis intermittently throughout the day for the past 2 weeks. On examination, her thyroid is normal in size without any nodules or tenderness, and she has no ophthalmopathy also. So what do you do in this young lady who is presenting
You can call him on
with
mobile.
these symptoms and with this report? Would you start her on methimazole? Would you start her on PTU? Would you obtain a radioiodine uptake scan for her? Would you repeat her thyroid function test, or would you do a thyroid ultrasound? So if you look at this lady, look at the various problems in pregnancy with hyperthyroidism. This can be because of Graves' disease, which is the commonest cause, subacute thyroiditis, which is the next commonest cause. Then you have other causes like toxic multinodular goiter, toxic adenoma. A TSH dependent thyrotoxicosis can also happen, and exogenous T3, T4 can also be factitiously causing thyrotoxicosis. Pregnancy specific conditions are the ones which have to be kept in mind. Hyperemesis gravidarum is one common condition. Hydatidiform mole, an uncommon condition, but should be kept in mind. HCG mediated hyperthyroidism. So these are all the situations that have to be kept in mind. An important thing is that these hyperthyroidism also can lead to complications, maternal complications like congestive heart failure, thyroid storm, preeclampsia, spontaneous abortions, or a preterm delivery also. While the fetal complications mainly are in the form of neonatal deaths, 2 to 3-fold increase in frequency of low birth weight, infarcts, and infants. The fetal and neonatal hyperthyroidism is another common problem that is noted in these patients, and congenital malformations are also likely to occur apart from IUGR. Now, if you look at what the ATA guideline is saying, is that in newly pregnant women, a TSH who are on low doses of methimazole or or PTU, they can actually be stopped from discontinued the medication because there's an increase in the requirement of thyroid hormones during pregnancy. And this decision should be taken after taking account the history, the goiter size, the duration of therapy, and all these things have to be taken into account. And you should continue monitoring the patient even though you may not be giving thyroxine at that time. If the pregnant woman remains clinically and biochemically euthyroid, test intervals may be extended from 2 to 4 weeks during pregnancy to 3 to 4 weeks. And what is also recommended is that PTU should be used as preferably in the first 16 days. What happened? Vigilized regarding whether they require treatment or not. Graves' disease is commonest cause of hyperthyroidism, and it has to be distinguished from gestational thyrotoxicosis and trophoblastic disease. Treatment is generally with antithyroid medications, PTU being the first of its kind, and neomercazole in subsequent periods. So with that, I'll conclude and I'll be happy to answer any questions.
Thank you, sir, for the outstanding presentation. And at the same time, you made it very simple to understand. So with this, I think we move on to our next speaker and the next topic. So I welcome the next speaker, that is Dr. Renu Sehgal, who is a MD, MAMS, FRCP, FACP, Department of Medicine, and JNU Institute of Medical Sciences at Jaipur. She is a consultant rheumatologist, Apex Hospital, Jaipur. She worked as a senior professor, head of the Department Medicine in the rheumatology clinic. Then he has been also experienced in SMS Medical College and Group of Hospitals, Jaipur. Former Professor Medicine Department, Rheumatology Clinic, Mahatma Gandhi Medical College, Jaipur. And she is the President, Rajasthan Chapter of Indian Rheumatology Association. So over to you, ma'am, for the next topic.
Hello.
That is large vessel vasculitis, approach to diagnosis and management. Dr. Renu.
Good afternoon, everyone. At the outset, I feel grateful to Dr. Anuj Maheshwari and Dr. Verma for giving me this opportunity. I'll be talking about large vessel vasculitis, approach to diagnosis and management. Large vessel vasculitis means inflammation of aorta and its major branches. There are two types of large vessel vasculitis, giant cell arteritis and Takayasu arteritis. And in both, there is granulomatous inflammation and thickening of the vessel wall with compromised lumen leading to decreased tissue perfusion. There are certain mimics of large vessel vasculitis, and these mimics we can very well confuse with the primary large vessel vasculitis. The inflammation of aorta and its branches can occur in Behçet's disease, Cogan syndrome, rheumatoid, SLE, ankylosing spondylitis, relapsing polychondritis, IgG4 related disease, sarcoidosis, and then connective tissue disorders and certain infections like syphilis, TB, and HIV infections. Then giant cell arteritis is inflammation of medium-sized and large sized vessels with predisposition to affect the cranial arteries. It is more common in people of North European descent, and there are two types of large vessel vasculitis, cranial vasculitis or large vessel vasculitis. So GCA is of two types, cranial and large vessel. This is latest criteria, just came in market. It is just 10 days old. 2022 American College of Rheumatology and European Alliance of Associations for Rheumatology classification criteria for giant cell arteritis. And when we are applying this criteria, we have made a diagnosis of medium vessel or large vessel vasculitis, and we have excluded the mimics, which I narrated in the previous slide. And absolute criteria is at the time of diagnosis, the age should be 50 years or more. And these are the additional clinical criteria. Points are given against each and every clinical criteria. The morning stiffness in shoulders and neck, sudden visual loss, jaw or tongue claudication, new temporal headache, scalp tenderness, abnormal examination of the temporal artery, then ESR 50 millimeter at the end of 1 hour or more, maximum CRP 10 milligram per liter or more, and positive temporal artery biopsy or halo sign on temporal artery ultrasound. This has got the maximum points +5. Bilateral axillary artery involvement, FDG PET activity throughout the aorta. If you sum up the score of these 10 items, a patient scoring 6 points or more, we can classify that patient under the GCA, that is giant cell arteritis. Specificity of this criteria is 95%. Other features of giant cell arteritis are constitutional features. The patient may present to us with low-grade fever, fatigue, loss of appetite, weight loss, arthralgia, arthritis, myalgia, etc. The patient may come to us with PO or FUO. The polymyalgia rheumatica is seen in 40 to 60% of the patients. Aching and prolonged morning stiffness of the shoulder and pelvic girdle can occur. Pulses and blood pressure in upper and lower limbs may be reduced. Then vascular bruit may be heard over the carotid, subclavian, bilateral axillary, abdominal and femoral arteries. Aortic root dilatation, aortic insufficiency, thoracic aortic aneurysm and its rupture can occur. There can occur ocular cranial nerve palsy because of involvement of the vasa nervosum leading to diplopia. Acute monoocular blindness, transient or permanent can occur. Retinal, choroidal or optic nerve ischemia lead to partial or complete vision loss. This is a thick, tender and cord-like temporal artery in one of my patients. Takayasu arteritis is idiopathic, chronic, granulomatous, inflammatory panarteritis of the aorta and its major branches. The women outnumber males in a ratio of 3 to 4:1. It has got highest prevalence in Asian countries, including India. It has got self-limited monophasic course in only 20%. In rest of the patients, it is progressive, relapsing or remitting course. Takayasu arteritis has 3 phases, stages. Pre-pulseless disease, which is characterized by constitutional features, just like the constitutional features I just described in the giant cell arteritis. Then inflammatory phase, when there is vessel wall inflammation, stenosis or fibrotic phase, there occurs arterial stenosis and ischemic symptoms. And again, when applying this criteria, this is latest criteria, published 10 days ago. Consideration when applying this criteria, we have made the diagnosis of large vessel vasculitis, mimics of large vessel vasculitis excluded, and absolute requirement is age 60 years or less at the time of diagnosis. This was earlier 40 years, now it is 60 years. And there is evidence of vasculitis present on imaging. Then additional clinical criteria, female sex, angina or ischemic cardiac pain, claudication of extremities, vascular buoy, reduced pulse in upper extremities, carotid artery abnormality in the form of carotidynia. The systolic blood pressure difference in the arms is more than 20 millimeter mercury or more. And the additional criteria on imaging, 1 artery involvement, 2 artery involvement, 3 artery involvement, according to that points are given. Symmetric involvement of the paired arteries, abdominal aorta involvement with renal or mesenteric involvement. It has got maximum +3 points. A patient is scoring 5 points or more, we can classify under Takayasu's arteritis. Specificity of this criteria is 99%, and classification criteria we should always apply when we are recruiting patients for research trials, where we want to be 100% sure that we are dealing with the Takayasu arteritis or large giant cell arteritis. If we are sitting in the OPD, even if a patient is scoring 3 points, we can diagnose that patient as having Takayasu or giant cell arteritis. So classification criteria and diagnostic criteria are not synonymous. The other features of clinic Takayasu arteritis is involvement of the subclavian artery, which is seen in 90% of the patients. Left is affected more than the right, and there can occur upper extremity claudication, unequal pulses on the 2 sides, bruit over the narrowed arteries. Raynaud's phenomena is occasional, so is the gangrene, because a good collateral circulation develops. Then skin involvement, erythema nodosum, pyoderma gangrenosum, ulcers may occur, carotids, vertebral arteries, retinal branch arteries, aorta involvement in 50% of the patients. According to that, the patient may have visual changes, syncope, transient ischemic attacks, stroke, bruit, carotidynia. Then the patient may have, because of aortic root involvement, aortic insufficiency, hypertension, abdominal pain, heart failure, CAD, and CVA. Renal artery stenosis is very common. Bruit over the renal arteries may be heard, and celiac and mesenteric artery involvement leads to postprandial angina. The investigations, the patient has leukocytosis, thrombocytosis, normocytic normochromic anemia. I remember one of my patients presented to us with fever and 23,000 counts. The patient was not at all toxic, and when we examined, there was bruit over the carotid arteries. There is high ESR CRP, though it may not be elevated in all the patients. IL-6 is a better marker than ESR in these patients. And low albumin, high alkaline phosphatase may be there, high C3 and C4 may be there. And novel biomarkers like MMP3 and 9, serum amyloid A, osteopontin, anti-pro-BNP, calprotectin may be raised, but these are not routinely available. Imaging is preferred over temporal artery biopsy according to the current guidelines. Imaging of the aorta and its major branches is recommended ideally before or within 1 week of starting steroids, and we can find stenosis, occlusion, dilatation, or aneurysm. And these are the various imaging modalities which I will be discussing one by one. The ultrasound with color Doppler. This is the first line imaging modality for the diagnosis of giant cell arteritis according to the current ACR and EULAR criteria. GCA, we should look for the temporal and axillary arteries. Takayasu, subclavian, carotids are more commonly affected. We should look for these arteries. And aortic inflammation, color Doppler is not recommended unless and until we do the transesophageal ultrasound. Nowadays, there are modern ultrasound machines with a resolution of 0.1 millimeter, and it can detect small changes in the wall thickness. This is typical halo sign. The specificity of this halo sign is 96%. There is this is lumen and hypoechoic vessel wall because of inflammation, and with steroids, it disappears. This sign disappears in 2 to 4 weeks. And this image is courtesy of Dr. Shinoy from Kochi. Then compression sign, if we compress the patient with giant cell arteritis, we can still visualize the lumen. The compression of the lumen with the transducer, we can still visualize the lumen. And this has got specificity of 100%. This is compression sign. If we press the normal artery with transducer, the lumen will disappear. So if it persists, it is compression sign. This CT angio, we can find various types, type 1 to type 5, depending on which part of the aorta is involved. If there is involvement of the coronary arteries, we write C+. If there is involvement of the pulmonary artery, we write P+. And radiation exposure is more, so it is not favorable for the younger patients. We can see the coronary artery involvement, cardiac aneurysms, and specificity of this criteria is 100%. This is CT angio, and you see the subclavian at its origin is showing narrowed lumen. Then MRI and MR angiography, it is the modality of choice in Takayasu arthritis. The MR angiography, it is yields sensitivity and specificity of 100% for Takayasu without any radiation exposure, and MRI shows enhancement if the vessel wall inflammation is there. We can also see the lumen. And cranial giant cell arteritis, there is high resolution MR angio will find the stenosis, and then here again there is a stenosis from the arch of aorta, the vessel showing and this narrowing. 18-fluorodeoxyglucose PET, that is PET scan, can show the arterial wall inflammation in the pre-stenotic inflammatory stage. In Takayasu, there is involvement of the common carotid pulmonary artery, which is more than that seen in the giant cell arteritis. The increased uptake of FDG may also be seen in infections, atherosclerosis, and besides the vasculitis, we can see the changes in atherosclerosis also. And it is not recommended for the assessment of cranial arteries. This is the PET scan. We compare it with the liver uptake, and you see here the increased uptake is seen in the thoracic wall aorta, and this is PET CT scan, and it is large vessel giant cell arteritis. We all know PET CTs have limited access, high cost, long procedure time, and the PET CT have more radiation than CT alone, but the functional image is better. This is a hybrid PET MRI showing the increased uptake in the arch of aorta, subclavian arteries, thoracic aorta, and the radiation exposure is much less than the PET CT. Only 20%, and good to assess the disease activity also. This is wide MRI showing the thickening of the wall because of inflammation, and also the large vessel vasculitis showing the increased uptake in the aorta. The histopathological diagnosis is done only when there is uncertain pre-test possibility and ultrasound has failed to confirm the diagnosis of giant cell arteritis. Then the biopsy should be done of the temporal arteries. Because of skip lesions which are present in the temporal arteries, it may be missed in 44% of the established giant cell arteritis. The biopsy should be 1 centimeter in length because of the skip lesions. Bilateral biopsy are not routinely recommended, but if there is strong clinical suspicion and the one side biopsy does not show changes, then we can go for the contralateral temporal artery biopsy. And in large vessel giant cell arteritis, temporal arteries may be normal in up to 42% of the patients. Now, what are the changes? Transmural inflammation occurs. There is fragmented internal elastic lamina. The giant cell infiltration occur, which coalesce to form a giant cell. So these are the changes which can be seen in temporal artery in giant cell arteritis. We should monitor the disease activity by symptoms of ischemia, clinical findings, ESR, CRP, imaging. We will show vessel wall edema and human diameter, but the false positive and false negatives do occur in imaging. And this is Indian Takayasur clinical activity score. The proforma can be downloaded from the internet, and it is a very good form for monitoring the disease activity. Remission means absence of everything normalizes. The management of large vessel vasculitis, we should manage the cardiovascular risk factors like hypercholesterolemia, diabetes, and all. Then confirmed case of giant cell arteritis, we should start with 1 milligram per kg of prednisolone and reduce the prednisolone in such a way that at the end of 1 year we reach 5 milligram per day. If there is high risk of adverse events with prednisolone like diabetes, hypertension, or osteoporosis, or there is relapse or refractory disease, then we should start the glucocorticoid sparing agents. These are the various glucocorticoid sparing agents, and we should escalate the prednisolone dose if possible. And if there is sustained remission, we should continue the steroid taper. And if there is threatening diplopia or vision loss, then IV methylprednisolone pulses 250 to 1000 milligram per day should be given for 3 days. Antiplatelet drugs are to be given when the patient has angina or MI or the transient ischemic attacks or the patient has a stroke. Surgical interventions ideally should be done when the patient has quiescent disease. If the disease is active and there is critical ischemia or dissection or there is aneurysm, then we can go for the surgical intervention in such critical situations. If the patient comes to us with Takayasur, we have made the diagnosis, then we can start with the prednisolone. Localized disease, we can start with the lower dose of prednisolone. When upfront, we should start steroid sparing agents, unlike in giant cell arteritis. And at the end of year, the dose of prednisolone should be 10 milligram per day. It is higher than giant cell arteritis. If the patient has refractory or relapsing disease, we should increase the dose of prednisolone, and we should consider alternative glucocorticoid sparing agents. Like if we are giving mycophenolate, we can start methotrexate. If we were giving azathioprine, we can start the mycophenolate. And if there is sustained remission, which is our target, we should continue steroid taper. And antiplatelet drugs, surgical endovascular intervention, the same indications which I narrated in the previous slide. And these are the various trials showing methotrexate, azathioprine, mycophenolate, tocilizumab, anti-TNF agents, showing clinical benefits, improvement in the ESR and CRP, and there is retardation of the angiographic progression. And these are naturally occurring therapies like resveratrol, curcumin. They have also shown clinical benefit, and there is improvement in the ESR and CRP. If the disease is refractory, that is angiographic progression is occurring despite steroids, steroid sparing agents, frequent flares, 3 or more in 1 year, or persistent disease, there is need for surgery, so we should use biologicals. Biologicals, whenever there is disease relapsing or refractory, increase the dose of steroids, add the immunosuppressants and biological then it is given for 52 weeks, and if fail, then TNF inhibitors may be tried. And the TNF inhibitors are infliximab, adalimumab, etanercept, and both have shown that there is steroid sparing effect, and there is angiographic progression which is retarded by both the agents. Giant cell arteritis Indian scenario, only 72 cases have been reported, and headache was the presenting symptoms. Tenderness over the temporal artery and ESR was high ESR 94 millimeter mean was seen in 46% of the patients. So take home message is Takayasu arthritis is very, very common in Asian countries, including India. Patient may present as a case of PUO, limb claudication, renovascular hypertension, carotidynia. Giant cell arthritis may be underdiagnosed in India. Therefore, it is important for the clinician not to miss the diagnosis of this rare disease and to prevent the serious complications like vision loss. Treatment should be started as early as possible to prevent complications in both the conditions. And thanks for the patient here.
Thank you, ma'am, for the excellent presentation. It's a pleasure to listen to you. Now, house is open for the questions. Okay. Any questions? I think there are no questions. So with this, I conclude the session. And I would like to thank all the faculty members and our judges for their patient listening and their attention. Thank you so much. So the next session would be started at 4:55 and the moderator would be Dr. Shivam. Thank you.
Sure.
So I welcome Dr. G.B. Satur. He is MBBS 1974 from Karnataka Medical College, Hubli. He is a MD physician and he did his MD in 1977 from Karnataka Medical College, MRCP in 1981 from Edinburgh, UK, FICC 1995, honorary physician to Cancer Hospital, Hubli, and a number of prestigious institutions in the region. So he had an immense professional experience in UK as well. He stayed in UK for 6 years from 1978 to 1983, and he has an advanced experience in cardiology, diabetes, and clinical trials on sotalol secondary prevention of MI done at Newcastle upon Tyne. So over to you, sir, Dr. G.B. Satur. Sir, unmute yourself, please.
Can you hear me now?
Yeah, very well, sir.
Okay, I just share the slides. Are the slides visible?
Yes, sir.
Okay, I'll just try to put it on. Yeah, okay. Thanks, Madam Rastogi Akshanka. Am I pronouncing it correctly?
Sir, it's Akanksha. It's Akanksha.
Yeah, correct. Akanksha. Correct. Dr. Akanksha and Dr. Vinod Kumar, thanks tremendously. And indeed, it's my great pleasure. And thanks to Dr. Anuji, my friend Dr. Srinivas Murthy, and all other organizers. I had to be there physical, but I sprained my right ankle yesterday in Calcutta airport while returning after an ADA conference. So nice to be indirectly facing you all. I'll be speaking on something like how do we go about exercise schedule. Your genetics load the gun and your lifestyle pulls the trigger is what is famously known. If you can just see this, there's an updated risk by the Lipid Association of India. Whatever the class of ischemic heart disease, ASCVD, may it be low risk, may it be our recently defined extreme risk group, which we defined and we have printed it in the November 2020 JAPI. And whatever the risk, what is most important is lifestyle. Very fortunately, higher the risk of ASCVD, more better off, more help from lifestyle than the lower risk. Now, there are many invasive techniques and many treatment strategies, but nothing equals a physical activity. You can look at the physical inactivity. It can lead to dyslipidemias, hypertension, smoking, some other novel risk factors, obesity, diabetes, age, all of them contribute to atherosclerosis. And Indians, most of the Indians are known for a sedentary lifestyle. You see many couch potatoes in India. And if you are not into physical activity, these are the risks: all-cause mortality, cardiovascular disease mortality, cardiovascular disease, type 2 diabetes, and cancer colon and the lung. The advantages of exercise are huge. On this, you can see here, these are the advantages you have from the aerobic exercise. Look at this, the insulin resistance, 30 to 85% improvement, in which case you could control diabetes by minimum tablet involvement. Abdominal obesity, Indians are known as thin fat Indians. So a 30% reduction in the intra-abdominal fat, and even this antithrombotic exercise, hypertension, a small amount of reduction in both systolic and diastolic pressures. So there are many advantages. Cardiovascular system, hypertension, it reduces some lipids, and it also reduces the stroke. But what is most important is sarcopenia. We all lose 1% of our muscle mass every year after we become 50 years. And this muscle mass loss is more in females than in males. Look at this slide, very beautifully shown. You lose 12% in isometric knee extension strength by hardly being muscle mass is lost only with 2 weeks. Disease-related immobility, which we saw in recent COVID-19 epidemic. So, and there are many advantages like release the stress, improves arthritis, and there are a lot of effects on the lipids too. It reduces LDL by 3 to 6 milligram, reduces non-HDL, and no consistent effect on HDL, but it does improve HDL if you do around 300 minutes per week of exercise, not the regular 150. Many excuses, especially Indians, we are known to have excuses. I don't have enough time. I get bored. The gym is too intimidating. I don't like it. I am too tired. I don't know what to do. I need to take care of my family. Hell with myself. I don't care about myself. Now, recently, there has been a plethora of cytokines being released, which are being called as exerkines. Whatever exercise you do, whether aerobic or weight managing, they release what we call as myokines in the blood from muscle, from liver, from fat cell, pancreas, and the heart. These cytokines enter the blood and or some in the extracellular vesicles. These released cytokines are also the released exerkines. They in turn kick, for example, the heart, the brain, the muscles. For example, heart should increase heart rate and a blood pressure. Muscles should be able to tolerate the exercise. This is one of the recent theories, and you can see how many exerkines are released in the blood. This is an ICMR study, the previous one, which also shows both Indians in rural and in urban, both women and men have an increased physical inactivity. This is a very interesting slide. Look at the right side, an android obesity. Look at the left side, the gynoid obesity. Both of them have the same BMI, but one on the right is more prone for metabolic risk because of the being a thin fat Indian that you see. Therefore, very important, I always tell in my lectures, tail of the tape is waist, not waist. See that you keep your waist to less than 90 centimeter if you are a male, less than 80 centimeters if you are a female. The activity advised by some physical activity guidelines and many guidelines, including European, American, and including in India, especially RHSDI and even Lipid Association of India has come out. It means the same 150 minutes per week, which is around 30 to 45 minutes for 5 days a week. And then muscle strengthening exercise. One could easily do muscle strengthening by using the dumbbells. And for the lower limbs, you should half sit for about 20 counts, for about 20 reps. That's what you should do. Short bouts are now a modern thing. I just tried to simplify it. I have called it 15 by 2 rule or a 10 by 3 rule. What does this mean? Either go 15 minutes twice a day, maybe around your house, and when you come back, go around your home, so that either 2 bouts of 15 by 2 or 3 times before breakfast, before lunch around wherever building you are working, and before dinner, 10 by 3 rule. So you can split up, not as efficacious as the continuous 30 to 45 minutes moderate or vigorous intensity. Nevertheless, something is better than nothing. Now you have many exercises. You can just see there, leisure walking would make you spend around 85 calories. A brisk walk, that's what we advise. Look at that. It is almost double the energy that you do. Many types of exercise, strengthening exercise 2 to 3 times a day. Look at this slide here. All these girls are half sitting. This is very important. You must strengthen your core muscles. And flexibility exercise is very important. You may go to gym and you may have a 6 abs abdomen, but if you are not able to catch something sitting on the back in the interscapular area, you don't have flexibility. So flexibility is extremely important. And of course, balancing is very important. As you age, your falls will decrease. And diabetic foot, we know all this. I already talked about you. Of all exercises, the prize goes to brisk walking. It's very easy, suits all ages. What you need is only 2 things. 1, a willpower, either to walk 2 times, 3 times, or at a one shot, or a good pair of shoes. Shoes cost anywhere from 3,000 to 2 lakhs in India. So depending on your purse, buy the shoes. Talk test. How do you know whether you are into vigorous activity or a moderate activity? When you are being active, try talking, not singing. Moderate intensity activity, if you are breathing hard but can still have conversation with your colleague next door, then it's a moderate. But if you can say only a few words, I'm going. If it is like that, then it is a vigorous intensity exercise. If you can talk in a slow tone, it's moderate intensity exercise. There are 1,440 minutes in every day, and you should be able to schedule at least 30 minutes. If I was physically present there, I'd ask you to raise your hands and see how many of you do at least 30 to 45 minutes exercise 5 days a week. That would be very important. And of course, prolonged sitting is new smoking. And we know recent even European guidelines said you should walk about even when you are sitting on a chair every 45 minutes or 30 minutes for about 2-3 times. There are weekend warriors. These are the heroes who exercise only over the weekend and not really advisable. But still, as I said, something is better than nothing. This is European guidelines, the 5S. Sitting prolonged is not right. Stepping, keep walking. Sweating, you must sweat so that you have done a proper physical activity. Strengthening exercise, which I already told you. And sleep is something that is given more importance, around 7 to 9 hours of sleep. Unfortunately, in today, we do not see this. I got it in air flight to Amsterdam some years ago. Now, this is how women were classed as hourglass, spoon, rectangle, triangle. Even in fact, men are not exception with the obese abdomen. Today, there are 46% of the women who are rectangle. And this hourglass deformity is envied by the women itself on the women. There's a beautiful story in Mahabharata. When Draupadi was taking a bath in one of the lakes, all the girls who were maids and who were looking after her, when she was bathing, they looked at her and said, "Wish we were men." In other words, to say how being physically fit matters. So it's very important, both men and women, that we should have proper exercise. Again, as I told you, male, female, both of them in India have high amount of inactivity. These are all recommendations I don't want to go through. This is our lifestyle modification. This whole article is entirely written by me, which has appeared in JAPI. We do these activities regularly in the Lipid Association of India. I already told this. Moderate intensity, what are they? Walking brisk, recreational swimming, bicycling, if you have good roads and a side of the road, which is not there, unfortunately, in India. Roads have more holes than a proper road in any city. You can play tennis, active yoga is okay, but not as good as the activity. Vigorous intensity, talk test we saw. And how much should the heart rate be? You can look at here, somebody the age of 36, you minus in 220 and be in the burning zone of 60 to 70% of your target heart rate. And once you go into aerobic zone, you need not reach the top end of the heart rate, but 70 to 80% of the heart rate is okay. And limit screen time, very important. You have to start making in the children. If you limit screen time, your children will. If you go home without talking to your wife and children, hook onto the mobile, even they will hook onto the mobile. What you do it, they will do it. Yoga really not very helpful. You can see that role of yoga is okay, but recent evidences show that the aim of the review was to systematically assess a meta-analysis of the effect of yoga, and it drew the conclusion yoga might reduce blood pressure, heart rate, waist circumference, but these should be used as ancillary intervention like a pickle in the diet, not a main diet. Unless you do something like Iyengar of Pune, who lived 92, or some other guys who do half a day of yoga. But you and I can't do it. So this is only to be used as a pickle in your diet. So it is only exercise that is much better than a diet, which also is important. Stopping smoking is important. Diet is important for physical activity, but exercise is the primemost. Exercise. There is an alternative. If you don't want to exercise, the best alternative is to get hospitalized with some illness later date in your lifestyle. So this is the last slide. All said and done, with so much of media trying to sort of bang each one with so much of information, what ultimately counts is each individual is a tailor-made treatment, and physical activity is not tailor-made. Thank you.
Thank you, sir, for discussing such an interesting topic. I think exercise is the need of the hour. And I loved your ending that says the alternative of exercise, not doing exercise, is getting hospitalized. So thank you so much, sir.
Thank you. Yeah, thank you. Thanks a lot. Yeah. Any questions? Want to take any questions?
Dr. Satur, I have no question, but I would like to congratulate you for a wonderful presentation and
thank you, sir.
Giving quite minute details of different forms of exercise. And there is a famous man who said, if someone doesn't find time for illness, he will soon find time for. If someone doesn't find enough time for exercise, he will soon find time for illness. That is what you have.
How lovely. How lovely. May I also extend Dr. Vinod Kumar, lovely said, because of your vast experience as a professor in the medical college, there is also a nice joke I read. It said there was a guy who was driving along the highway and the next door guy sitting to him said, hey, your petrol is finishing off. You have to refill. He said, I have no time. I have to reach early. So this is how things go on. We are not very attentive. I think physical activity must be an attentive job and individualized.
Well, I think if there is no question, there is one more quote I would suggest. Someone said that if exercise could be dispensed as a pill, it will be the most precious medicine in the world.
How lovely, sir. Very well said.
Absolutely. So shall we move to the next topic?
Thank you, Dr. Akanksha. Yeah.
Yes, sir. So I feel immense pleasure in welcoming Dr. Vinod Kumar, Professor Emeritus, for the next talk. So Dr. Vinod Kumar is a MD, FICP, FIACM, FAI, MS, FGSI, consultant physician, former President Emeritus, formerly Professor of Medicine and Head, Geriatric of Institute of Medical Sciences, New Delhi, member of WHO Expert Advisory Panel on Aging and Health by WHO Headquarters, member of National Council for Older Persons, recipient of four Lifetime Achievement Awards from the Indian government, AIMS, and Indian Aging Congress and Jan Seva Foundation, and a teacher award from the Indian College of Physicians. It is so good to see you, sir, here, and my gratitude goes to you for all that you have done for us, for me, for all the DNB students, for inspiring, guiding, sharing, and shaping our future. I would like to extend my thanks to Dr. Vinod Kumar. So what I am today is all because of him, and he has till now, I think more than 100 students have done DNB under him. Thank you, sir. Thank you so much.
Well, thank you, Dr. Akansha. It is my great pride that I am speaking under your chairpersonship for the first time, and I wish to have such occasions again and again. And I would like to express my grateful thanks also to Dr. Anuj Maheshwari, Dr. Narsingh Verma, Dr. Srinivas Murthy, and other organizers who invited me to deliver this talk. I would be speaking on the subject of dementia, which is a dreadful and irreversible progressive disease which has no cure and it results in certain death. I would like to highlight very briefly how dementia is accelerating in its epidemic proportions all over the world, including our country, how early stage of dementia can be confused with normal aging individuals, and how to go about preventing such a catastrophic illness at a population level. Of course, for the lack of time, the pharmacological treatment and advances in drug management for dementia will not be a part of today's presentation. So I will just put them on the slideshow. You can see the slideshow now? Can you?
Yes, sir.
Okay. So why dementia is called an emerging epidemic in India? It is already a pandemic in the West where life expectancy is high. It is an age-related disease. Worldwide, one new person with dementia every 3 seconds is detected. Prevalence at the age of 65 is about 2 to 3%, but it keeps doubling every 5 years to reach about 40 to 50% at the age of 90. Globally, there are 50 million, 82 million, and 152 million people with dementia as targeted in 2017, 2030, and 2050. With regard to India, the corresponding figures are 5 million, 7.5 million, and 15 million persons with dementia in 2021, 2030, and 2050. Now, this is the disease burden as far as our country is concerned over time, shown from 2005 to 2050. The bottom two colors, the deep blue and the light blue, indicate the progress of disease burden over the about 50 years, and they represent people who belong to the age group of 65 to 75. But you will realize that the above four colors, which represent people from advanced ages groups up to the 90 plus, here after the year 2030, there is going to be a steep rise of patients with dementia in our country. What is dementia? It is an acquired syndrome, and by definition, it has to be a conscious patient. The main feature of dementia is memory impairment, although it is present in most cases, not in 100 cases all the time, and it is associated with at least one of the following: aphasia, that is, there is a difficulty in communication, a speech problem. Apraxia is failure to carry out familiar tasks that we carry out day to day. Agnosia is failure to recognize people, places, and objects, and executive functions are impaired, like reasoning, judgment, decision making, and so on. And finally, they are impaired in all their activities of daily living, like bathing, taking feed by themselves, toileting, shifting from bed to floor, something like that. And they are not capable of performing in social environment. So they become very dependent on others for day-to-day activities. These are the warning symptoms from the clinical aspect. Memory, I have already told. Perception means that they are not able to understand the world around them. There is all time either misconceptions of events, misidentifications, hallucinations, delusions, and time shifting. Reasoning, attention, and concentration power is less in dementia patients, much more than what would happen in normal aging individuals in advanced ages. They cannot think properly. They cannot take any judgment, and about language I have already spoken to. And this set of symptoms must be severe enough to interfere with a person's ability to function in order to make a complete diagnosis of well-advanced dementia. In the later stage, they get all kinds of behavioral symptoms, agitation, anger, apathy, and so on. Now, this is gross appearance of Alzheimer's brain as compared to that of healthy brain. You will see that on the right side, the brain of Alzheimer patient is smaller in size. It may be puckered. The sulci are broad. The cerebral atrophy is there, and there is a ventricular dilatation more than what you would expect in an aging individual. These are the inside histological changes in the brain. On the right side, again, Alzheimer's disease, there are two major changes histologically in Alzheimer's disease. One is neurofibrillary tangles. They are intracellular bodies composed of certain proteins called phosphorylated tau proteins. The other histological hallmark is the presence of amyloid plaques, which are extracellular bodies, and they are composed of amylo-beta proteins. Now, dementia in our country also happens to be a highest disability out of various chronic diseases, and it counts only after blindness. The percentage contribution to the years lived with disability is also highest in cases of dementia only after the blindness. For example, as shown at the bottom of this picture, yes, so it is about 11.9% contribution of dementia to years lived with disability. In addition, although not written on the slide, but I would like to inform you that dementia people live with disability for as long as 7.4 years, which is only second to blindness. No other chronic disease patient lives with such a long years of disability. Now, this is the global figure as of today for 55 million. of patients with dementia. In 2015, there were 46.8 million, and this is set to rise further and further. The individual figures on the screen show the number of dementia patients in millions in different world regions. This is how the patients of dementia in terms of millions, in terms of number, go on rising from 2005 till 2050, as this slide shows. I am sure it's going to rise further also. And this rise is faster than many other countries, and it is direct effect of increasing age and life expectancy of our population that is going on at this stage. This is the comparison of disease burden amongst people with dementia aged more than 60 years in India when compared to Western countries like UK and USA. You will again find that India is overshooting as far as the disease burden is concerned in terms of dementia. And it also speaks of that there is an increasing number of older people going to live in our country, and it will continue for a long time, and as shown in this slide, at least for 2050. But it also shows a striking finding that in England, in UK, the increase in dementia is not that fast at all, and USA lies somewhere in between. Now, how to recognize dementia? A, B, C, activities of daily living, behavior problems, and cognitive decline. Cognitive decline is something like forgetfulness, misplacing objects, difficulty in recollecting phone number, recognizing people, confused about orientation of time, judgment problem, decision-making problem, behavior problems, as I said earlier, but in addition, they have a tendency to speak repeatedly the same thing, the frustration, they shout and they sometimes wander out and lose their way to return to their home. Activities of daily living I have already alluded to. And this is some differences between a normal aging individual versus aging people with dementia. And that is one of the reasons why family members bring their elderly patient with dementia very late, because they often dismiss it as because of normal aging. In normal aging, a person may occasionally forget the date, time, or friend's name. It happens to many of us. But in dementia, they not only forget these things, they even forget that it is morning, it is noon, or it is evening, and not even recognize a friend, a close friend. The second difference example is that a normal aging person often remembers the name of misplaced object. If I have misplaced a bunch of keys, I would keep searching it. I will know that I have misplaced a bunch of keys. But a dementia patient may not even remember what he has lost. So he is in no position to search. The third difference is the normal aging individual can perform ADLs unless they are physically too weak. That is a different story. And they observe social etiquette. They know how to behave in a crowd, how to behave within friend circle and other. But dementia patients are unable to perform ADLs, and also they socially carry out sometimes unaccepted acts in public which are not acceptable in a normal circumstances. And there are many other unique things that one can find out. For example, not knowing what a toothbrush or telephone is meant for. That is because there is a visual perception difficulty, and also they also do not know how to carry out a task that they were carrying out before. Now, these are the four major types of dementia. Commonest is Alzheimer's disease. Next is vascular dementia. Third is Lewy body dementia. And last is frontotemporal dementia. These are very briefly the features of various kinds. Alzheimer's disease is slow onset, early memory problem. They have apathy, depression. And as I said earlier, plaques and tangled deposits are the hallmark. Vascular dementia follows a post-stroke. Either it is a single large stroke or maybe a result of multi-infarct dementia, lacunar infarct. The memory problem is little less in the beginning, and the progression is stepwise. Lewy body dementia, here the memory is a late feature, memory impairment. It has a fluctuating course very notoriously. Hallucinations and Parkinsonian features are important in this, and the deposits are of a protein called alpha-synuclein in the brain. Frontotemporal dementia, again the memory impairment is a late feature. There are personality changes because the frontal lobe is involved. They behave differently and they carry out disinhibition. that is unacceptable act in public. And it must be reminded that more than one type of dementia can exist in the same patient, giving the term mixed dementia. Only 10% of dementias are due to reversible or treatable causes. All the other 90% causes are irreversible. I will not go into the details of the individual causes of reversible dementia, but I would suffice it to say that thyroid deficiency, vitamin B12 deficiency, brain tumor, or chronic sodium deficiency are some of the causes that one should know. And it is important for the physician to detect whether a dementia in a given patient is reversible, because he can treat it and the patient can go home happy. So who has the risk of getting dementia? These are the risk: head injury, hearing impairment, tobacco smoking, alcohol, social isolation, depression, air pollution, hypertension, diabetes, obesity, physical inactivity, and very importantly, low educational or literacy level early in the development of, or maybe child or adolescence. These are all modifiable risk factors. Something can be done about it. But there are non-modifiable risk factors like increasing age. Age cannot be modified. Female gender have little more of dementia. Family history and genetics, because a small proportion of dementia patients run in families and they have some chromosomal abnormalities. Down syndrome is vulnerable to dementia, and ethnicity. Caucasians have a lower risk compared to black. Now, I would like to come to the prevention. Cognitive impairment, there are three overlapping terms. One is the age-related cognitive decline. It's very much a part of normal aging and remains stable for years. They do not necessarily go into the cognitive impairment or dementia. Only this is age-related. So they do not have any bad effects of dementia later on. They will continue to carry out their activities, daily living. They will be socially acceptable and so on. But there is a preclinical stage of dementia which is called mild cognitive impairment. It is a minor neurocognitive disorder. It is a stage between normal and dementia. It may or may not pass to dementia and may revert back to normality. It is now considered that about 10 to 15% of patients with mild cognitive impairment do pass into dementia within 1 year. Dementia, which is a dreadful disease, is a major neurocognitive disorder, normally irreversible, remains untreated, progressive, and results in death. So what is the key to the management? The key to the management is prevention, because all the drugs, in spite of struggling by various scientists, none of them has given a complete answer to the treatment or reversal of dementia. So we have to carry out a screening, word recall, minicog, and many other tests are available. Neurophysiological, neuropsychological tests, MMSE, and now its Hindi version are available. Lab tests to rule out reversible dementia, I've already alluded to. And of course, neuroimaging and biomarkers, a lot of advances have taken place, of course. And this is about the biomarker. You see, till very recently, it was not possible to confirm the diagnosis of Alzheimer's disease or any other dementia without taking a brain biopsy or postmortem. But this is not a favorable scenario for the diagnostic purpose. So many scientists have been struggling for last few decades to find out if there are any biomarkers in fluids or through imaging technique, and whether these biomarkers could be useful in detecting early cases of dementia, including the variety of Alzheimer's disease. And here is the summary of these biomarkers. MRI and CT scan, of course, are to be done in all indicated patients. But MRI gives not much information, except it will only say there is a abnormality in signaling, and it will indicate the presence of neurodegeneration in some areas of the brain. But PET scan is important, and SPECT is also important. Now, PET scan gives a reliable indication of the load of amyloid and tau. And if both loads are presently found to be increased in PET, they are very favorable to the diagnosis of Alzheimer's disease. If they are not present, it almost rules out the diagnosis of Alzheimer's disease. In addition, a supplementary help can be done by the deoxyglucose metabolism on PET scan again, And this hypometabolism is indicative of, again, neurodegeneration. And another scan, which is called DAT scan, this is an imaging of dopamine terminal. And if this is present, this favors the possibility of Lewy body dementia. But you would be realizing that not everybody can afford, not every facility has these in this infrastructure to carry out these things, and this is certainly notoriously not favorable for population screening. So they then resorted to CSF biomarkers. They tried to find out what is happening in the brain. Is it getting reflected into the CSF? Although CSF is also an invasive procedure, and in every small nursing home or hospitals, people are not very keen to carry out lumbar puncture. But I think very significant advances have been made as far as the CSF biomarkers are concerned. One biomarker is AB42, which is a very harmful component of amyloid beta, but by itself it is only slightly elevated, mildly elevated. But if you have another robust parameter like amyloid beta 40, and you calculate the ratio of AB42 by AB40 in the CSF, this is highly decreased, up to 50% than the control value. Phosphorylated tau in CSF is increased. Total tau is also increased, but total tau only indicates the neurodegeneration. Then there are some less important but more recent neurofilament light chain biomarker and one GFAP. And these are not very specific, so I will not go into the details. But similar markers as in CSF are being tried from the research angle in the blood. Because if these markers become sensitive enough to be detected by a simple blood prick, they would be eminently suitable for population marker. I think some successes have been carried out, but I think we still have a long way to go as far as the blood biomarkers are concerned. So we come to the steps how to prevent dementia. I divided into physical health, cognitive health, emotional and spiritual health. Then nothing great to say about physical health. This is just traditional self-health care, eating right, exercising well, maintaining weight.
Sir, you have unmuted yourself. Sir, unmute yourself, please. Sir, unmute yourself.
Okay now?
Yeah, sir, I can hear you now.
Okay. So these things will help control diabetes, blood pressure, CVD, cholesterol, all are risk factors for dementia. Just a minute. Now this is cognitive health. In other words, it's a brain challenging. You have heard the quote that use your brain, either use it or lose it. So for that, all over your life, particularly after the middle age and old age, accomplish new tasks like reading, learning music, assembling gadgets which you might have purchased from market, befriend grandchildren, play games, use dominant and non-dominant hand. That can be done in women do knitting in which both hands are employed and therefore both cerebral lobes are stimulated. Explore internet in spite of frustrating experience in the beginning where elderly people have difficulty in doing internet on computer. But once they start doing it, make a habit to do online shopping, pay bills, income, property return, and surfing long time. This will keep stimulating the brain. Fun with puzzles, gardening, including planning a garden, humor and jokes, and imbibing a new language. These cognitive health steps benefit brain cell regeneration and improve memory and cognition. This is the last slide, emotional and spiritual health. This mediates via hormones, various hormones, neurotransmitters, and they all reduce mediate through anti-inflammatory agents. These are 4 types: intrapersonal, which are applicable to both persons with dementia and also for their carers. Second is interpersonal. Third is environmental. Fourth is transcendental. The World Alzheimer Report 2022 mentions some concepts for the prevention, which I have underlined, and they are included in these 4 steps of intervention. Intrapersonal is that you can inculcate and enhance spiritual traits like forgiveness, optimism, gratitude, empathy by doing yoga, pranayama, meditation. And this is particularly important for those who are caregiving the patient. Interpersonal is by interacting with other persons, by social interaction and outdoor activity with other people during the entire life course. Those who are engaged in such habits, they have lesser chance of developing dementia in old age. Environmental, this is more applicable for non-cognitive pathways, because people with advanced dementias have lost their cognitive pathways. So for them, it is important that they are shown some side symbols of maybe of religious nature, Om, cross, or other kind of religious or other symbol. They still be able to recognize them. They will able to connect with them without using the cognitive pathway. They also like to be exposed to colors, nature, greenery, hearing, music, touching, smelling. So all these 5 senses are important for them. And lastly, transcendental, one can do meditation again and various other contemplation methods like Japanese Zen or Chinese Tai Chi or Qigong from Korea. And by this, you can connect yourself to an inner force, a cosmic force, or you may call it God or anything. But this, if carried out over a long period of time, preferably lifelong, or preferably at least when you start finding time for middle age and old age, this will stand in good stead for preventing dementia. With that, I think I will close here, and I would like to be engaged in any discussion that you may like to have with me. Thank you so much.
Thank you, sir, and many congratulations for the wonderful presentation. I am grateful for the time and effort that you took to share the detailed information about dementia. Any questions? I think, sir, participants are not much there.
Okay, no problem. It is already, I've already shared my video to the organizers, so this can be seen by people later on.
Yeah, sure, sir. So I think, sir, we have covered everything on the list. So I conclude the session here, and many thanks to you, sir, and the audience for the patient listening and attention.
Thank you, Akansha. Thank you so much. Okay, thank you.
Okay, sir. Thank you.